Check, 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 check. Hello, hello. Check.
check, 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 check. Check, check, check.
Check.
पांडे जी का भी चालू कर दो, कौन सी आईडी से है, कुछ पता है क्या? कितने बजे चालू है ये खबर में? 11 बजे।
हेलो। हाँ डॉक्टर राजेश सर, आपका ये वर्चुअल कॉन्फ्रेंस में आपका लेक्चर है। हाँ तो सर आप 10:30 तक आप लॉग इन कर लीजिएगा। स्टेशन स्टेशन 4 स्टेशन 4। ओके। आपका वर्चुअल कॉन्फ्रेंस में आपका लेक्चर है। हाँ सर आप 10:30 तक आप लॉग इन कर लीजिएगा। स्टेशन 4 स्टेशन 4।
Hello, sir. Hello. Hello.
You could put those chairs.
Hello, Dr. Shiva.
Yes, sir. Good morning.
Morning, sir. You are first speaker, ना?
क्या स्क्रीन करूँ बोल रहे हैं?
हाँ, Manoj. You share your screen.
Yes. I'm disabled. Will you please enable?
Yeah. Try again.
Thank you.
क्या बोलते उसको तुम्हारा छत्तीसगढ़ से इधर की तरफ बहुत ठंडा हो रखा है यार है ना भाई इधर की तरफ धूप
Is
है
it visible, sir?
Yes, yes. Clear.
Okay. Yeah.
हमारी दवाई कौन ले गया हमसे मरीज लेना आएगा वहाँ मरीज
स्किन खराब कर लेगा कोरोना से बचने के चक्कर में।
भाई करो बाहर बच्चे के तो इसकी कहाँ से क्या करोगे स्किन का
कोरोना का महंगा है।
स्किन तो जल्दी है।
मतलब आपके किसी भी सेशन में
मतलब ये
डॉक्टर सैयद
क्या करोगे?
ने शेयर किया था
मार
सेशन
देता है
कल
भाई ऐसे है ना कि सुबह आए और पहले एक बार हाथ में लगा तो दूं तो मर जाएगी
आप तीनों में से किसी में भी डॉक्टर सैयद ने शेयर किया था जिसका देखो क्या है। हाँ मेरे
कर दिया ना
नहीं लिस्ट कल
नहीं, लिस्ट देखो क्या है?
क्या है अरे क्या है क्या
डॉक्टर राजेश
तो बैठा हूँ हाँ सबका आ गया तो हो रहा है क्या करूँ
डॉक्टर राजेश कैन यू हियर मी
Hello, sir.
प्लीज शेयर योर स्क्रीन
Yes, sir.
अरे भैया सैयद इनके पास है डॉक्टर सैयद वही कल से बात कर रहे थे लिस्ट होगी तुम्हारे पास।
Sir, is this visible, sir?
यस यस क्लियर
लिस्ट
ओके
तो जब तक ऊपर की बात नहीं कर सकते ये वाला चेयरपर्सन है अरे चेक वगैरह भी सही है चालू है लाइव चैट है हाँ लाइव चेक करो ये सही काम हाँ स्टेशन का लोगो लगा दो ना लाल साहब
लगा रखा है
हाँ
स्टेशन हो अच्छा उसमें
आपके आगे गए देंगे
माशाल्लाह
आप प्रेजेंटर को भी फोन करोगे है
फोन रिचार्ज 408145. 8145.
Good morning, sir. Dr. Ashok.
Okay, yeah.
सर 11 o'clock स्टार्ट करेंगे और 10 फर्स्ट टू स्पीकर आ रहे हैं सर
Okay, who all are there? I can't see anybody. Participant. Okay. Webcam event, Rajesh Siva Kames. All right. Okay. Hi. Good morning.
गुड मॉर्निंग सर
So 11 o'clock is the session.
यस सर
Okay.
सर शेयरिंग कीजिए सर एक बार
डॉक्टर अशोक, आपने दूसरे लिंक से भी ज्वाइन किया है, दूसरे डिवाइस से? डॉक्टर अशोक
Yeah, yeah.
सर, उसका आपको म्यूट कर रखना पड़ेगा।
Sorry.
दूसरा लिंक दूसरे डिवाइस से भी आपने लॉगिन किया है?
Okay. I will. Yeah, I'll just see if which one is better.
फर्स्ट वन इज बेटर।
Okay, I'll just put up my computer. I think we are happy with the mobile. Okay, that's fine.
हेलो, क्लियर सर? हेलो डॉक्टर अशोक, कैन यू हियर मी?
Yeah, yeah.
ओके,
सर 1 मिनट में शेयरिंग देता आपको सर। जी सर। जी सर।
सर डॉक्टर शिवा इज फर्स्ट स्पीकर। डॉक्टर शिवा,
Yes, sir. Good morning, sir.
गुड मॉर्निंग सर, प्लीज शेयर योर स्क्रीन।
यस सर। सर फुल सिलेक्ट सर। हेलो, फुल स्क्रीन सर।
Is my screen visible, sir?
यस यस।
Yes, yes.
लॉगिन कर लिया है सर, किस सेशन पे था? सेशन 10।
मुझे सर देखिए राइट जहाँ पे मैंने प्रेस करा नीचे कोने में मेरे फुल स्क्रीन का ऑप्शन है राइट साइड में नीचे देखिए सर नीचे हाँ जहाँ पे मैंने प्रेस है ना प्लस मैंने सारा पार कर लिया
डिलीट
और जहाँ पे आपके टू लिखा हुआ है
आपने सर स्टेशन 1 पे
नंबर आ रहा है 2 लिखा हुआ है नीचे देखिए yes sir next lesson yes
Yes, sure. You can start.
Yes, sir. Good morning, everyone. I am Dr. Shiva Kamesh, a final year resident of general surgery from Osmania Hospital, Hyderabad. I'm here to present a case series of small bowel volvulus today. So as we all know, a volvulus is a clinical entity wherein there is a greater than 180-degree twist in the hollow organ about its mesentery that leads to luminal obstruction, vascular compromise, and eventually intestinal ischemia and gangrene. As far as small bowel volvulus is concerned, it's more commonly seen in children than in adults. And however, the true incidence of this condition is not yet reported because there are lack of population-based studies to estimate the incidence. Estimated incidence with case series across the world show drastically how it is more common in the Central African and the Southeast Asian countries such as India and Nepal. My aim of the study is to study the 3 cases that presented to our hospital over the past 3 years. And the objectives being to describe their clinical presentation, to identify the difficulties in the preoperative diagnosis, and to elucidate what were the intraoperative details and the perioperative course of these cases. So my first patient was a 49-year-old gentleman with chief complaints of pain abdomen for 4 days and diarrhea and vomitings for 6 days. He also had a history of melena of 1 to 2 episodes, and there are no other complaints. He had no history of similar complaints in the past, and he being a known diabetic for the past 15 years, also underwent an open appendectomy 15 years ago. On examination, he was febrile with tachycardia and although a normal blood pressure. His abdomen was distended with diffuse tenderness and guarding, and rectal examination was essentially normal. Imaging suggested evidence of dilated edematous small bowel loops with a maximum diameter of 4.2 centimeters. with probable suspicion of closed loop obstruction and moderate free fluid. So given this examination, our probable diagnosis was mesenteric ischemia, and the patient was taken up for emergency laparotomy after adequate resuscitation. Intraoperatively, this is what we found. There was a thick vascular adhesion between the sigmoid and the cecum, around which the distal ileal loops had undergone a 2.5 turned volvulus, 2.5 turns of volvulus, resulting in ischemia and gangrene of that distal ileum. My second patient was a 47-year-old lady with chief complaints of pain, abdomen, vomitings, distension, and obstipation for 4 days, the classic tetrad of an intestinal obstruction. And she also interestingly gave history of similar complaints 1 year back, wherein she had underwent emergency surgery. And on referring to her operative notes, it was a sigmoid volvulus, in fact, for which resection and anastomosis was done. She's also happened to be a known case of pulmonary TB who finished her ATT 5 years back. On examination, she had tachycardia, she was afebrile with a blood pressure of 100/70, and per abdomen, there was diffuse guarding tenderness and a distended abdomen. Rectal examination was collapsed. So our clinical diagnosis of intestinal obstruction was apparent, with the imaging as well concordant with the same. So the patient was resuscitated, taken up for laparotomy, and intraoperatively, these were the findings. Similar to the first case, there was volvulus of the distal ileum around an adhesion. This time it was the adhesion band was present between the distal ileum and the raw area that was created near the rectosigmoid junction due to the previous surgery. As after the release of the adhesion, you can see the 180-degree, more than 180-degree turn of the small bowel mesentery leading to gangrene. My third patient was a 60-year-old gentleman who presented with complaints of pain, abdomen, vomitings, distension, and obstipation from 4 days. Although here he had no complaints of, no similar complaints in the past, he had no known comorbid illnesses and no previous abdominal surgeries. He was afebrile, vitals were pretty much stable. Per abdomen, however, was distended with diffuse tenderness and guarding. Rectal examination was normal. Imaging gave evidence of proximal small bowel loops of diameter 4.2 centimeters with multiple enlarged lymph nodes. They weren't able to comment on any transition point or a clear-cut obstruction. But given the examination history and examination findings, we proceeded with our provisional diagnosis of small bowel obstruction. And intraoperatively, to our surprise, there was a volvulus, a small bowel volvulus with a viable dilated ileal loop, as we can see, and a collapsed ileum distal to this volvulus. So here, only simple detorsion was done in the clockwise direction and the obstruction was relieved. Whereas for the first two cases where there was gangrenous ileum, resection was done and a double barrel ileostomy was constituted for both the cases. The post-operative course for all these three patients was uneventful and they were discharged and are on follow-up. So small bowel volvulus, basically as etiology-wise, it is primary or secondary. Primary being no evidence of anatomical factors and no identifiable predisposing factors. The etiology of this is poorly understood. However, many associations have been described. Like a review from Spain here noted association of small bowel volvulus with diabetes, that is diabetic neuropathy and its altered small bowel motility leading to increased incidence. And a study from Uganda showed how a tribe that consumed large amounts of Congo beer, which is rich in serotonin, to have increased incidence of primary small bowel volvulus. And studies from Afghanistan showed how during the months of Ramzan, when Muslims ingested large quantities after a prolonged period of fasting, had a 9 to 10-fold increase in this condition. So postulated theories were long mobile mesentery, narrow insertion, a lack of mesenteric fat, akin to the sigmoid volvulus that we are
Ostona.
Secondary small bowel volvulus, however, has a long list of causes, among which post-operative adhesions are the most common. And there are many rare case reports of Meckel's diverticulum, malrotation, ascariasis, etc., leading to this condition. The diagnosis clinically is there are no findings. The findings are non-specific, and around 90% patients present with acute intestinal obstruction as it can be expected. And plain X-ray, usually the findings are non-specific. And CECT abdomen, if performed during an emergency, has a sensitivity of 27 to 64% in demonstrating the Whirl sign, which is diagnostic of small bowel volvulus. And if ischemia sets in, the radiological findings are very much apparent. So treatment, when there is gangrene, resection and anastomosis are mostly done in all the case series that have been reported. And if there's a viable bowel, simple detorsion is done in most cases. However, there are few case series and studies that show recurrence of about 4 to 5% in such cases where simple detorsion is done. But however, there are no prospective studies to address this issue of recurrence, and some even have procedures like intestinopexy done to such cases where there is viable bowel. So, although uncommon, I would like to conclude that small bowel volvulus is a very relevant cause of small bowel obstruction, and this should be kept in mind because there is increased incidence of this condition in our country. And an emergency surgical intervention like a resection or with stoma or anastomosis would be required because this diagnosis is often delayed and even the patients present to us very late. And only very few cases escape this major procedure by undergoing just simple detorsion. And further studies are required to comment on the recurrence after detortion alone. These are my references. And thank you, one and all.
Thank you. I think Ashok would like to speak. I think you need to unmute.
So Shiva, you presented a case of 3 cases of intestinal volvulus in adult. All right.
Yes,
Your third case had some lymph node findings. What happened to that? Was there any kind
yes,
of
no, sir. The
biopsy done?
nodes were about 0.5 to 0.6
Okay.
centimeters.
Okay.
So we had not taken any biopsies, sir.
So 2 of your cases had an adhesions is the cause, post-operative cause, and third one was what was the cause?
There was
Just
no,
primary.
yes, sir. That was a
Primary.
primary small bowel volvulus.
Okay, okay. Yeah, you're right. The literature are lacking about this exact cause, why it happens like that.
Yes, sir.
Further studies are required. It's rare episodes and occurrence, but it is very common among post-operative patients. There's no doubt
Yes,
about
sir.
it.
Definitely.
And yeah, and some large series should come up in coming years. No problem.
Yes, sir. The thing is that there are many case reports of this condition in our country as well, but there are
Yeah.
proper studies to show exactly what is to be done when there is a viable bowel found in intraop. Should we just detort bowel,
So,
or is there any procedure to be done?
what is the take-home message you would like to give through this paper?
First of all, it is important to recognize that this condition is not as rare as it was thought to be before. And there is requirement of further reporting of such cases and a proper consensus to be drawn as to what is to be done in a case where there is volvulus without any cause and the exact management is detorsion alone sufficient or any other extra procedure is to be done in such cases.
So the early CT and early exploration. All right.
Early CT, early exploration, yes, sir, would definitely help the patient in reducing morbidity and mortality.
Okay. Thank you very much.
Thank you.
Other faculties wants to ask questions?
I have two questions. One is, was it diagnosed preoperatively?
No,
All
sir.
these patients?
No, sir. The
So
first,
on the table.
on the table, sir. Yes.
So were all the 4 patients had a CT scan?
Preoperatively, yes, sir. In the emergency, it was
So what was an intention to do a CT scan?
sir, to diagnose for the first patient actually presented with pain, abdomen, and diarrhea, sir. But he had a clinical examination findings of acute abdomen. So, in suspicion of a perforation or a mesenteric ischemia, we had done a CT in that case, sir. The second one was an obstruction, sir, clinically. So, to establish the diagnosis and to note any transition point, so for that CT was done in that patient. Here, third one, sir, the clinical history and examination were suggestive of obstruction, but imaging itself was.
So what do you suggest? How do you suggest? What do you suggest that how to diagnose preoperatively that there is small bowel volvulus?
So, sir, preoperatively, the only diagnosis, the only test that could probably give a diagnosis of small bowel volvulus is CECT, sir. So, if that is widely available and if the radiologist is able to demonstrate the Whorl sign, that is the SMV anterior to the SMA,
So most of the times it's an on-table diagnosis.
on-table diagnosis, sir. Yes.
Okay.
That is,
Thank you.
it would be already gangrenous and resections and anastomosis are usually done. So,
Okay, thank you.
yes, thank you, sir.
Next, Dr. Sudha Reddy. Can you share screen, sir? Yes. Can next, sir? Next slide, sir.
Good morning, sir.
Next slide, share your screen.
सर आप अपने लैपटॉप के माइक से ही बात कर लीजिए सर, हेडफोन हटा दीजिए। ओके, साउंड आ रही है सर?
Hello.
Yeah,
Hello. Hi, good morning, sir. Can you hear me?
yeah, can.
Okay. I'll start, sir.
Yeah, please go ahead.
Good morning. My name is Sudha Reddy and I'm from KMC Manipal. Today I'll be presenting my paper, which is titled Minimally Invasive versus Open Esophagectomy, a comparison of surgical outcomes in a tertiary care center. So, esophageal cancer is the eighth most common cancer and the sixth most common cause of cancer-related mortality worldwide. Recent changes in treatment guidelines reflect the changes in multimodality approach to treatment. With the rise of minimally invasive surgical techniques, their use in the management of esophageal cancer is also rapidly gaining popularity. So, the aims and objectives of this study is to compare surgical outcomes of open versus minimally invasive esophagectomies in a single center in India. So this is a single center retrospective study from 2015 to 2019 of 57 patients undergoing an esophagectomy for esophageal cancer. The open group included patients who underwent the transhiatal technique, Ivor-Lewis technique, and McEwen's esophagectomy. The minimally invasive technique included thoracoscopic assisted or VATS and the thoracoscopic plus laparoscopic techniques. Data collection was done according to a performer sheet and was analyzed using SPSS software version 23. So this first pie chart, it compares the treatment modalities that both groups of patients underwent. The gray area shows the percentage of patients that received only upfront surgery. Orange area is for patients who underwent neoadjuvant therapy and then surgery. The light brown area is for patients who received adjuvant therapy post surgery, and the dark brown area is patients who underwent NACT followed by surgery and adjuvant therapy. So this table shows tabulates the type of surgeries that the patients have underwent. Overall, there were 44 patients in the open technique and 13 patients who underwent minimally invasive surgeries. In this others group, 3 patients of these have undergone an Ivor-Lewis technique along with a gastrectomy, and 1 patient has undergone a VATS plus a transhiatal esophagectomy plus a coloplasty. So this table shows the rates of surgical complications that we have taken into consideration in our study and the rates of occurrence in the open and minimally invasive groups. The complications that we have considered are surgical site infection, pneumonia, anastomotic leak, sepsis, and cardiac complications. So outcomes, again, this table shows the outcomes in the open and minimally invasive group. In the open group, 21 patients were discharged without any complications. 15 patients were discharged with complications. 6 patients had expired and 2 patients were discharged against medical advice. In the minimally invasive group, 5 patients were discharged without complications. 5 patients were discharged with having developed some complication. 3 patients expired and 1 patient was discharged against medical advice. So in the postoperative period, the outcomes that we have taken into consideration are stricture, recurrence, and voice change. 6 patients developed stricture in the open group and 3 in the minimally invasive group. Recurrences, that is local, distant, or local and distant recurrences. 15 patients developed recurrence in the open group and 3 patients developed them in the minimally invasive group. Voice change was seen in 9 patients, and all of these patients had undergone an open technique. So factors affecting mortality, the overall mortality rate in our study was 15.7%. 13% of these patients, for the open technique, the mortality rate was 13%, and for the minimally invasive technique, it was 23%. There was no statistically significant difference in the mortality rates due to the type of surgery. However, in the total study population, patients who were expired were more likely to have had a cardiac complication. This table shows the factors affecting the rates of recurrence along with the type of surgery that the patient underwent. So in the study, we found that 2 surgical techniques had higher rates of recurrence. One was a McEwen's esophagectomy, and another was patients who underwent a VATS plus a transhiatal esophagectomy. Both these techniques, one in the open group and one in the minimally invasive group, were found to have higher rates of recurrence in the postoperative period. We also found that patients who received neoadjuvant therapy after surgery have also had statistically significant rates of recurrence. So, discussion, the average hospital stay was found to be lower in the minimally invasive group. In the open technique, the average stay was 22.7 days, and in the minimally invasive group, it was 13.8 days. The overall complication rates were comparable between the two groups, 34% in the open group and 39% in the minimally invasive group. The overall mortality rate was 15.7% in the opening, with open techniques having a mortality rate of 13, and minimal invasive groups had a mortality of 23%. However, this higher observed rate of mortalities in the MIE group, it can be attributed to the fact that there were less number of cases itself in the MIE group. In our study population, we found a statistically significant relationship between mortality and developing cardiac complications in the post-operative period. The cardiac complications that we took into consideration were most commonly seen were arrhythmias and myocardial infarction. A multivariate analysis was done using logistic regression, and cardiac complications were found to be an independent risk factor for mortality. In our study population, 20 out of the 57 patients had in some form of recurrence, either local, distance, or local and distant metastasis. Local recurrence was seen in 13 patients, and distant metastatic recurrence was seen in 17 patients. Recurrence rates were higher in patients receiving adjuvant therapy post-surgery, but this could be attributed to the fact that the patients are considered for adjuvant therapy because they have high-risk factors, such as lymphovascular invasion, neural involvement. They have a poorly differentiated tumor, multiple positive lymph nodes on histopathology, or inadequate margins. Recurrence rates were higher in patients who had undergone an open technique. So the patients who had undergone an open technique, their recurrence rate was 34.1, while the minimally invasive group had a recurrence rate of 23.1. In our study, we found a statistically significant relationship between recurrence rates and certain surgical techniques, that is McEwen's esophagectomy and patients who underwent a VATS plus a transhiatal technique. In conclusion, the average hospital stay was found to be shorter in minimally invasive techniques. The mortality rates and overall complication rates were comparable between the two groups. But limitations of this study were that the sample size was very small. The changes in the treatment recommendations over the study period may have affected the outcome, and the minimally invasive techniques were only performed in the later study part of the study period, and the long-term mortality rate could not be assessed. These are my references. Thank you.
Okay, so this is Dr. Puranik.
Yes, sir.
I just wanted to know, did you consider the patient factors also, especially their comorbidities and the nutritional status and the ERAs done on them,
Yes, sir.
affecting the mortality?
Yes, sir. Actually, we had not found a correlation between patients having morbidities, between the type of comorbidity the patient had and their outcomes. That could have probably been because of the small sample size. I think only 4 patients were diabetic and 2 patients were IHD. So,
Okay. My second question is whether anybody required thoracotomy?
uh, in a sense, as part of the surgical procedure, yes, sir, but not separately. No, they did not.
Okay. Thank you.
I just would like to know why the recurrence rate is more in open group than minimal invasive group.
Actually, sir, we were looking into that. It could be because the majority of the open surgeries that were undergone were the transital surgery. So it could be because it's a blind procedure. Adequate lymph node clearance was not achieved in the thoracic compartment. Could be correlated to that.
And what is the duration of the follow-up in all these cases?
Follow-up was for the earlier cases, sir. We had taken them until almost 2 years. For the latest part of the studies, it is until they were following up with our hospital.
2 years. Longest is 2 years. And how many had an gastroesophageal junction tumors in your study? You not mentioned how many had a middle third of the esophagus malignancy or lower third of the esophagus malignancy.
Yes, sir.
So that you not mentioned.
Yes, sir.
I feel that's a very important thing needs to be mentioned.
Okay, sir. We do have that data, sir. The lower esophageal junction had lower third of the esophagus were the highest that we had seen. I think 13 patients had that, and GE junction tumors were 7, sir, out of the total study population.
Okay, thank you.
Thank you, sir.
So let's move on to next paper.
Next is Dr. Rajesh. Dr. Rajesh,
Yes, sir.
please share your screen.
Yes, sir. Sir, is my screen visible, sir?
Yes, yes, yes.
Yeah.
This is start.
Sir, good morning, everyone, sir. Sir, I'm Dr. Rajesh. I'm a final year postgraduate from Tirunelveli Medical College, and my guide is Professor Dr. Jailal, sir. So my paper presentation topic is appendicitis inflammatory response score. So introduction, acute appendicitis is the most common cause of acute abdomen, and it is the most common surgical emergency worldwide. Approximately 7% population will be affected by this condition during lifetime. Appendicitis, defined as inflammation of the appendix, was first coined by Reginald Fitz from Boston and identified as the most common cause of right lower quadrant pain. Appendicectomy was first performed by Amayan during hernia surgery. Even now, appendicitis still remains as one of the most common emergency and poses a difficulty in accurate diagnosis, as the symptoms are mimicking like other pathologies. The development of appendicitis inflammatory response score may contribute to diagnosis, associating easy clinical criteria and two laboratory tests. Now, what we commonly follow is Alvarado score, which uses tenderness, nausea, vomiting, temperature, and rebound tenderness, and leukocytosis, and shift of neutrophils to the left. So these are some of the intra pictures. First picture is showing appendicitis perforated at the tip, and we are clamping the mesoappendix, and we are seeing the base. And second one is the clean appendicitis. It was thickened, inflamed, and mesoappendix was clamped, ligated, and we are clamping at the base. So what is my aim of my study? So and objectives. So to evaluate the score, appendicitis inflammatory response score as a diagnostic tool and prediction of severity of acute appendicitis. So study places Tirunelveli Medical College and Hospital, and the sample size of 100 cases, and it's a descriptive type of study, and for purpose is stamping. My inclusion criteria includes age more than 12 years, and exclusion criteria patients those who are not willing for my study, and methodologies after getting ethical clearance and informed written consent in the native language of the patient. Patient will be entered in questionnaires. Data entry analysis will be entered using number software, and statistics will be derived using SPS software version 23. So this is the Alvarado score and appendicitis inflammatory response score. First one is the Alvarado score: migratory right lower quadrant pain, anorexia, nausea, vomiting, tenderness, and rebound tenderness. So raised temperature and leukocytosis and shift of neutrophils to the left, where maximum number of scores was given to leukocytosis and tenderness. In coming to appendicitis inflammatory response score, the same criteria will apply. Extra are taken in account as C-reactive protein, one of the most important predictor of severity of the acute appendicitis. That's why appendicitis inflammatory response score overtakes Alvarado score in overall predicting the severity and positive predictive value in case of an acute appendicitis. Suppose if the score of Alvarado is 0 to 4, it's not likely an appendicitis. We should think of other causes of right lower quadrant pain, male, female, children, elderly. So if it is 5 to 6, it is equivocal. Next thing, we have to go for CT abdomen. That is contrast tendon, CT abdomen and pelvis. So second and 7 or more than 7 is appendicitis. We have to go for surgery. And coming to appendicitis inflammatory response score, 0 to 4 is low probability, but appendicitis can be there. So 5 to 8 is intermediate group, and 9 to 12 is high probability. What I'm going to prove in my study is, in case of Alvarado score 8 and appendicitis inflammatory response score 8. So in taken into account negative appendicectomy when compared to appendicitis inflammatory score in Alvarado score, negative appendicectomy rate is very low in case of my study, that is appendicitis inflammatory response score, whereas Alvarado score can have negative appendicectomies also. These are the result. Male and female distribution. Overall, male predominance is more when compared with the female, and age-wise distribution, 13 to 30 years will be having more number of appendicitis when compared with 31 to 60. When more than 60 age factor coming, there is more chance of perforation, appendicular abscess, appendicular mass. That is more in terms of complications arises. In coming to presentation, most of my patients presented with vomiting and abdominal pain. First is vomiting, followed by abdominal pain, followed by nausea, anorexia, then guarding and temperature. This is the bar diagram. This is the pie diagram showing that appendicitis inflammatory response score 8 and Alvarado score 8. It shows that the clearly negative appendicectomy rate in appendicitis inflammatory score is 0, whereas 40% in case of an Alvarado score. So appendicitis inflammatory response score 4 and Alvarado score. In appendicitis inflammatory response score 4, there is a 60% chance of appendicectomy and 40% chance of negative appendicectomy. In case of Alvarado score, 80% chance of negative appendicectomy. Discussion. Acute appendicitis is a common surgical emergency with an incidence of 1.17 per 1,000 population and a lifetime risk of 8.6% in men and 6.7% in women, with the highest incidence in the adolescent age. The widely applied scoring system was Alvarado scoring, which was validated in many studies globally with few limitations and drawbacks. Modification of Alvarado scoring system was developed. Hence, to overcome the limitations of Alvarado scoring system, appendicitis inflammatory response score was developed in Sweden in 2008. Based on prospectively collected data of variables with independent prognostic value. This scoring system, because of its simple design and application, could estimate the probability of appendicitis and acts as a supportive and aid in decision-making process of acute appendicitis. Conclusion. Appendicitis inflammatory response scoring performed equally well and in chances more with the Alvarado system, preventing unnecessary negative appendicectomies. This scoring system also prevents unnecessary and costly radiological investigations like CECD abdomen, was the gold standard investigation of choice for acute appendicitis, thereby reducing the financial burden to the patients. Here's my references. And appendicitis is a pocket-sized time bomb. So thank you.
Okay, Rajesh, good study, but I would like to know why you chose a Alvarado score over the Mantel's scoring system.
Mantle scoring system 7 or more is highly improbable of acute appendicitis. Sir. If it is 5 to 6, we have to go for radiological investigations like CECD abdomen. Sir. In case of if it is 4, we have to think of other lower quadrant pain.
So you did not mention out of your this all 100 cases, how many underwent CT scan?
Sir, if it is Alvarado score 4 or appendicitis inflammatory score, definitely I will go for CT. Sir.
Did your all these 100 patients were analyzed with CT findings?
No, sir.
So CT was not done in all these 100 cases?
No, sir. 46% underwent CT. Rest of the person, I don't take CT for CT.
So you admit that 46% patient still underwent CT scan?
Yes, sir. Yes, sir.
Okay, so negative it can help it. Okay.
Negative rate for Alvarado, appendicitis inflammatory response score is 40%. Sir. That's why I took CT for the negative patients for not missing any diagnosis in emergency situations. Sir.
Okay. My last question is only doing CRP in case of appendicitis is going to make a difference?
Sir, CRP is a diagnostic tool marker for acute appendicitis recently, sir. CRP value 10 to 49 is low probability, and greater than 49, there is a high probability, not only for acute appendicitis, it is taken as a marker of acute inflammation, sir.
And out of this 100 cases, how many underwent operation?
Sir, 97% underwent operation, sir.
And 3 were not operated? No, sir.
No, sir. We did conservative management for the patients, sir.
So, okay. So the clinical suspicion of appendicitis turned out to be 97%, you would like to say?
Sir, I didn't get you the...
Yeah, like out of 100 patients, 100 appendicitis patients suspected by a clinician and put up to the study, 97 came to be true on a clinical basis. Yes, and sir. Simple investigations. Okay, all right. Thank you.
Sir. Thank you, sir.
I just want to know why a CT scan should be done in appendicitis, and how many negative laparotomies or appendicectomy was done if there are clinical symptoms. How does your investigations are going to really useful?
Sir, appendicitis is a clinical diagnosis. First, I will examine the patient history, then examination, then followed by the blood investigation, sir. So WBC I will take into account, sir. Routinely we are doing WBC. Then recently we are taking CRP as a positive predictive value.
CRP is not a diagnostic tool for any. It can raise in any inflammatory lesions. It's not a diagnostic tool.
Okay, sir.
For your kind information.
Okay, sir.
You cannot make a decision based on a CRP.
Okay, I will substantiate my diagnosis. Okay, sir. Yes, sir.
Okay.
Yes, sir.
Then how did you rule out an appendicitis based on your scoring system?
Yes, sir. Sir, if appendicitis inflammatory response score will be of 8 or more than 8, I will definitely go for acute appendicitis.
So in 100 cases, how many patients you have saved from appendectomy?
Sir, I did 97 cases appendectomy and 3% I put as conservative only, sir.
That's very low. Very, very low. So it's as good as clinical diagnosis of appendicitis. I don't
Okay,
need.
can I ask another question?
Yes, sir.
Yeah, in the era of antibiotics, now it has been publication have come and the experienced clinician have published that the cases which are doesn't have a perforation peritonitis or perforation of appendix, they can be managed conservatively just by giving antibiotics.
Sir, in case of perforation, we have to.
Only the perforation requires an operation. Rest
Yes,
of the
sir.
cases have got a equal kind of recovery rate, whether you operate, whether you just give antibiotics for 3 to 5 days. So in that contrast, in that context, what your study is compared, it will be a kind of lot of unnecessary operations just based on this data. How do you defend yourself?
Sir, since I'm a surgeon, need to relieve the pain immediately, so I have to settle the sepsis immediately. So I will take the patient for surgery. If score is more,
no, my question is very simple. That is, still you would like to operate, or you would like to treat them by antibiotics? We need to change our practice system now. What you have to say? How you have to defend yourself? You want to operate more cases? You want to operate? You want to treat by antibiotics most of the cases?
Sir, I will do surgery for the patient, sir. Lap appendicectomy, I will do, sir.
Just because it is your bread and butter, just because it has been going for ages.
No, sir. If there is a high chance of recurrence in the next 1 year, or in case if it is if my appendicitis biopsy will come as malignancy for the incidence of 0.6 to 1%, I have to do next further surgery for the patient, sir. So
your argument is wrong.
Yes.
And instead of doing all the investigations, you can do laparoscopy. That would have been a best investigation.
Yes, sir.
So why you want to do all those things, CT scan and all those things, it's not necessary. And as Dr. Ashok rightly said, that antibiotics, yes, and the recurrent appendicitis is much less than before. Okay, anyhow, time up. Congratulations to Dr. Rajesh. Thank you very much. We'll go to the next paper.
So next point is next 3 speakers not here.
Pardon?
Next 3 speakers not here.
Okay. That's all? Over?
Yeah, that's all.
Okay. Thank you. Thank you, Dr. C.R.K. Prasad, for giving us opportunity to chair the session.
Nice meeting you, sir. Nice knowing you. I'm based in Jodhpur, AIMS Jodhpur HOD surgery, sir.
Oh, thank you. I'm Dr. Birappa from Nizam Institute of Medical Sciences.
Nice knowing you, sir.
Thank you, sir. Thank you very much.
Okay, so yeah, I'll forward my marks to by email to the organizers.
Okay, thank you.
We have plenty of time. Next session is going to start at 12 o'clock, if I'm not wrong.
Yes, sir.
Okay.
I'm also there in that 12 to 12:15.
No, I got a lot of other works to do. It's exam time over here, so yeah. I'm quite busy.
Sure.
Okay.
I'll sign off.
Why you are still wearing mask, sir? You must be alone in the room, so.
I'm alone, but today, next is my OP, so people are, knocking the door continuously.
Okay. So all this 7-8 months, I logged myself to my academic building and I do go to OPD and take round, but most of the time I'm confined to the kind of my own chamber. So, so I'm
No,
free from all this
next to
mask.
my room is an OPD, and
Okay.
third floor we have an operation theater. A theater is going on, and a lot of patients are becoming positive, either
Okay.
pre-operatively or post-operatively.
Okay.
So we are really very scared
I
situation
know,
here.
sir. You are a very busy center. I understand.
Yeah.
But this is the high time you should shift and ask for a kind of a totally secluded room in some top floor where people don't have access.
Getting this room itself is a big difficult.
Yeah, I had my lot of trainees got infected because all the surgery people were rotated to COVID wards and management of ventilated patients.
Yeah, true.
So all of my trainee one by one fell sick. They were detected, and then all those observation, a little bit of symptomatic treatment, everybody required.
Yeah.
Yeah.
Our anesthetist felt that our residents are managing very well our post-operative patients, and when they are on ventilator, so they have put them in a respiratory intensive care unit for COVID patients.
I don't know the other centers who lost their young doctors, probably because of I think the drug abuse or overprescription, like combination of chloroquine and azithromycin and other drugs.
Probable, yes,
Cause
probable.
I think otherwise all young doctors who are managing, not taking any treatment, had done well. They had no problem. They failed for kind of a mild fever and general asthenia and weakness, and they came out in once they are isolated. And
I think before starting dexamethasone, I think mortality was there because they are not sure what to give. Some of them got HCQ, some of them got remdesivir, some of them got ivermectin. Once dexamethasone started, it changed the really.
So the lesson learned is all the people 50 years plus should hide, and young people should be pushed forward for the war.
Yeah, true.
Exactly.
I'm real. That's why my den.
So I think another 3-4 months we should take care of ourselves, and
hope by end of this month we get the Pfizer vaccine. We are just eagerly looking for that. So
I know, but it is still poorly studied. We don't know what is going to be the complication and all that. Everybody is apprehensive, but everybody will
let's
get
have
it.
One shot. Let's have one shot.
Exactly.
And we are the guinea pigs. We are the guinea pigs because they say warriors, COVID warriors will get fast. They know that they can't take it.
Okay. There is a lot of kind of apprehension about it. Yes. We'll be getting 2 shots rather, not 1 shot. I think it's 2 shots.
At least one shot, one mask out. So we are wearing 2 masks.
Okay.
1 shot, 1 mask out. 2 shots, 2 masks out.
How big is your department, sir? How many PG students?
I have mine is a surgical gastro. I'm heading the department of surgical gastro, and we are 6 faculty, and I have nine residents. So and we have a 36 bedded general ward and 15 bedded ICU, and 6 paying rooms. So that's our bed strength, and daily we have 2 operation tables.
Okay, sir.
12 tables.
And during COVID times, you were running all emergencies?
No. We had stopped for 2 months, 2-3 months.
Okay.
Then slowly we started small cases, and then for the last 1 month, we are doing all major cases.
Okay. And who is your director, sir?
Dr. Manohar is a physician.
Okay.
So he's a director. So
okay. You are next in the line, sir. Okay.
I'm not in the next in the line. So there are a lot of. It's a political post.
It's a political post. Okay.
It's a political post.
So, just pulling your leg. Okay.
Yeah. Only heavyweights will get, and those who have a big purse also can get.
No, I think no, sir. Every whosoever becomes senior person, I think it should be gunning for the post. Okay, I want to become director like that.
Yeah. That's what we have been crying for. That institution for so long time. The senior most guy should get the director post. So,
Yeah.
but
So I'm just sowing the seeds, making you ambitious. You should also go.
yeah, we've been raising a voice, but
Yeah.
chairman,
Okay.
chief minister is the chairman, is the president
Okay.
of our university. So
Okay.
his decision is final.
Okay. Okay.
And there are a
Okay.
lot of permutations, combinations, local fellow, non-local fellow. So
Okay.
Telangana, non-Telangana, all these kind of things also are
I
there.
understand, sir. I understand.
So,
North South.
so,
Nice knowing you, sir. Hopefully, we'll meet very soon.
yeah, sure. Thank you, Dr. Ashok. Nice
Very good.
talking to you. Thank you
Nice
very
meeting you,
much.
sir. Bye bye.
Good afternoon, sir. Rajput sir, good afternoon. GD Yadav sir, good afternoon.
Good afternoon, Dr. Gyan. How are you?
अच्छे हैं सर.
Live from OT.
हाँ OT में है.
ये ऐसा ही है. अभी 1 घंटे बाद फिर ऑपरेट करने चले जाओगे हैं?
हाँ वो रेजिंग लोग कर रहे हैं सर, बस उसी में हो जाएंगे.
और सब ठीक है, बढ़िया?
सब बढ़िया सर, सब बढ़िया.
अरे चलो, गेट टुगेदर हो गया.
तो इसमें क्या करना है सर? कितने पैसे वो हैं पार्टिसिपेंट? 4 हैं, 6 हैं?
6 है, 6 पार्टिसिपेंट्स.
हाँ, इसमें किस किस चीज में नंबर देना है सर?
6 है, 50 मार्क्स का है. हाँ, हेलो.
हाँ सर.
50 मार्क्स का है, 10 मार्क्स ओरिजिनलिटी.
कैन यू हियर मी? हेलो
हाँ राजपूत सर, नमस्कार सर.
सर, नमस्कार. मैं
हेलो
से बोल रहा हूँ सर.
हेलो
12:15 पे सर स्टार्ट करेंगे.
यस.
सर अभी तक 3 पेपर्स आए हैं मेरे पास.
अच्छा, बस 3 ही आए हैं?
जी, फर्स्ट एंड थर्ड एंड लास्ट वन.
फर्स्ट, थर्ड एंड लास्ट.
देखते हैं, और अगर बीच में ज्वाइन करेंगे तो फिर मैं आपको बता दूँ इन्फॉर्मेशन.
ठीक है.
7 मिनट्स का लेक्चर है, 2 मिनट्स क्वेश्चन आंसर.
ठीक है सर. यादव बॉस पूछेंगे सबसे ज्यादा तो.
अरे भैया,
प्रोफेसर एंड हेड.
पूछना. एक्सपर्ट हो तुम, कितनी कॉन्फ्रेंसेस जज बन चुके हो.
अरे सर,
इंटरनेशनल आदमी हो.
आशीर्वाद है सर.
हम लोग तो छोटे छोटे कॉलेज के हैं.
अरे नहीं सर, राजा तो राजा होता है सर, चाहे नेपाल का हो चाहे बांग्लादेश हो. प्रधानमंत्री जाएगा तो राजा से ही मिलेगा सर.
डॉक्टर पंडित. हेलो डॉक्टर पंडित.
SGPGI में पूरा स्टार्ट हो गई ओटी, डॉक्टर ज्ञान?
हाँ सर, ओटी तो चल रही है हम लोग की, शुरू से ही चल रही. बस खाली ये था कि पहले हाफ वो 30% चल रही थी, अभी 50% चल रही है.
अच्छा अच्छा.
डॉक्टर पंडित.
कानपुर आओ किसी दिन.
हाँ सर.
सर प्लीज शेयर योर स्क्रीन.
आ रहे सर.
हेलो डॉक्टर ज्ञान. हेलो
हेलो ज्ञान.
हेलो सर.
हाँ डॉक्टर पंडित, आप अपना पीपीटी शेयर कीजिए.
Sorry sir, I can't hear you sir. Am I audible?
Yes, yes.
हेलो
Dr. Pandit is the first speaker. Good morning, sir. Hi, sir. Sir, total are 6 papers, but 3 presenter is available. Okay, sir. First presenter. Sir, start करें.
I can't hear you.
No, I Excel sheet, but I send the first presenter will come. Okay, sir. Okay, sir. Dr. Nagesri, please start the session. Vinita Kumari, please not join. And Dr. Muhammad Rafi is the second paper. He is also not join.
Hello.
हेलो
सर स्टार्ट करें सर. डॉक्टर GD यादव, डॉक्टर ज्ञान.
हाँ, यस यस, ऑफ कोर्स.
Okay, Pandeshwari.
Shall I start, sir?
Yes, yes.
Yes, you can start.
Okay.
मीटिंग आईडी तेरे को व्हाट्सएप कर रखी, चेक कर ले, खोल उसको.
Carcinoma stomach. To introduce, the gastric cancer is the fourth leading cause of the death in the world, with the incidence of nearly 1 million cases. It is the second leading cause of cancer death in the worldwide.
Hello. Hello.
Please continue your
Although
voice.
early diagnosis and
Yes, you continue. Continue.
gastric cancer. Hello.
Hello. Here.
डॉक्टर पंडित, आपका नेटवर्क का इशू है.
The voice is not audible.
Sorry, sir. It's breaking. Hello.
Yeah. Yes.
Is it audible, sir?
Now audible.
Hello.
Hello, Dr. Pandish, you are audible now, and you should continue.
Yes. Yes, sir.
Yes.
The carcinoma stomach, to study the food intake habits and to study physiological of the patient and their contribution to the prognosis of the stomach, and study the anatomical location of the tumor. The physiological patterns of the carcinoma stomach, and they are 18 to September 2020 has been included in patient who are diagnosed as a carcinoma stomach, the patient who are willing for follow-up. The criteria: the patient not follow-up, and the patients with recurrent carcinoma stomach.
Your network is something not continuous. It is breaking. Your network is interrupting frequently. Dr. Pandish, we are not hearing you. Your voice is not coming. Dr. Gyan?
Dr. Pandish.
Voice is not there. I am not
Pandish. सर नेक्स्ट करें, मैं उनसे बात करता हूँ सर.
We should start next because frequently there is interruption.
Dr. GD, call the next speaker.
Yes, next speaker is Dr. Bal Kumaran.
सर वो नहीं है, ज्वाइन नहीं किया है.
And
Dr. Harish.
then next, who is the next present?
Dr. Harish.
Sir, yes, sir. Sir, good afternoon, sir. This is
Please
Harish.
share your screen.
Yes, Dr. Harish, you can start.
Yes, sir.
Okay.
Yes, sir. Sir, is my screen visible?
Yes.
Yes. Okay.
Yes, it is visible.
Yes, sir. And I'm starting now, sir. And myself, Dr. Harish from Bharati Vidyapit, Pune. And my paper is about a comparison of tamsulosin and solifenacin in management of ureteric stone-related symptoms. Introduction: ureteral stents are the most common prosthetic devices used by urologists. Ureteral stents are mostly used in obstructive uropathy, promote ureteral healing after surgery. Ureteral stent placement is not complication-free. Some degree of morbidity in the form of generalized urinary discomfort is complained by the majority of patients. The ideal stent has to be discovered. Stents are used to maintain ureteric patency and achieve free flow of urine, prevention of stricture following instrumentation. Patients with ureteric stent may present with symptoms like urgency, frequency, burning, micturition, hematuria. Strategies for managing stent complications include use of medication. Recently, alpha blockers like tamsulosin and anticholinergic drugs like solifenacin has been utilized to get relief from urinary symptoms, which are... Yes, sir.
Yes, yes.
Sir, should I continue?
नेटवर्क इशू आ रहा है
Yes.
आपका फ्री पेपर में प्रेजेंटेशन है क्या बोल रहा था
Sir,
पर आपका वॉइस का ब्रेक हो रहा है तो आपको बैंडविड्थ
Sir, मेरा voice, sir.
नेटवर्क इसका स्ट्रॉन्ग कीजिए और या बाहर किसी भाई
But his voice is audible to us. Organizer,
It's audible, sir.
आपका
Dr. Harish Kumar is audible to us.
ब्रेक हो रहा है सबके पास लैपटॉप तो दिलवाया लैपटॉप है ही नहीं लैपटॉप बोल दे
So, hello.
should I-
Other than Harish, please mute yourself.
यस यस
Okay, sir.
तेरे को मैसेज आया उसका कल चेकअप किया तो मैसेज आया दूसरा अरे सबके नेगेटिव
Yes, Dr. Harish, start.
Sir, somebody told me to stop my presentation, told me to mute.
No, please continue.
Okay, sir.
Organizer, please streamline the presentation.
Okay, sir. Sir, can I continue?
Who to continue? Harish?
Sir, yes, sir. I'm Harish. Yes, sir.
Okay.
Yes,
Dr. Gyan?
Yes, please continue. Yes.
Yeah.
Okay, so continuing, sir. Recently, the alpha blockers like tamsulosin anticholinergic drugs like solifenacin has been utilized to get relief from the urinary symptoms, which are caused due to prostatic hyperplasia and overactive bladder. Tamsulosin is selective alpha-1 receptor antagonist, causing relaxation of the smooth muscle and therefore less resistance to urinary flow. Solifenacin is a competitive cholinergic receptor antagonist selective for M3 receptor subtype. The binding of acetylcholine to this receptor, particularly M3, plays a critical role in the contraction of smooth muscle. My aim is of the study is to compare alpha blockers and anticholinergics in management of ureteric stone-related symptoms. Objective is to determine relief of ureteric stent-related symptoms by alpha blockers, to determine relief of ureteric stent-related symptoms by anticholinergic drugs like solifenacin, to compare the efficacy of alpha blockers like tamsulosin with respect to anticholinergic drugs like solifenacin, to suggest a better management of protocol for lower urinary tract symptoms due to ureteric stent. Materials. This study was carried out in Bharati Vidyapit, which is a tertiary care center in Pune. The study population comprised of total 120 patients with ureteric stenting and having lower urinary tract symptoms. A period of study is 24 months, and it is a randomized controlled study. Inclusion criteria is patients above 18 years of age, unilateral stenting and lower urinary tract symptoms. Exclusion criteria is bilateral ureteral stents fixation after opening or laparoscopic surgery, low urinary tract symptoms before fixation of the stent. Methodology. All patients included in this study were administered in ureteric stent questionnaire and score noted. These patients were randomly divided into two groups on the basis of odd and even number of the IPD, taking last two digits into consideration. One group was given alpha blocker and the other was given anticholinergic drug. The dose of drug of tamsulosin was 0.4 and the dose of solifenacin is 5 mg, and both were administered orally once a day for 14 days. Stent-related symptoms questionnaire was administered again at a time of removal of stent, that is after 3 weeks, to see relief of or improvement of symptoms. Many ureteric stent symptoms questionnaire contains 4 categories of symptoms, which include pain, voiding, work performance, and general health feature. Each symptom is given 1 point and a total score is 15. Questionnaire score, if there is S1, if there is no, then 0. My observation is present study, and this table shows the distribution among the age group. It was observed that majority of the patients in group T were in between 24 to 40 years, and group S were in between 24 to 41 to 60 years. And out of 120 patients, as far as age is concerned, 76 were females and 44 were males. In this group T, 38 are male and 22 are female, and in group S, 38 are male and 22 are females. And this table, as per the location of them, that is whether the stone is in upper ureter, mid ureter, or the lower ureter. And the group T, it was observed that the majority of patients in group T and group S had stone in lower ureter. There was no significant statistical difference in location of stone among two groups. And it was observed that major symptom of pain was 58.3% in group T and 78.33% in group S, which was higher significantly in group S than group T. Frequency was found to be significantly higher in group T and compared to group S. The presence of hematuria and dysuria was significantly higher in the group T. And the side effects like fever, nausea, and vomiting were also significantly more in group T patients than group S patients. The work performance was affected in more in group T significantly than group S patients. While there was no statistically significant difference in urgency, incontinence, nocturia, and malaise when two groups are compared statistically in respect to urinary symptoms. And this is about the distribution of patients according to urinary symptoms, just now I discussed. And this table shows the scoring system. And the mean MUSSQ pre-intervention and after removal of stent was 7.62 plus or minus 2.1 in the pre-intervention, and 4.29 plus or minus 1.2 in after the removal of the stent. And there is a statistically significant. And this score shows the symptoms as far as group S, that is anticholinergic group is concerned. And pre-intervention, the score is 5.13 plus or minus 1.9. And after the removal, it is that, and this has significant, and it is statistically important. And in this chart, we are comparing the scoring system between group T and group S. And well, the difference in the means of MUSS score in the pre-intervention group T is 7.62 and group S differed significantly. The means of after removal of symptoms also differed significantly. When the MUSS score was compared in group T patients, pre-intervention after removal of the stent, the score was significantly decreased after stent removal. Similarly, the score was significantly lowered in group S patients after removal of stent than pre-intervention. The mean VAP score post-operative day 1 and after removal of stent was 6.62 plus or minus 1.2. And that is pre-intervention, and that is under POD 1. And after the removal of stent, then the VAP is 3.63 plus or minus 0.90. And it is statistically significant. And this table shows the relief by the patients according to relief to stent symptoms by TAPS loss. It was observed that majority of patients had relief from nausea and vomiting. Also, the work performance was increased in 33.3% of patients, followed by dysuria, urgency, frequency, nocturia, pain, and incontinence. And this shows the relief of to SEM by solifenacin. It was observed that majority of patients has relief from urgency, pain, followed by frequency. And what are the various side effects of the these groups? And the majority of the patients, that is group T, has orthostatic hypertension as the main side effect, and tamsulosin has a dry mouth as the major side effect. And discussion, the present study was conducted to compare alpha blockers and anticholinergic in management of ureteric stone related symptoms. The study was conducted on patients with ureteric stenting and having a low ureteric tract symptoms. Total number of 120 subjects with age more than 80 years and ureteric stenting and having. Sir, am I audible?
Yes.
Little bit interruption.
Yeah,
It's
please.
okay.
Yes,
Go
sir.
ahead.
Yes, sir. Okay, sir. The study was conducted on patients with ureteric. The total number of 120 subjects with age more than 18 years and ureteric stenting and having low urinary tract symptoms. The patients had of drug tamsulosin was 0.4 mg and that of solifenacin is 5 mg. Stent-related symptoms questionnaire was administered again at the time of removal of stent. In the present study, it was observed that majority of patients in group T were in age group of 21 to 40 years, and in group C, in group S, it is at 41 to 60 years and 21 to 40 years. The mean standard deviation is 39.28 and group S was 40.65 plus or minus 13.46 years. There was no significant difference in age distribution in both groups. Power et al. Studied effect of tamsulosin and solifenacin on stented patients. There was no significant difference in relation to age. Out of 120 patients, 76 were males, while 44 were females. There was male dominance with 38 in both groups. In a study done by Kyongtae et al. Observed that majority of patients were male and there was no significant differences between the groups in relation to sex. So that's also.
So, by your conclusion, what inference you drawn?
Sir, sir, there is no whatever as far as the drugs are concerned, there is no superior drug when both the drugs are compared, like tamsulosin, and when we give tamsulosin and anticholinergic drugs, the final outcome is similar in almost all the patients. Sir.
So if you combine tamsulosin and solifenacin both for
Yes,
the
sir.
patient symptoms,
okay, sir.
Then that is also coming in the combination by certain pharmaceutical companies.
Yes, sir. Yes, sir. Right
I
now,
think.
yes, sir. It's coming, sir.
So that is causing more beneficial effects.
Okay,
so
sir.
why you are splitting these two? So that means there is no significance in individual use of these drugs.
Individual use, yes, sir.
Okay.
Yes, sir. Okay, sir.
You can combine these both and get the better results.
Yes, sir. Okay, sir.
Dr. Gyan?
Yes, sir. So, how long you have given this medicine to the patient?
So,
after?
sir, for 2 weeks, sir. For 2 weeks post procedure, sir.
When you started, just after stenting, or?
Yes, sir. After stenting, sir. After means from the P1 is 0.
If you have the small lower ureteric stone.
Sir, your voice is breaking, sir. I can't.
If you are having the lower stone, that's the less than 5 millimeter, will you prescribe without any stent this drug?
So for lower ureteric, sir.
Yeah.
Yes, sir. Less than 5 mm. Yes, sir. Less than 5 mm we can give, sir.
And if you got the patient with stent-related symptoms, which drug will you prefer?
So stent-related.
Yeah.
Sir, in our college, usually you use tamsulosin, sir.
If you
yes, sir.
need both, means you are increasing the dose, double dose.
Yes, okay, sir.
You will have a side effects also.
Yes, sir. Yes, okay, sir.
Initially, it was mixed in the single bore. Now it has been discontinued again.
Yes, sir. Okay, sir.
Will you still combine both drugs?
Yes, sir.
Patients already on tamsulosin, then have you included or excluded those patients?
Sir, this is after. So these patients preoperatively, these patients are not any drugs, sir.
Okay.
Yes, sir.
Thank you.
Okay, sir. Thank you. Sir.
Thank you.
So should I stay and till the all the procedures are complete, or can I discontinue, sir?
You can discontinue.
Yes, sir. Okay, sir. Thank you, sir.
Next, Dr. Balraj.
So thank you, sir.
Share your screen.
Who is the next candidate?
Dr. Balraj.
Sir, I came. Yes, sir. I'm. Very good afternoon, sir. Good morning, sir. I'm Dr. Balraj from Tinur Medical College, postgraduate student. I'm going to present a paper on preoperative serum albumin and body mass index as a predictor of postoperative morbidity and mortality in LT major surgeries. So, introduction. So, wound healing requires energy is a catabolic process, and patients who are severely malnourished demonstrate impaired wound healing and predisposition to infection. They also suffer deficient immune mechanism. The catabolic effects of disease or injury can be reversed by adequate nutritional support. The degree of malnutrition is estimated on the basis of weight loss during the past 6 months, physical findings, and plasma protein assessment. Patient outcome can be calculated by a variety of valuable nutrition indices by means of risk stratification
an objective comparison among patients, but when used alone, there is no consensus on the method for assessing nutritional status. So serum albumin level greater than 3.5 gram per deciliter suggests adequate protein stores, whereas serum level less than 3.5 gram per deciliter raises concern for potential surgical complications. And also the body mass index of 19 to 25 kilograms per meter square is for average suggests it's a normal nutritional status. Less than 18 kilograms per meter square suggests a potential surgical complication. Thus, this study therefore aims to correlating preoperative serum albumin and body mass index as a predictor of postoperative morbidity and mortality in L2 major surgeries. So, aims and objectives of this study to validate preoperative and serum albumin and body mass index of predictors of postoperative morbidity and mortality in L2 major surgeries. Materials and methods. The source of data is from patients admitted in surgical wards at Tirunelveli Medical College Hospital for any major L2 surgeries from September 2018 to 2020, and my sample size is 100 patients. Methods of collection of data, inclusion criteria, patients admitted for any major L2 surgeries, both male and females, more than 12 days.
Is it network problem?
So no, sir. I'm able to hear, sir. Sir, can you able to hear me, sir?
Yeah. We are hearing you.
Yes. So exclusion criteria is so children is less than 12 years, and patient who have already have any chronic liver disease or chronic kidney disease or anemic less than 7 grams per deciliter. And going to results. The study was carried on 100 patients between 15 to 85 years who undergone any major L2 stage in Tirunelveli Medical College. Among 100 patients, 54 patients developed complications and 58 had uneventful recovery. Sex distribution, sir.
Dr. G.D. Yadav, are you hearing the voice?
Yes, sir. That is
yes,
audible.
Sir. I'm able to hear, sir.
Audible,
yes.
sir.
Yes, continue. Dr. Balraj, continue.
Yes, sir. Sex distributions among the 100 patients under my study, 42 were female and 58 were male. And the standard deviation for this minimum age is 18 years and maximum is 80 years. Median age is 50 years. Sir. And based on the age-wise distribution, there was 40 to 70 years of age was occupying the more number of cases in my study, sir. And based on the distribution by BMI, in my study, undernutrition cases 14%, that is 14 cases. The normal, that means between 18.5 to 24.99 kilogram per meter square by 83%, 83 cases, and overweight patients are 3%, sir. That is more than 25 kilogram per meter square of BMI, and this shows in the pie chart. And based on the lesion, in my study, the malignant cases are 43%, and the non-malignant cases are 57%. Distribution on the level of serum albumin, patient categorized are 3: mild, moderate, and severe, normal. Mild albuminemia, that means serum albumin level from 2.1 to 2.7. Actually, it's not. The normal level is 3.5 to it's 21%. This is a moderate hypoalbuminemia, it is 14%, and my severe hypoalbuminemia, that is less than 2.127%, 60%. Distribution of complications of surgery. There was complications of 54% were had complications. Among them, burst abdomen 1%, fistula of 5%, and the mortality was among 2%, and port site on the infection was 1%, seroma was 9%, and wound infection was 27%. Discussions with natural defense mechanism malfunction and malnutrition are perceived as risk factors for high morbidity and mortality in the postoperative period. Malnourished patients are at high danger of postoperative morbidity and mortality whenever contrast with well-nourished patients exposed to similar surgical procedures. Nutritional appraisal is concept basic so as to distinguish patients who are at an increased risk of developing postoperative complications. In spite of the fact that various studies have assessed the diverse nutritional indices, serum albumin and the BMI as a markers of developing postoperative morbidity and mortality have been taken up in specific studies. In this serum albumin less than in one study, serum albumin level under 3 grams per deciliter was related with increased postoperative morbidity as indicated by the study by Mullen et al. And Kolab et al. And Light et al. And our study is likewise credited to comparative outcomes with patients having serum albumin levels lesser than 3 grams per deciliter suffering from significantly higher complications as seroma, wound gapping, and lower respiratory tract infections and mortality in fistula. When contrasted with the patients having higher serum albumin levels. A large portion of patients in our study had serum albumin levels going from 3.1 to 3.5%. So thus the serum albumin is in this assessed as the reliable indicator of mortality for surgical procedures as whole. It was a better indicator of certain kinds of morbidity, especially sepsis and infections than other types, and was a valuable prognostic marker as per studies. The postoperative complications were more in females than males in my study. Our study likewise had a slight preponderance to females with respect to complications during postoperative stay and complications. That is increasing in the proportion of people affected with post-surgical complications with increasing age up to the age of 70, and it's statistically significant. Those with above 50 years of age have 2.9 times more odds of developing post-surgical complications when compared to patients aged 50 years and below. It is a statistically significant. This p-value is less than 0.05. And another study, Florish et al. In their study exhibited the preoperative hyperalbuminemia is a significant risk factor for postoperative morbidities following rectal malignant surgeries. This recommends preoperative hyperalbuminemia is a risk factor for postoperative complications following rectal malignancy, surgical procedures such as postoperative bowel function and the mean hospital stay. Our study additionally shows that lower serum albumin levels and increased incidence of morbidities seen among the patients who suffer from malignant lesions compared to non-malignant lesions. Those with malignant lesions had 7.2 times more odds of developing post-surgical complications when compared to patients with benign normal lesions. It is also statistically significant. In our study, the postoperative complication increased as the serum albumin level diminished from 3 grams per deciliter to lesser levels. And furthermore, as respects BMI, the complications were more with the patients with abnormal BMI, both undernutrition and overnight, when compared to patients with normal BMI. Those with abnormal BMI, that is 76.5%, both undernutrition and overweight, had more post-surgical complications when compared to patients with normal BMI. So those with abnormal BMI had 4.9 times or more of odds developing post-surgical complications when compared to the patients with normal BMI. So that is 18.5 to 24.9 kilogram per meter square. Significant difference was observed and statistically significant. Comparable outcomes were noted by a process cohort study done by Mullen et al. On body mass index on perioperative results in patients going through major intra-abdominal surgery, which is where they concluded that patients who were underweight had a 5-fold increase in the post-operative mortality, perhaps as an outcome of their underlying nutritional malnourishment. In a study by Michael et al., malnutrition outcome and nutritional health recommend perioperative response like BMI 18.5, less than 18.5 kilogram per meter square, and serum albumin less than 2.51 kilogram per deciliter, having significant surgical outcomes. It's a conclusion, sir. Serum albumin is valid as just serum albumin is thus validated as the single important marker indicator of post-operative complications, depicting the individual's nutrition status and highly indicative of post-operative morbidity and mortality. In our study, 100 patients, the complication rate was more when the serum albumin was less than 3 grams per deciliter, which was statistically significant. The rate of complication decreased as serum albumin level increased from 3.1 gram per deciliter and above. Patients with serum albumin level greater than 3.5 gram per deciliter have lesser complication, which was statistically significant irrespective of malignancy or non-malignant pathology. Thus, serum albumin is a better predictor of surgical outcomes than any other preoperative patient characteristics. It is a comparability, a low-cost test that is widely performed, and which estimated value should be used more frequently as a prognostic tool to detect malnutrition risk of adverse surgical outcomes. And finally, sir, there was no statistically significant sex preponderance with regards to complication rates. The disease process also play in post-operative complication rates as evidence in our study as the complication is higher in the malignant operation which was statistically significant, sir. Thus, the serum albumin and the BMI can be used as an easy, cost-effective, and highly reliable tools in predicting post-operative complications, and thus the effective preoperative nutrition supplementation can be given to reduce morbidity and mortality in the long run.
Hello.
Yes, sir.
Dr. Barlaj, there are various indicators of malnutrition. You did not mention about the anemia in your study. Only the hypoalbuminemia was associated with the poor outcome, not any relation with anemia, low hemoglobin level.
Yes, actually that I have excluded hemoglobin levels of less than 7 grams per deciliter, sir. And specifically, I would taken serum albumin and BMI only, sir. I have not taken any other nutrition or any other indicators in my studies.
So hemoglobin was always more than 7 in all these patients.
Yes, sir.
Okay, that was not less than 7. There was no severe anemia in these cases.
No, sir. Choosing the selection criteria was the cases with more than 7 grams per deciliter in all my cases.
More than 7 is also anemia. You should have taken more than 10.
Yes, sir. Yes, sir.
And BMI is also this risk factor for the post-operative outcome.
Yes,
so
sir.
all these two things, they are well established. Anything new in your paper presentation?
No. Yes, sir. None. Actually, nothing new, sir. Actually, it's already proven, and again, it's a proper decided again to prove that again.
BMI less than 18 or more than 25, that is, which one is more significant? Less than 18?
So less than 18, sir, it was more significant, sir, with post-operative complications and mortality also. Out of my 100 cases, 2 cases are died, sir, and both of them were less than 18, sir.
And also more than 25 is also having more risk and more complications?
Yes, sir. They are prone for wound infection.
So either the obese patients, overweight and this undernutrition, underweight.
Yes.
These
Yes,
both conditions, they are harmful for the post-operative outcome of the patients.
Yes, sir.
But in your study, it is less than 18 malnutrition. It is more significant for the post-operative complications. Okay.
Yes, sir. Yes, sir.
Dr. Barlaj.
Yes, sir.
What was your end point of study?
For patient who are planned for elective surgeries, if their serum level, protein level, albumin level is less than.
Suppose patient underwent surgery, then what was the end point? How long you have observed these patients after surgery?
Up to 1 month, sir. And post-operatively, patient is asked for follow-up for monthly once. He'll follow up to for 6 months, sir.
So, what are the different types of surgery? Have you taken only single type of surgery or all types of surgery you have included?
Sir, I've taken all major surgeries, sir, including any abdominal, any malignant disease, and umbilical hernia. In my cases, I've excluded in hernia classification, the inguinal hernia I've excluded, sir, or umbilical hernia, incisional hernia I've included, and thyroid or malignancy, all cases I've included, sir. The patient who received chemotherapy, I've excluded, sir.
Dr. Barlaj, there are so many confounding factors you have not excluded. If you have been taken single type of surgery, then the result will be better. But you have not excluded, you have taken all type of surgery. You know, the complication rates are different in different type of surgery.
Yes, sir. Yes,
you know, depends on the age. You have not selected the group. You have just after 18 years, you have taken all the patients. So it's not a good study you have planned. So if you plan properly, then you have some fruitful results. In your study, it is very haphazard. As Dr. G.D. Yadav also mentioned that you have not taken the other nutritional factor. But even if you are not taken, then you have to take strict criteria for that. not just about the 7 gram of hemoglobin you have taken it. So if the patient's one is the 7, another is a 14, so how will you compare both these groups? So
Sir, for my
study
aim of
is very unplanned type of things. So next time you have to plan very well. And
yes, sorry. Sir, actually, we have planned to just describe the serum albumin alone, and we have discussed ICMR, sir, here in our college.
No,
just
you
to,
are right, Dr. Balraj, you are right, but you have to confine or you have to stick to your selection criteria or define the selection criteria. I mean, suppose you are taking laparotomy, so take only the laparotomy, not the perineal surgery, gallbladder surgery, all surgery you have included, clubbed with all these things. So the complications rate are different in the hernia surgery as well as different in the gallbladder surgery.
Yes.
Your study, Dr. Gaya said, your study should be more scientific, and
yes,
that could be explained to everyone. Okay.
Yes, sir. Yes, sir.
Dr. Balraj, if you have a patient of BMI 32 with albumin 2.7 and subacute intestinal obstruction due to the CA ascending colon, how will you manage?
Sir, I'm not able to say the partial breaking, sir.
If you got a patient of subacute intestinal obstruction with CA ascending colon,
okay, sir.
albumin 2.7, BMI 32, how will you manage?
Sir, BMI we can't do on our patient is in malignancy in the potential for metastasis. So we'll be improving his albumin status by asking him to take protein-rich diet and also protein-rich diet. But BMI we can't because patient may be stunted due to the tumor necrosis factor from the malignancy. The patient will be emaciated, but we can improve protein level by giving protein supplementation, sir, by asking him to take protein-rich diet, sir.
Means you will wait for surgery.
No, sir, we can't wait because.
Then how will you tackle albumin and all that?
Either we have to take up for surgery and post-operatively we can infuse with TPN like.
You already said the complication rate increases 29%. Complications are bound to occur. Then what will you do? Okay, thank you.
Thanks.
Okay.
Thank you very much.
Okay, Adam, next speaker.
Yes, next speaker. Organizer, please send the next speaker.
No one. Next speaker, please.
No, all is over.
Yes, all
Third candidate, Mr. Harish. Mr. Harish Kumar.
Pandey is ready or not? Pandey.
Sir.
No, Pandi.
Hello.
Hello, Balakumar.
Balakumran, hello. Yes, sir. This is Balakumran. I was called upon early, but due to some technical issue, I couldn't continue. Shall I do it now, sir?
Balakumran.
Yes, sir.
Dr. Rajput, sir.
Shall I press?
What's the topic, Balakumran?
The hand of hope, sir.
Okay.
Dr. Yadav, allow him.
Yes,
yeah,
yes.
Please allow.
Dr. Balkumaran, you can start.
Yeah, Kumran, please start.
Thank you, sir. Can you see my screen, sir?
Yeah. Yes. But it is
Okay,
not clear. It is very.
This is a.
Yes,
The first page is. Just a minute.
Okay. Now.
Okay.
Now it is
Good afternoon,
clear.
everyone. Yes, sir. Good afternoon, everyone. This is Dr. Balakumran, second year PG, from Sathya Sai Medical College and Hospital. My paper topic is The Hand of Hope. The death of beloved is an amputation, said by C.S. Lewis, famous author of Chronicles of Narnia. I'll start with my presentation with an overview of with aim, introduction, case report, result, and conclusion. Aim of this presentation is to emphasize the need for a devout attempt to save the limb before amputation. Traumatic injury and infection of the limb are one of the leading causes for amputation all over the world. Here we have discussed a case where we saved the patient hand, which was referred to our center for amputation. A 50-year-old male daily laborer came to surgical OPD with a history of thorn prick and right hand in the right hand and subsequently developed an ulcer and ascending ciliatus of forearm, which he was trying to conservatively manage by home remedies. Later, he developed severe restriction of hand movements. The wound got worsened in due course, and the fifth digit was disarticulated in a secondary care setup which he was taken to. Patient later came to us. On examination, patient was found to have necrotizing fasciitis of right hand and forearm with symptoms of sepsis and uncontrolled type 2 DM. We did a serial debridements and infection control was achieved. Patient was put up on higher antibiotics and other supportive medications. Wound dressing was done twice a day with minimal debridement in bedside. Patient was advised to have high protein diet and high protein and nutritive diet. Wound over the course of 2 weeks. The wound in the first picture was post-op day 2, later after post-op day 7, and there's the post-op day 14. Patient was planned for SSG. Graft uptake was good. Rehabilitation and physiotherapy was given to the patient. Patient was able to do daily duties and personal care by himself with his recuperated limb. Conclusion: a determined and willing patient with proper medical care got a second chance to have his hand.
So
this is
that's over.
Just a minute. So this is a video of him with a severe restriction of movements. Now he started to even write a paper and he can sign his name. The video is not playing, so I'm sorry about the technical difficulty. The take-home message is when it comes to limb or life, the life matters the most. But if you can save the limb too, it will be a life changer for the patient. My references. That's also.
Your paper is too short, only covering the one aspect of infection. If you have must included more things to save the limb, that would have been better paper.
Yeah, definitely. Dr. Kumran, you have not mentioned any culture report, antibiotics, dressing material, nothing you have mentioned. Just so what is new in this your case presentation?
My
The
presentation
case presentation itself is not very complete. You have not mentioned the culture report, not mentioned the vascularity of the limb, whether you did any vascular study in this patient, what dressing you have used in this patient. Nothing is mentioned. So it is totally incomplete presentation. Even if
And that again one thing, he must have included the trauma and all those things where the plastic surgery they are saving the limbs. That must have been better paper in spite of infection and all this. One case cannot make a paper.
Okay, sir.
Okay.
Okay. Your paper is incomplete. Moreover, you have taken the title of this. From where you taken that?
I made it up, sir.
Hand of hope. It belongs to the one team, that is the patient neonate was operated for spina bifida. Probably you have taken that.
Okay. No, sir. I don't think. Okay, maybe a coincidence, sir. It was just made up theme, sir, for me.
Grossly inadequate presentation.
Sorry about it, sir. I'll improve.
If you are coming at national forum, so you must have paper which should be of sufficient knowledge and informations. Okay, your
Okay,
small presentation, we appreciate it. Your effort is good, but
thank you,
it
sir.
should be better.
Sure, sir. We'll improve for next time.
Yeah, please complete all these details and then publish it in some article in your journal, whatever you selected. Okay.
Sure, sir. Thank you so much.
Okay. Thank you.
Okay,
Thank
okay,
you, sir.
thank you.
Thank you.
I think that's only 3 candidates were there. Dr.
First
Rajput, sir.
presentation, sir.
Thank you, Yadav. Thank you.
Dr. GD, sir, what was the first one whose voice was not clear and it was interrupted in between?
Dr. Pandishwaran.
Yeah, yeah. What happens to that candidate?
Dr. Pandishwaran, are you audible?
Yes, sir.
You are now.
Your voice
You
is
are
not clear.
your voice is still interrupted. Now again speak.
Okay.
Your Wi-Fi communication
hello,
is not.
Audible, sir?
Yeah.
Yeah, please present.
Yes.
Dr. Pandit, please present.
Yes, sir.
Yeah, please.
Yes, Dr. Pandish. Dr.
Yes,
Pandish.
visible, sir. My screen is.
Yes.
Hello.
Hello.
Still your voice is breaking.
सर नहीं हो पाएगा इनका बैंडविड्थ इशू
चलिए ठीक है ऑर्गेनाइजर डू यू हैव एनी अदर कैंडिडेट फॉर प्रेजेंटेशन और वी क्लोज इट
नो सर हेलो पंडित सर
इट्स डिसीजन ऑफ डॉक्टर राजपूत सर
Yes, sir. If there is we should complete the session.
Okay.
Yes.
Thank you.
That's over. We are in time.
Yeah. Sorry, Pandeswaran, because your voice is not clear. I think your Wi-Fi or connection is not clear from your side.
We could not communicate you.
And yeah, please try on next time.
Okay. Thank you, Dr. Gyan. Thank you, Dr. Rajput.
Thank you, sir.
Thank you, Rajput sir. Thank you, GD Yadav sir. Thank you.
Okay. Bye bye.
Bye, sir.
Hello. याने तुला फोन आलता का? तुला फोन आलता? मला आलता फोन, तुम्ही जॉईन नाही म्हणून. म्हटलं होतं जॉईन, म्हटलं थांब थोडा वेळ.
किती वाजताचं आहे का?
मॅडम व्हाईट व्हाईट शर्ट घालतो मी. चलो हो गया, फिनिश्ड.
Hello, Dr. Naz. Dr. Naz?
Yeah.
Can you hear me?
Yeah, I've just joined. Okay.
Ma'am, first speaker here, next speaker is Dr. Ritu Arora, Dogra.
So I have to call Ritu Dogra.
जी डॉक्टर रितु डोगरा
Yeah. और 3 मिनट है ना?
डॉक्टर रितु डोगरा एंड डॉक्टर
Who are present?
First is Dr. Ritu Dogra.
Ritu Dogra. Who are all present? Dr. Ritu Dogra.
And Dr.
Vinay Kumar.
No.
Siddharth Singh.
Siddharth Singh Arora and Kranti Raj Popat. Three speakers in this session.
Kranti Raj. Okay.
Dr. Ritu Arora? Dr. Ritu? Please share your screen. Dr. Ritu? Can you hear me? Dr. Ritu? Hello, Dr. Ritu? Can you hear me? Dr. Ritu, can you hear me?
We can start now.
Dr. Ritu, can you hear me? Dr. Ritu?
अभी तक इसमें तो कोई चेयरपर्सन ने ज्वाइन नहीं किया, बट मैंने उनको इन्फॉर्म कर दिया था और मीटिंग आईडी वगैरह। ओके सर, मैं अभी फिर से दोबारा एक बार कॉल करता हूँ। फर्स्ट प्रेजेंटर सर डॉक्टर प्रियंका गुप्ता, सेकंड सर प्रतीक अग्रवाल एंड थर्ड सर वरुण। Yes, sir. Yes, sir. Okay, sir. Okay. Thank you. Okay, sir.
डॉक्टर रितु, आपको हमारा आवाज नहीं सुनाई दे रहा? ओके ओके मैम, आपको ये किससे लैपटॉप से यूज कर रहे हैं? लैपटॉप? हाँ, लैपटॉप। आप इसको लॉग आउट कीजिए, फिर दोबारा से लॉग इन कीजिएगा, और स्क्रीन शेयर करते समय आप अपना सिर्फ पावर पॉइंट खोलेंगे, पहले मिनिमाइज करेंगे उसको, फिर जूम पे जाके शेयर करेंगे और अपने प्रेजेंटेशन पे क्लिक करेंगे। जल्दी कीजिएगा। डॉक्टर नास,
आई मीन
मैम डॉक्टर रितु का कुछ टेक्निकल इशू है, वो थोड़ी देर बाद ज्वाइन करेंगे।
ठीक है।
नेक्स्ट हम स्टार्ट करें।
ये मेरे लैपटॉप में ये म्यूट ये सब नहीं दिखाई दे रहा, इसलिए आई वाज जस्ट वंडरिंग। एनीवे आई लॉग इन थ्रू द फोन।
उस पे आपको कर्सर को आप लेके जाना पड़ेगा स्क्रीन पे, तब वो दिखाई देगा। लैपटॉप पे यूज कर रहे हैं?
ठीक है। Should I call the next speaker?
Okay. Dr. Vinay Kumar.
Yes, sir. I am in. Yes, sir.
मैम डॉक्टर रितु अरोड़ा आ गए, रितु डोगरा आ गए हैं। डॉक्टर रितु।
Hello. Is it audible?
Yes, yes, yes. Please share. Okay. You start.
Start. Restart.
Yeah, go ahead.
Good afternoon, everyone. I'm Dr. Ritu Dogra from Deen Dayal Upadhyay Hospital, presenting our study for the evaluation of sentinel lymph node biopsy by using methylene blue dye alone technique in breast cancer patient under the able guidance of Maninder Kaur Chhabra ma'am. Hello. Hello.
Yeah, go ahead.
Actually, it's not moving properly. Sorry for that. Over the past few decades, surgery of the breast cancer has evolved from radical mastectomy to breast conservation. So there is an emerging trend for conservation of the axilla. And sentinel lymph node biopsy is now considered standard of care for breast cancer patient because we avoid axillary dissection because of its associated comorbidities. Clinical assessment of the axilla gives false positivity of 53%. Ultrasonography adds to the diagnostic accuracy of only 67.9%. So the next option, that is sentinel lymph node biopsy, provides a histopathological confirmation and is better in predicting axillary involvement in clinically negative axilla. Sentinel lymph node biopsy can be done by blue dye alone method or dual method. Dual method is the gold standard, but it requires elaborate nuclear medicine setup and is expensive. Our research question in the study was whether sentinel lymph node technique using blue dye alone method can be validated to have reasonable sensitivity, accuracy, negative predictive value, and acceptable false negativity so as to advocate its use in the resource constrained setups. So we planned this study to evaluate methylene blue dye alone method as an alternative so that it can be offered as therapeutic option to axillary lymph node negative patient in resource constrained patients. So keeping this aim and objectives in mind, we proceeded with the study in Deen Dayal Upadhyay Hospital in New Delhi. Our sample size was 50 patients calculated on the basis of Dharmiya's Cancer Hospital study. We included both the male and female patients with non-metastatic breast carcinoma undergoing MRM and excluded the inflammatory breast carcinomas, pregnant and lactating women with history of any prior surgery on breast and axilla and known allergy to methylene blue dye. Prior to surgery, we took the IEC approval, did the workup for the patients, and metastatic workup was done in stage 3 patients. We informed the patient about the procedure, informed consent was taken. After that, the patient was taken for MRM in a standardized technique. Incision was marked for MRM preoperatively. Peritumoral injection of 4 ml of methylene blue dye was given, followed by breast massage for 5 minutes. Then axilla was entered first by incision at the lateral end of the margin, and flap was raised. To see any blue color lymphatic is identified and followed till blue nodes are encountered. All the blue nodes and the lymph nodes present along the track of the blue lymphatic were taken for the biopsy. This is a slide showing the blue lymph nodes excised in our patients. Sentinel lymph node were taken in a separate container for histopathological examination. After SLNB, mastectomy was done. As a part of MRM, axillary dissection was done. There were no anaphylactic reactions noted in any of the patients intraoperatively. In our results, the patients were in the mainly in the age group of 41 to 50 years of age with median age of 48 years and ranging from 25 to 85 years of age. Most of the patients were having the breast lump in the upper outer quadrant, that is 34% of the patient, and least in the lower inner quadrant, that is 8% of the patient. And most of the stage at presentation was stage 2 followed by stage 3. And 11 patients were post-NSAT patients. The time of central lymph node identification in our case is ranging from 10 to 30 minutes. And the central lymph node exercise were ranging from 1 to 8. In our 2 patients, we were not able to identify the central lymph node. Complications in post-operative period were mainly seroma and SSI. Histopathological examination revealed that majority were ER/BR positive patient and HER2 negativity, HER2 positivity in 13% patients, and distribution of triple negative patient was in 28% of the patient. Histopathologically, the tumor was IDC in 68% of the patient, and majority were grade 2 followed by grade 3. For our calculations, we made 3 contingency tables for the main study group, for the post-NACT patients, and after excluding the post-NACT patients. So we calculated that our identification rate was 96%, false negative rate was 8.33%, and diagnostic accuracy of 91.6%. But after excluding the post-NACT patient, our sample size became 39, and our identification rate becomes 100% and increases the diagnostic accuracy to 94.87% with false negative rate of 5.13%. We know that central lymph node biopsy in post-NACT patient have the concern of poor identification rate and false negative rate, which was also seen in our study as well. Coming to discussion, Halstead gave the hypothesis of natural history of breast cancer. This is also the basis of central lymph node biopsy. Feasibility of identifying central lymph node in breast cancer and capability of sentinel lymph node to accurately predict the status of the axilla was demonstrated by Giuliano, whose identification rate was 65.5%. Later, many major trials were done for central lymph node biopsy, but Simon was the first surgeon in 2003 who reported the successful application of 1% methylene blue dye in breast cancer central lymph node biopsy. In the major Western trials, our study results are quite comparable with these studies. And also the blue dye and combined agent studies, our results with the Asian studies and the Western studies are quite comparable with identification rate of 96% and false negative rate of 8.3%. So we conclude that diagnostic efficacy of methylene blue dye alone technique of central lymph node biopsy is comparable to reported studies of single dye and combined techniques of central lymph node biopsy. Therefore, it is safe and reliable method of central lymph node biopsy. These are my references. Thank you.
Yeah. Thank you. Thank you, Dr. Ritu. It was a nice presentation.
Thank you, ma'am.
Yeah. You have finished on time. I just wanted to know whether your clinical evaluation was it including USG negative or only clinically negative axilla?
Ma'am, it was clinical as well as if we find any lymph node in the axilla, we did the FNAC of that also.
Okay. After the FNAC, you say it is negative.
Yes, ma'am.
Okay. And then you have said that those people who are allergic to methylene blue,
yes, ma'am.
You have expected them to have taken the methylene blue in their previous. What do you mean by that?
Ma'am, methylene blue is given in some cardiac conditions.
Okay.
And for that, if there is any history of that drug intake and drug allergy, then we have asked for that.
But that would be a very remote possibility, isn't it? So do you give a test dose?
No, ma'am, we didn't give test dose because of its that tattooing effect on the skin,
yeah,
as well as the allergic rate to methylene blue dye are very low.
Exactly. Okay. Then I just wanted to know that you are doing an MRM,
yes,
and then you are taking a sentinel lymph node. You do a sentinel lymph node first, then do the MRM. How are you going to do it?
Ma'am, we did first the central lymph node biopsy and then did the MRM.
What was the incision taken? Did you include the whole incision of the MRM into it, or you took a separate incision then merged with it?
Ma'am, since we are doing the MRM along with the central lymph node biopsy, so we took the lateral end of the incision as the axillary incision.
Okay. Okay. Yeah. Thank you.
Thank you.
Yeah. Can we? Who is the next presenter?
Next is Dr. Vinay Kumar.
Thank you, ma'am.
Dr. Vinay.
Yes, sir. I'm in.
Please share your screen.
Okay, sir. Just a second. Respected teacher, today I am going to present a paper on clinical correlation of preoperative serum albumin with postoperative outcome as a marker for surgical stress and predictor for surgical outcomes in laparoscopy patients. Sir, in the introduction, approximately 1/3 to half of the hospitalized patients in our country are malnourished at the time of admission. And their nutritional status can not only adversely affect a patient's clinical condition, but also adversely affect their surgical outcomes. Surgical interventions trigger a metabolic stress response of varying magnitude, which contributes to complications, delayed recovery, and prolonged hospital stay. A number of preoperative interventions allow modulating an excessive stress response, some of them having an important positive impact on clinical outcome. Therefore, a trustworthy forecast of the surgical stress response is of high interest. The ideal marker has to be easy to measure, available early in the preoperative course, and economical. It should be robustly correlated with the extent of surgical trauma and be a reliable predictor of complications and prolonged hospital stay. So far, no such parameter is available. Albumin, the most abundant protein in humans, is widely used as a nutritional marker and an outcome predictor. Albumin also shows an instantaneous response to surgical tension and could therefore meet the criteria to determine surgical stress and to predict a complicated postoperative course. The present study aims to assess serum albumin levels as a response marker for surgical stress and as a predictor of adverse outcomes. So initially, insulin was proposed by Thorel et al. In 1999, but the cost of test and the reliability factor has made it difficult to measure insulin. Sometimes the peak values are observed only after the golden period is crossed. The information of the major surgeries and their outcomes is scarce in India. Publicly available data on postoperative complications, their predictors and outcomes are scanty, which is hindered in deciding the parameters to follow or observe in the patient undergoing major surgeries. Not many studies are available that uses serum albumin to understand the response to surgical stress and related clinical outcomes. This is why albumin is proposed as a reliable predictor, as it is evidently available and easy to measure. Albumin is known to react immediately to surgical stress and has been instrumental in predicting clinical course and outcome. So Jones and Eaton found that postoperative edema was associated with low concentration of serum albumin and serum protein, which they attributed to preoperative and postoperative undernutrition, a study conducted in 1933. Rich et al. In 1918 found that patients undergoing cardiac surgery who had lower serum albumin levels showed a trend towards having higher postoperative mortality and morbidity rates than did patients with normal serum albumin levels. Hypoalbuminemia affects tissue healing, reduces collagen synthesis in the surgical wounds. It also has a role in impairing immunity like granuloma formation and activation of macrophages. Thus, in patients with hypoalbuminemia, postoperative wound infection and other complications are common. One similar study was recently conducted by Martin Hubner et al. In 2016 on 17 patients who underwent abdominal surgery. Their albumin levels were measured from day of surgery and followed up to till post day 5. The results showed that the values of albumin dropped postoperatively by 10 grams per liter, which correlated with the length operation complications and clinical outcomes. So, aim of the study was to assess serum albumin levels as a marker for surgical stress, to assess serum albumin level as a potential predictor of adverse outcomes like delayed wound healing, increased hospital stay, and organ dysfunction. So, the study was conducted at Department of General Surgery, High-Tech Medical College of Bhubaneswar between November 2019 and 2050. A total of 50 cases undergoing abdominal surgery were included. Patients were evaluated preoperatively for serum albumin, intraoperative data collected and documented. Postoperatively, patient was assessed for wound healing, hospital stay duration, and complications. The criteria for the study was inclusion criteria: patient above 18 years of age, patient undergoing clean and clean contaminated surgery, patients with preoperative albumin below 3.5 milligram per deciliter. Exclusion criteria: patients having contaminated and dirty wounds and undergoing surgery. Patients with other established risk factors for postoperative morbidity like diabetes mellitus, decompensated liver disease, and systemic illness are excluded. So the results in study included 50% undergoing abdominal surgeries. The data shows of which 50% are males and 46% are females. The mean preoperative serum albumin was 3.038 gram per deciliter. So this is a study. The age ranges from minimum 18 years to maximum 72 years with mean of 48.18 year. And pre-op albumin level was varied from 2.1 to 3.4 with mean 3.038. And presumption of diet occurs in minimum 4 days to maximum of 4 hours to maximum of 216 hours. For a length of hospital stay was minimum of 5 days to maximum of 73 days. Sir, we noticed a total of 27 complications out of 50 patients with a mean of 2.935% with a degree of 98 and p-value less than 0.001. Whereas surgical site infection were present in 14 patients out of 50 patients with a mean of 2.873 and degree of freedom 98. There is significant difference in the albumin levels in the presence and absence of the complications as well as presence and absence of surgical site infection. So discussion, a total of 50 patients undergoing clean and clean contaminated cases were taken to determine the correlation between preoperative albumin and postoperative outcomes. Serum albumin is a marker of disease and malnutrition and hence can be predictive of operative outcome. It is better prognostic indicator of nutritional status than anthropometric markers. All abdominal procedures were collectively taken off under this study and was not differentiated according to the undergoing procedure as in case of previous studies. So the complications were classified as per Dindoclavin system, where grade 1 and 2 are measured as minor and grade 3 and 4 are measured major complications, and the mortality is graded as grade 5. So it was observed that 28% of our patients, there was a significant relationship found between the occurrence of surgical site infection and albumin levels. Hennessy et al. Reported 25% developing surgical site infection in that study. They reported that patients who developed SSI had a lower probability serum albumin. So similar studies also showed incidence of 10 to 15% of SSI for patients undergoing various surgeries as the complications. Other major complications being serum formation and anastomotic leak. In another study, we found that an albumin level below the discriminatory threshold of 3.2 gram per deciliter was a significant predictor of overall postoperative morbidity. Apart from surgical site infection, duration, hospital stay, and resuming oral dietary intake are also parameters which are negatively affected by preoperative low serum albumin levels. So conclusion, low preoperative albumin level is associated with a significantly higher risk of surgical site infection. Also, low preoperative albumin levels are associated with a significant higher risk of other complications postoperatively. There is a negative moderate correlation between preoperative serum albumin levels and resumption of diet after surgery. That is, patients with lower albumin level before surgery took longer to regain bowel function postoperatively. There is similar negative moderate correlation between preoperative serum albumin levels and length of hospital stay. In view of these results, we conclude that preoperative serum albumin is a good prognostic indicator for predicting the outcome of surgery. It is a cheap and easily applicable test by estimating albumin levels in surgical patients before surgery and adequately correlating lower levels when necessary. Post-operative morbidity could be reduced in this patient. There are certain limitations to test. There are also several limitations. In this study, where only a single set of surgical procedures is evaluated, the other surgical procedures are not considered as part of this study. The smaller sample size leaves us with only hypothesis. False positive and false negative are yet to be addressed with more sensitivity, reliability, validity, and specificity. Testing in larger patients is required and also in other critically ill patients. How far these values can be used to decide therapeutic procedures remains a query. There are future recommendations for this study. This study should be replicated for other major surgical procedures as well. Future studies should be focused on correlating the results from multi-site, multi-city studies to prove albumin as a reliable indicator of postoperative surgical stress. A larger sample size should be selected for better understanding. False positive and false negative are to be addressed with more sensitivity, reliability, validity, and specificity. Testing in larger patients is required and also in other critically ill patients. Translating these findings into a decision-making protocol for therapeutic procedure is important. These are the references. Thank you.
Thank you, Dr. Vinay Kumar. My first comment is that there is too much material on your slides and your introduction has been very long on this subject. My first question to you is why only 18 years and above is selected in your particular category?
Usually we take the adult patients only,
okay,
who can tolerate the surgical stress. Younger patients may be due to their build and other causes.
And your 28% of surgical site infection you attribute to lower serum albumin or anything else?
So 28%, ma'am.
Yeah, isn't it high? You are doing
Yes,
clean contaminated surgery.
Yes, sir. Yes, ma'am.
28% surgical site infection.
It's a bit high, ma'am.
High, isn't it? So
Yes,
there is always a need to go back and find out what exactly could be the cause.
Yes, sir. Actually, that's why, ma'am, this is a hypothesis only. The actual study we have to do in a multi-site, multi-city center with larger number of patients. We have taken only 50 patients. So sample size is also low, ma'am.
Okay. And the last question is, what intervention, suppose you have found a low serum albumin, would you
Yes,
like
ma'am.
to wait and then, because you're expecting a 28% complication rate,
Yes, ma'am.
would you like to improve the serum albumin and then go ahead? Because these are all clean and clean contaminated are
Yes,
mostly.
ma'am. We'll try in case of elective surgeries. We'll try to maintain the serum albumin by transfusing either 3.5%, 20% albumin, depending on the cases. And after normalization of albumin, then only we'll proceed for the surgeries.
Okay. Okay. Thank you, Dr. Vinay Kumar.
Thank you,
Can we
ma'am.
have the next speaker, please? Who is the next speaker?
Next is Dr. Siddharth Singh.
Siddharth Singh Arora. Dr.
Yes,
Siddharth
ma'am.
Arora.
I'm sharing the screen, ma'am.
Yeah, sure. Go ahead.
One minute, one minute, sir. 1 minute. Yes, sir. Can you share again?
Um,
Can you open the camera, sir?
is my slide visible?
Yeah, we can.
Good afternoon, faculties. I am Dr. Siddharth Singh Arora from NKP Salve Medical Institute and Lata Mangeshkar Hospital, Nagpur. I am doing this study under the guidance of my guide, Dr. B.S. Gedam. My topic is cholelithiasis, clinical profile management, and chemical analysis of gallstones, an observational study. Introduction. Gallstone disease continues to be one of the major reasons of abdominal pain. The basis of gallstone disease is the compromised metabolism of bilirubin, cholesterol, and bile acids that is associated with the development of gallstones. Gallstone may be responsible for various complications if not treated. Prevalence of cholelithiasis is greater in females than in men. In India, the prevalence is common in North India population as compared to South Indians, followed by Maharashtra, mainly from coastal regions. About 80% of the patients suffering from cholelithiasis continue to be unaware of their disease, and approximately 1 to 2 patients every year develop complications because of unawareness and require surgery. There are research publications conducted which have assessed the clinical profile, etiology, and clinical presentation and management of gallstone. However, many of the studies have not assessed all these parameters in a single study. Moreover, the chemical analysis of gallstone has not been given much importance, in spite that they could give an insight into pathogenesis and presentation. Considering all the above mentioned factors, we decided to evaluate the clinical profile, management, and chemical analysis of patients with gallstones at a tertiary care teaching hospital in the Department of Surgery. This study tried to have an holistic approach on gallstone so that strong evidence can be generated from India, taking into an account all the aspects of the disease. Aims and objective. To study the clinical profile and management of cholelithiasis and to study the chemical analysis of gallstone. Material and methods. My study design was an observational study, and my study population was all the cases admitted to a tertiary care center and diagnosed with cholelithiasis. Inclusion criteria. All cases admitted in surgical wards with cholelithiasis and treated by surgical procedures. Exclusion criteria was age less than 18 years and patient not consenting for study. Study factors, demographic factor, clinical features, laboratory, and imaging investigation and management. Observation and results. My total number of cases was 64. Demographic factors. Age. Mean age was 42.64 years plus minus 11.5 years. 32 from the age group of 41 to 50 years, followed by 17 in the age group of 31 to 40 years. Gender. 44 patients out of 64 patients were females. Clinical features. Most of the patients presented with right upper quadrant pain, 60 patients, which were followed by nausea in 43 patients and dyspepsia in 39 patients. Jaundice was observed in 13 patients who has associated corn bile duct calculus. 39 patients were having BMI more than 25. 4 patients had hypothyroidism, 14 patients were diabetic, and 13 patients were suffering from systemic hypertension. Although the comorbidities was not significantly associated with the etiology of gallstones. Outcome. Laparoscopic cholecystectomy was done in 51 patients with a conversion rate of 5 patients. Total 16 patients were operated by open cholecystectomy. A total of 13 patients had CBD calculus, out of which 8 patients underwent open cholecystectomy with common bile duct exploration, and 5 patients had ERCP guided stone removal followed by laparoscopic cholecystectomy. Post-operatively, surgical site infection was seen in 5 patients of open cholecystectomy, and bile leak was seen in 2 patients of open cholecystectomy. Histopathology of gallbladder. Chronic cholecystitis was observed in 62% of patients. Malignancy was detected in 1 patient and xanthogranulomatous cholecystitis in 1 patient. Gallstone analysis. Mixed type of stone is more common than cholesterol and pigment stones. 2 patients had post-operative biliary leak. When the post-operative complication between the 2 modalities of treatment were compared, there was no statistical difference seen in wound infection or biliary tract leak or post-cholecystectomy syndrome. Discussion. Laparoscopic cholecystectomy is a feasible and safe procedure even in most cases of acute cholecystitis, albeit the conversion rate. The conversion rate from laparoscopic to open cholecystectomy was about 9.8% of the total attempted. Factors associated with the need to convert may be duration of symptoms, severity of the disease, complication associated with cholecystitis, and pathology of the disease. Conclusion. We conclude that cholecystectomy occurs in middle age, mostly in 5th decade, and more in females than males. Right upper quadrant pain, nausea, and dyspepsia are the major clinical presentation of the gallstone. Mixed type of stone is more common than the cholesterol and pigment stone. Wound infection and other complications were more predominant in open cholecystectomy group than the laparoscopic cholecystectomy. Laparoscopic cholecystectomy was better than the open cholecystectomy. Thank you, ma'am.
Can you just focus on your first slide, the title of your slide? Okay. What was the chemical analysis of the gallstones?
Ma'am, we have done a qualitative analysis of the gallstone. We have sent the gallstone and for analysis of cholesterol, bilirubin, and various salts, calcium salts, so potassium and magnesium levels, and phosphorus levels to observe the analysis.
No, did you come to any conclusion like these particular stones cause severe gall severity, more severity, and less severity, or something? Did you come?
No, ma'am. It was not statistically significant. But severity was not detected. But we got a cholesterol gallstone were mostly a single gallstone, and multiple gallstone were detected in mixed type of gallstone.
Okay. And who was bearing the cost of this particular test? Were you doing it in your hospital or you sending it outside? And the cost factor involved?
I'm a cost factor was actually cost is actually much more, but we are doing a large number of cases, then the cost has significantly reduced, around 200 to 300 rupees per patient.
But who was bearing the cost? The patient was paying for this, or you were getting some grants for this or something?
Ma'am, we have some cholelithiasis was plans, ma'am, actually. So it was included in that.
Okay. Okay. Thank you, Dr. Sidak Singh. Yeah, the time is up. Any other speakers? Who's the next speaker?
Yes, Dr. Kantiraj, Dr. Kantiraj.
Yes, sir.
Please share your screen.
Yes, sir.
After this, Dr. Nikhil Pawan.
Yeah, Dr. Nikhil Tumati.
Yes, ma'am.
Yeah.
Good afternoon. I am Dr. Nikhil from Mahatma Gandhi Medical College, Pondicherry. My guide is Dr. K.V. Rajan and my co-guide is Dr. Prabhu. My paper is a comparison of bipolar diathermy and conventional techniques of hemostasis in thyroidectomy. Coming to the introduction, thyroid is a highly vascular organ with around 5 times its weight blood supply, and it's a small operative field. So hemostasis is of utmost importance, meticulous hemostasis. Conventional methods are mainly so-called clamp and tie, clamping by sutures or clips in some cases. They have worked well since Koch's time, but there is always a risk of foreign body slip reaction or knot slippage. And another issue, they are said to take more time, relatively more time. And later, diathermy is not a new thing. We all know the diathermy and its effects of coagulation. Advanced energy devices are slightly advanced versions of diathermy. They are ultrasonic shears and advanced bipolar diathermy, two are there. So with the advent of lap surgery and its this minimally invasive trend catching up to thyroid, this axillary thyroidectomy and all took place, and advanced energy devices were also propelled into this. But and a name called sutureless thyroidectomy has been given to them, and they have found to reduce the operative time and in some cases even post-operative complications. But those studies are from high economy countries, whereas ours is a low resource setting. In many colleges or in many centers, we don't have these advanced energy devices. Even if they are there, they are charged separately, and Indian patients usually won't be affordable for the same. So a study is to compare outcomes between patients undergoing thyroidectomy with bipolar diathermy and conventional hemostatic techniques, so that we can use bipolar diathermy in the place of advanced energy devices. So objectives, obviously we compared the operative blood loss. Apart from them, hematoma, RLN and superior laryngeal nerves injury and hypocalcemia have been taken. So research hypothesis, bipolar diathermy is safe as conventional technique of hemostasis. So exclusion criteria, bleeding diathesis or coagulopathy or patients less than 16 years of age. Then, so the study is a comparative study, and after consulting with statistician, the sample size of 32 has been decided with patients divided into two groups. One will be the test group, where only bipolar will be used for cauterization of vessels without any ligatures. The other one is the control group, where ligature supplemented by bipolar or without supplement may be used. Allotment of patient into groups was based on the discretion of the operating surgeon. So preoperative ideal evaluation was done for all patients, and written and informed consent was taken for the study. And so you can see here, we are cauterizing the vessel with bipolar instead of applying sutures. Then, so intraoperative blood loss. So we had a standard reference weight for all sizes of gauze pieces available in our hospital, and post-op, the gauze pieces which were used, including mopping pads, they were weighed on a sensitive balance, and based on that, the difference of weight was taken, and based on that, intraoperative blood loss was calculated in grams. Hematoma, we relied on clinical examination to detect any hematoma. Then hypocalcemia also, we relied on clinical examination. Only in patients who were clinically hypocalcemic, we went for a lab test. Then for voice, similarly we relied on voice change for nerve injury, and we followed the patient for up to 3 months to detect any voice change, of course on OPD basis. Statistical analysis was done with SPSS version 19 software. So coming to the baseline characteristics, in our study, due to small sample size, we were able to take all females in both test and control group. No males were included. No males happened to be included in the study. Coming to age, the mean age of control group was 41.5 and test group 38.7. This shows a p-value of 0.5. So the age difference is not significant between both the groups. But our population is significantly younger than many of the reference studies, where mean age was at least above 50 in most of the studies.
Diagnosis, various diagnosis, STNs were there, MNGs were there, but the p-value was 0.3, again not significant. And we took several surgeries, almost all types of surgeries, but p-value is again 0.3, which is not significant. But most of the studies which studied this sutureless thyroidectomy mainly took total thyroidectomy for study. We took all sorts of operations. Then regarding hypocalcemia, its absence and presence percentages, it was, as you can see, it's significantly lower in the test group, and p-value came as 0.01, which is statistically significant. So hypocalcemia incidence was lesser in the test group, that is bipolar group. And similarly, voice change, incidence of voice change was significantly lesser in the test group, 81.3%. So, and coming to intraoperative blood loss, mean intraoperative blood loss in control was 86.7. The values are in grams, whereas in test it is 63.5. P-value of 0.001, a statistically significant reduction in bipolar group, the biggest advantage perhaps in our, according to our study. So coming back to the outcomes, hypocalcemia and intraoperative blood loss, these two show a significant reduction, a statistically significant reduction in the test, that is bipolar diathermy group. Then the limitations of this study, the study is not randomized. It's based on discretion of the operating consultant, and several consultants are involved. So experience played a role. All are of female gender. Many of the reference studies, almost 90 to 95% population was female, but ours 100% was female. It is important because males usually have malignancy with high vascularity, and this metal needs to be proven more in males. So coming to reference studies, one was done by Rajendran CV et al. In Tamil Nadu. There were hypocalcemia was compared and no statistical significance was noted between bipolar and conventional group. Another Su L et al. Here they prove, according to this is the only study which said bipolar diathermy is safer than advanced energy devices, and there is a reduction in incidence of post-operative complications. Then this is Koshan Pei et al. Somewhere in Scandinavia. It showed no significant incidence of post-operative complications. Tysom JR et al., one of the earliest study on bipolar, it showed no statistically significant difference in the incidence. Das AT et al., another Indian study, bipolar diathermy, and here advanced energy devices were compared and no significant difference was noted. Conclusion is bipolar diathermy is a safe and better technique compared to clamp and tie technique, and can be applied in the lesser centers, but wider range of studies on randomized population and including males are required, and malignancies before widespread application. Thank you.
Thank you, Dr. Nikhil. Dr. Nikhil, thank you.
Thank you.
Your slides have been good with adequate material. Then I just wanted to know whether you have chosen the size of the gland for this by dividing the patient for a particular procedure. The size of the gland.
No, ma'am, we didn't take the size of the gland into account, ma'am.
Okay.
The allotment of group was totally under discretion of attending surgeon.
No, what was it like? You know, it is a personal choice, or is it
personal choice, ma'am?
Okay.
Personal.
Okay. And then regarding the size of the vessel ligated, what is the maximum size of the vessel you have used energy source?
We used bipolar for all the vessels of all the patients in test group, ma'am. Superior, inferior, and all the vessels. I even have video of one of the surgeries if I'm permitted.
Okay. And then what about the lateral current that causes injury? Don't you think using it for bigger vessels, and then you're not
Yes,
very sure, you go back, there is a bleeding. So what do? You hold it with an artery initially, and then you do a cauterization, or you just directly hold it and cauterize, especially the larger vessels?
Yes, ma'am. Ma'am, we held the vessel and lifted it up while cauterizing, and we cauterized, ma'am. We didn't hold it with an artery, but we lifted from the operating field.
And then you said that hypocalcemia is less with the bipolar injury, bipolar.
Yes, ma'am.
How do you explain this?
We were actually not sure, ma'am, because except I think Suel et al, there was no difference in hypocalcemia found in other studies. What we thought was suture while knotting the vessels or some extra blood has been slipped. That could be one reason. And another thing, this consultants agreeing to this bipolar, they'll be usually will be relatively senior surgeons compared to SRs or APs who will be little apprehensive, ma'am. So it could be the experience factoring into reduce hypocalcemia.
Okay, thank you, Dr. Nikhil, for the nice presentation.
Thank you.
Dr. Kantiraj? Yes, sir. Full screen चाहिए सर. Let's sir. Yes, sir. Yes, sir. Next slide, sir. Check. Only check. Dr. Kantiraj? Okay, sir. Please unmute yourself. Dr. Kantiraj? Dr. Kantiraj, please unmute yourself.
Yes, sir. I am audible, sir?
Yes. Please carry on.
Yes, sir.
Very, very screen.
Yes, sir. Hemorrhoids are common. Yes, I am Dr. Kantiraj Pawar, junior resident from Government Medical College, Aurangabad, hereby presenting the paper on comparison of efficacy between sclerotherapy versus band ligation of symptomatic first and second degree hemorrhoids under the guidance of Dr. Sarojini Jadhav, professor and head of department, Government Medical College, Aurangabad. Hemorrhoids are common surgical conditions of anorectal area resulting in significant subjective discomfort. Very few people do not suffer from symptoms of hemorrhoids, and only few report to their doctor before having resorted to self-medication with proprietary preparations. The common anorectal complaints from the patients suffer from hemorrhoids are bleeding, discomfort, protrusion, discharge. The common therapies available for grade 1 and grade 2 hemorrhoids or OPD basis are infrared coagulation, bipolar diathermy, direct current therapy, cryotherapy, rubber band ligation, and injection sclerotherapy. Hence, comparative study was conducted to compare the efficacy of rubber band ligation over sclerotherapy in grade 1 and grade 2 hemorrhoids in our institute. My aims and objective to study the efficacy of sclerotherapy versus band ligation of symptomatic first and second degree hemorrhoids, to compare the rate of cessation of bleeding, reduction or cessation of pain, and complications. Methodology: it is the randomized prospective comparative study. The study was conducted in Tertiary Care Center in Government Medical College, Aurangabad. Sample size is 120, out of which we divided the total number of patients, including the present studies, 120. Among them, 60 patients were randomly selected for each group. One is going from this rubber band ligation and another one's for sclerotherapy. All the patients were observed after procedure and they were reviewed after 1 week, 3 weeks, and 6 weeks and 9 weeks, respectively. Inclusion criteria: symptomatic, bleeding per rectum, grade 1 and grade 2 hemorrhoids. Male and female patients of all age group with complaints of bleeding per rectum where causes grade 1 and grade 2 hemorrhoids were included. Patients where cause of bleeding per rectum is other than hemorrhoids, such as a fissures, fistula, malignancy, etc., are excluded from the study. Asymptomatic grade 1 and grade 2 hemorrhoids, grade 3, grade 4 hemorrhoids, and those patients are not willing for any procedures were excluded from the study. Results and summary. The mean age of total study population is 30.5 plus or minus 4.5 years. Highest incidence was seen between 26 to 35 years of age, which is similar as study conducted by Johansson et al. And Hess et al. their incidence was second and third decades of life. However, the study conducted by Ayman and Kylie et al. And Rees et al. They shows equal sex distribution. In my study, there is a male preponderance that is 3.8 as to 1 as compared to other, that is Ayman et al. And Kylie et al. They shows the equal sex distribution. The per rectal bleeding was the most common. Per rectal bleeding was the most common symptoms. Per rectal bleeding 97.05%, followed by pain and discomfort, that is 30.8%. Per rectal bleeding was also the most common presenting complaints in between the studies conducted by Gracia et al., Rees et al., Selviraj et al., and Emeka et al. While discomfort is presenting symptoms in the study conducted by Grace et al. Emeka Reoff. Itching and pruritus was the major complaints in the study conducted by Rees et al. And Selviraj. All the patients were observed after procedure, and they were reviewed after 1 week, 3 weeks, 6 weeks, and 9 weeks. On first follow-up on day 7, in the group which underwent banding, 19 patients, that is 31.6%, had bleeding compared to the sclerotherapy group, which shows bleeding in 20%, in a 20 patients, that is 33.33%, which was not statistically significant with p-value, that is p-value is 0.5. Banding group had pain in 21 patients compared to the sclerotherapy group, which had pain in 16 patients, which was statistically not significant. P-value is 0.215. At the second follow-up, after 3 weeks, all patients were observed. Bleeding present in 10 patients and 17 patients in the rubber band ligation and sclerotherapy group, respectively, which was statistically significant. P-value is 0.095. Banding group shows pain in seven patients, and sclerotherapy group shows pain in 14 patients with p-value 0.074, which was statistically significant. At the third follow-up, patients were observed in a band ligation group. Bleeding was stopped in 56%, with bleeding in only 6% patient, and pain in 3%, 3 that is 5%. In sclerotherapy group, bleeding stopped in 16 patients, bleeding stopped in 19 patients, that is 63.33%, with bleeding in 6 patients, that is 20%. Pain in 14 patients with statistically significant p-value. At the fourth follow-up, at a 9-week, bleeding were noted in 2 and 10 patients for rubber band ligations and sclerotherapy group, sclerotherapy group, which shows that the rubber band ligation is superior as compared to the sclerotherapy. Then we compare the post-procedure complications such as the recurrence, infections, acute urinary retention, anal stenosis, and perineal cellulitis. So most common complications following either procedure was recurrence. The total 14% had recurrence. Out of these, 3 had undergone rubber band ligation and 11 had undergone the sclerotherapy. This was statistically significant. P-value is 0.01. Out of 3 patients undergoing recurrence following rubber band ligation, 2 had slippage of band. A reprocedure was needed in all 3 patients. Similar rates of recurrence was seen in study conducted by Badrivaran et al., Gret et al., Panda et al., and Vegasi et al. Post-procedure infection, rates of post-procedure infection were equivocal in both groups in our study. 2 patients undergoing rubber band ligation and 3 patients undergoing sclerotherapy had post-procedure infections. Equivocal findings were found in conducted by Greboyne et al., Walker et al., and Guy et al. However, study conducted by Gaiman et al. Shows statistically significant post-procedural infection in patients undergoing sclerotherapy as compared to patients undergoing rubber band ligation. Post-procedure urinary retention. In our study, only 1 patient experienced post-procedure urinary retention following by rubber band ligation, while 0 patients present urinary retentions in the sclerotherapy group. So So perineal cellulitis and anal stenosis were not reported in the study. Conclusion: hemorrhoids of grade 1 and grade 2 can be effectively treated with rubber band ligation and sclerotherapy. Both procedures are equally effective, though our study shows significant advantage of rubber band ligation over injection sclerotherapy for cessation of per-rectal bleeding and pain. Therefore, as a treatment of choice for grade 1 and grade 2 hemorrhoids, rubber band ligation is highly recommended over injection sclerotherapy. However, since the number of patients included in the study were less, to arrive at a conclusion, further studies are required with large population group. Thank you.
Okay, thank you, Dr. Kranti Raj.
Yes, ma'am.
You did these procedures as an outpatient or an inpatient?
Ma'am, as an outpatient.
Outpatient procedures. And
Yes,
can you
ma'am.
explain why the pain factor was more in your sclerotherapy group?
Ma'am, by using the injection pylonidal canal, which is a local irritant. That's why patients had a pain in the sclerotherapy group compared to the rubber band ligation group, ma'am.
And then what did you do? When did this band slippage occur? What was the particular day, or was it after 1 week, or when was it? And how was it? Was it a heavy bleeding or what?
Only 3 patients were reported, out of which 1 patient reported within a 1 week, and 2 patients were reported after the 2 weeks.
But then would they have not got thrombosed that you had to put a band once again?
Yes, ma'am. Yes, ma'am. I had to put the bands once again, ma'am.
Will they have not undergone thrombosis by that time?
Ma'am, one patient's the slippage of band is within a 1 week, but there is a slight thrombosis, ma'am, in other 2 patients, ma'am.
Okay. And what is the mechanism of the reduction of hemorrhoids in these two, in sclerotherapy and this?
In sclerotherapy, we use an pylonidal canal agent. It causes the chemical reaction around the tissue, and that's why there is a thrombosis of that tissue, and that will lead to slough off. In rubber band, rubber band also causes the mechanical irritations, and it compresses the vessel which are which supplies to the hemorrhoids. So,
and what is the precaution you take while injecting the sclerotherapy agent? Where do you exactly inject the sclerotherapy agent? What is the site of
ma'am, by proctoscopy, we first visualize the hemorrhoids, and after visualization of hemorrhoids, at the base of the hemorrhoids, we inject the pylonidal canal, ma'am.
What is the precaution you take? Will you inject above or below the dentate line?
Yes, ma'am, below the dentate line.
Will that not cause a problem, anal stenosis then?
No, ma'am, it's above the dentate line. No, sorry, ma'am, it's above the dentate line.
Thank you, Dr. Kranti Raj.
Yes,
Any
ma'am.
other
Yes, ma'am.
presentations?
हेलो जो पहले वाला जो आईडी है उससे लॉग आउट
Dr. Nas?
Yeah, I'm here.
Ma'am, all speaker is completed.
Yeah, okay. Thank you. Thank you.
वो डालेंगे और उसके बाद सर पासवर्ड आएगा 1 2 3 तो मैंने कहा 2 दिन पड़े हैं नए शर्मा और बीबी साथ दीजिएगा वापस वहीं मिल जाएगा मैं यहाँ से आपको ओके ठीक यस सर आ रहे हैं मैं यहाँ से आपको प्रमोट कर दूँगा आपका प्लान ओके सर थैंक यू
ये अपने यहाँ कंप्यूटर पे कर दिया कि सब
यहाँ सब कंप्यूटर में नहीं है कंप्यूटर पे नहीं है लाल साहब ने तो कर लिया था उस टाइम
कर लिया था तो कर ले तेरे
बहुत ज्यादा कब पिलाओगे इनकी बाद में शाम को करते हैं ले भाई तुझे कैसा है
अरे स्टेशन 4 किसके पास है यार कौन है यहाँ का इनके इसमें 2:30 बजे को अमित कुमार मिश्रा है उसको आईडी भेजो यार वो ज्वाइन नहीं कर पा रहा
कोरोना दरवाजे में चले गया वो बोलेगा भेज दे तो कतई दवाई चाहिए दरवाजे पे बोला बात नहीं तो सालों
क्या अगर आपका बंदा मेरे को फोन कर रहा है उसको आईडी भेजो ना तो बंदो ज्वाइन नहीं हो पा रहा मेरे यहाँ से प्रेजेंटेशन खत्म हुई है ना उसकी भेज नहीं रहे इन पे गलत लिंक गलत पहुंचा ना सब पे लिंक मेल पॉजिटिव क्या करूँ
ये तो भाई साहब हमने ये वाला जो ऐप था सुनो ये वाला ऐप जो हमने डाउनलोड कर रहे हैं इससे मतलब क्या वो पता लगता है अगर तुम्हें होगा तो ये तुम्हें दिखाएगा कि इसको है फिर
आपके आसपास दिखा देगा
आसपास ही कैसे दिखाएगा
अगर उसके पास ब्लूटूथ होगा तो
है
मेरे को हुआ था ना
हाँ
तो मेरा नंबर उसमें चढ़ गया तो उन्होंने मेरे नंबर पे डाल दिया कि डिवाइस ये बंदा जो इस नंबर का जो बंदा है वो कोविड पेशेंट है
जैसे मेरा अभी मैंने
अब मैं मोबाइल जहाँ जाना मैं जहाँ जाऊँगा तो जिसका ये जितनी भी तरह जा रहा है वो सबने मोबाइल को दिखाया सारे डिवाइस मेरा रेड हो गया था
मैंने अब मेरा
अभी नहीं पहले जब मैं था
मेरा भी ब्लूटूथ मैंने लगा रखा इसमें कनेक्ट किया हुआ ना तो ब्लूटूथ वो करना था यस करो दोबारा उसने मेरा नंबर मारा मैं ASICON 2021 को कंप्लीट मैं बोल रहा हूँ आपका पेपर प्रेजेंटेशन है तो मैंने यस मैम जो अभी आपको टेस्ट मार दिया
अनम्यूट का मतलब है कि अब मैं ऑडिबल हूँ
यहाँ से वीडियो ऑन होगा
यहाँ से वीडियो
ऑन हो गया सर यहाँ से जैसे मैं दबा दूँ सर
तो ये वीडियो
काटा का मतलब कट होगा वीडियो
ठीक ठीक
ये सर फुल स्क्रीन यहाँ से
फुल स्क्रीन यहाँ से
ये सर यहाँ आ जाएंगे सारे एक आ चुके हैं सर
हेलो
हेलो
हाँ डॉक्टर गोयल
हाँ गुड इवनिंग सर
गुड इवनिंग सर सर मैं मनोज बोल रहा हूँ सर
मनोज गुड इवनिंग
हाँ सर 2:45 पे स्टार्ट करेंगे सर
हाँ वेलकम मनोज वेलकम
Okay, I am ready.
Okay, sir.
Thanks. 2:45 कितना टाइम लगा?
अभी तो पूरे 2:30 बजे सर, 15 मिनट बाकी सर।
अच्छा अच्छा।
लास्ट कब है सर अपना खरीदिए सर?
क्या?
लास्ट कब है सर?
लास्ट आज है।
अच्छा आज ही है सर।
हाँ बस देखो।
जल्दी से बोल दो कि काढ़ा वाड़ा ले लें।
चलो फिर मतलब 10 मिनट में इसमें से देख लेता हूँ क्या कुछ थोड़ा है।
यस सर। यस सर।
उससे क्या
अभी
होता है?
बाकियों को अपना कुछ दिखेगा नहीं सर अभी।
अच्छा अच्छा
यस
ठीक।
सर।
test.
क्या बोले? Hello, coordinator.
Yes, sir.
Mine was first to present. Should I share screen or station one?
But he said, no. This is station 4.
But the other in the station one, the coordinator told me to you have in station 4. It has been changed.
No, sir.
3-4 minutes.
No change, sir.
So mine is station 4 now.
This is station 4.
Should I share or screen?
No, सर आपके यहाँ पे एक नंबर फर्स्ट नंबर पे देवेंद्र बहल है.
ओके.
आपका तो कोई नाम नहीं है इस लिस्ट में.
नहीं है.
नहीं सर. डॉक्टर साहिल सचदेवा
है या नहीं है?
नहीं है.
तो फिर मैं वापस स्टेशन 1 ही ज्वाइन करूं?
जी. आपके प्रोग्राम में कहाँ पर है आपका?
मेरा मेल में मुझे यही बोला गया था स्टेशन 1 है, और अभी जो स्टेशन 1 वाले पीपल है दे टोल्ड मी इट इज स्टेशन 4.
नो सर.
ओके.
स्टेशन 4 में नहीं है आपका. कौन है? डॉक्टर साहिल सचदेवा.
हाँ जी.
स्टेशन 1 में.
ओके, थैंक यू.
डॉक्टर अमित कुमार मिश्रा. डॉक्टर अमित कुमार मिश्रा.
Sir, yes, sir.
Please share your screen.
Yes, sir. Yes, sir.
डॉक्टर गोयल
मतलब अभी ये वहाँ चालू है।
डॉक्टर गोयल
क्या
बाकी लोग
अच्छा अच्छा, ये एक तो डॉक्टर प्रतीक चौधरी हैं और कौन? हाँ ये सर, गुड आफ्टरनून सर।
सर गुड आफ्टरनून सर, स्टार्ट करें।
यस यस प्लीज।
डॉक्टर अमित कुमार मिश्रा फर्स्ट
ओके ओके सर।
ये सेकंड स्पीकर है डॉक्टर अमित कुमार मिश्रा।
हाउ मेनी जजेस आर देयर सर?
5 स्पीकर है सर।
Good afternoon, sir. Good afternoon, sirs.
Hello.
Very good afternoon, sirs.
Good afternoon. Good afternoon. Good afternoon.
Yes, sir.
Okay,
Sir,
start.
Yes, sir. Sir, good afternoon, sir. I'm Dr. Amit Mishra. My topic is prospective comparative clinical study of onlay versus sublay mesh repair in ventral hernias. The aim of my study is to compare the onlay versus sublay mesh repair techniques for the ventral hernias in the patient coming in our hospital. The objective being, the primary objective being to compare the outcomes of the onlay mesh repair versus sublay mesh repair techniques in the ventral hernias in our hospital. The secondary objective being the patient being operated by both the techniques to be assessed for the post-operative pain by the vasoscope for the duration of the hospital stay, for the time required to return to the primary activity or the basic activity or the ab initio level, and the complications related to the hernia surgery in the form of seroma formation, hematoma formation, wound infection, and recurrence. Material and methods. The patients reporting to the general surgery OPD of our hospital, Sharda Hospital, with a ventral hernia were included in the study. The sample size was calculated by using the World Health sample size formula calculator with a power of test of 1 minus beta equals 95% confidence limits. The level of significance was 5%, and the population standard deviation was taken as 41% standard value. The population variance was standard deviation is square. So the sample size formula came out to be, which is a standard one, is n equals z square p bracket 1 minus p divided by e square, where z is a constant, where z is a constant of 1.96. The p is the prevalence value and e is the error, which is also known by precision. The 1 upon precision comes out to be the standard error. The prevalence for the ventral hernias was 3.7 to 28% in the previous studies and the literature review. Our institutional previous year's surgery record evaluation and assessment concorded with our upper value of the range of prevalence, that was 3.7. This means to say that our hospital has got a prevalence of 3.7%, and with the using of a 3.7%, it was rounded off to make 4, and it was utilized to get the value, and it was found that using an absolute error of 5%, which is a universal standard, the sample size came out to be 59 point something. So we concluded as the 60 patients in the sample size, making into T equal halves 30 and 30. And the material and methods continued. The inclusion criteria included all adult patients of all genders coming with a ventral hernia diagnosis, which were surgically fit, were included in the inclusion criteria. Exclusion criteria included the patients which are pregnant, female patients, or the patients which are terminally ill, the patients presenting with concomitant malignancies, the patient having widespread collagen diseases, patient having an already diagnosed and taking a treatment of antiretroviral therapy, patient having an active and open pulmonary tuberculosis cases, patient having a treatment for the anti-neoplastic therapy, or the patient having a diffuse skin diseases were excluded. Material methods continued. The study design was prospective, analytical, and a randomized study, and the population was the patients admitted in our hospital setup with ventral hernia diagnosis, fulfilling the inclusion criteria of taking only the informed consent. The pre-op work was done, and the patients were taken for the surgery only if they were fit under the informed consent. The patient were randomized into 2 groups by the closed envelope methods. Group A, in which the patients were operated by the onlay mesh repair, and the group B, in which the patients were operated by the sublay mesh repair. The patients were then followed by the post-operative pain on day 2nd, day 7th, 1st month, and the 3rd month using a visual analog scale. The mean hospital stay in the days was calculated. The return to the basic activity in days was calculated. Complications including the seroma, hematoma, surgical site infections, and recurrence was noted. Material and methods continued. The data collection and the assessment method, the data collected were entered into the proforma, tabulated, and analyzed using the software package for the statistical analysis, that is SPSS 2015. The follow-up data was obtained during the return visits at 3, 6, or 12 months, or whenever the patient has a complaint or was having a problem. The method of the measurement and the outcome of interest was that the mean and the standard deviations were calculated for the quantitative variables like age, gender. The qualitative variables like the wound infection, seroma, hematoma formation were recorded in the terms of frequency percentage. Chi-square test was applied for the qualitative variables. Independent sample t-test was applied for the quantitative variables. A p-value of less than 0.05 was considered as a significant one. The results. The surmising results were that the total of 60 patients in the study, they were divided into two groups of 30 patients each. The patients included 42 females, coming out to be 70% of the total group, and 18% and 18 were the males, that is 30%. The female to the male ratio was 7:3 in our study. The mean age of the patient was found to be 41.95 plus minus 9.11 years. Range was 28 years to 65 years. The mean age was 40.95 plus minus 9.6 years, range being 28 to 65 years of the patient in the only mesh repair, and it was 42.95 plus minus 8.6 years, range 34 to 64 years for the sublim mesh repair. Out of 60 patients, 10 have got the epigastric hernia, that is 16.67%. 16 has paraumbilical hernia, 26.67%. 14 cases have umbilical hernia, 23.33%. And 20 cases have incisional hernia, 33.33%. The complications were observed in 12 patients, that is 40% in the onlay group versus 6 patients, that is 20% in the sublay group. The p-value about the complications between the two groups was statistically significant, that is the p-value was 0.02. There were two cases, that is 6.67% of SSI, surgical site infections in group A, that is the onlay, which was managed conservatively by IV antibiotics. There was one case of 3.33% of SSI in the group B. The difference between the two groups was statistically insignificant as the p-value was more than 0.05. Results. Again, the seroma formation, which was the commonest complication among all the complications, was observed in 11 patients, that is 18.33%. Seroma formation occurred in 8 patients in group A, 26.67% versus 2 patients in group B. The significance being statistically significant, that is 0.03%. Seroma cases were managed by opening of the stitches, draining of the seroma, drain placement, and secondary closure of the wound. Whenever required, the drains were kept until the drain output became less than 25 ml in 24 hours with a clear or a serious discharge only. Hematoma formation was observed only in 3 cases, that was 10% in onlay mesh repair versus 4 cases, that is 13.33% in sublay mesh repair. The difference was statistically insignificant. Because the p-value was more than 0.05. The duration of hospital stay was average 3 to 4 days in group B, that is the sublay mesh repair, compared to the average hospital stay of 3 to 5 in the group A. And obviously, it was also found to be insignificant. In the group B, the drain removal after 3 to 4 days was taken, and in small defect cases, the drain was removed just in 2 to 3 cases, depending upon the amount of discharge. But in the group A, the drain was removed after 2 to 5 days, except for the large incisional hernia, where the drain was removed even after 10 days by calling the patient on the follow-up discharge. This is the pie chart distribution showing the gender. That is the blue area showing the females, and this orange area showing the males. This is the bar diagram showing the different distribution of the types of the ventral hernia. That is the incisional being the maximum cases, then being the paraumbilical, then coming the umbilical, and then last with the epigastric. This is the SSI occurrence in the onlay versus sublay in the study of ours. The seroma formation, which was more in the onlay than as compared to the sublay. Hematoma formation was more in the sublay, but the difference was not found to be statistically significant. The discussion parts comes. The most patients in our study was found to be females because of the previous gynecological surgeries, like a cesarean section or the hysterectomy or the ectopic pregnancy, leading to a future formation of incisional hernias. In our randomized control trial, 42 out of 60 patients were female. The mean age of the patients was 41.95 plus minus 9. The complications were in 12 patients in the onlay and 6 patients in the sublay group. The difference was statistically significant. The seroma formation, hematoma formation.
Unstable.
So the last line is the hernia recurrence in our study mainly comprised of observing the patient for the short term, and there was no recurrence noted in that short term. The sublay mesh repair is an edge over the onlay mesh repair for abdominal hernia in terms of efficacy, safety, and reliability. And the merits of the lesser frequency of postoperative complications, the sublay mesh repair definitively outweighs the demerits of a longer operative time required for the sublay mesh repair.
Good afternoon, Dr. Wilkinson. Good afternoon.
Good afternoon. Good afternoon,
Dr. Goel here, sir.
Good afternoon, Dr. Goel. Yes.
Good afternoon.
What can I ask a question, Dr. Goel? Hello.
Yes.
Hello. Am I
Dr.
audible? Yes. My question to Dr. Amit Mishra is that you have this study. You're comparing epigastric, umbilical, and incisional hernias. All of them are included in your study, right?
Yes, sir.
Dr.
Sir,
Amit,
yes,
can
sir.
you hear me?
Yes, sir. Yes, sir. Yes, sir. I can hear you, sir. I can hear you, sir.
So all the three epigastric, umbilical, and incisional hernias are included in your study, right?
Yes, sir. Yes, sir.
Okay. So
Yes, sir.
Can we compare all these, put them all in under one thing? I mean, for example, that if you have umbilical hernia, you would expect a smaller mesh, either onlay or sublay mesh. Or in epigastric hernia also, you may or may not even require a mesh. Whereas in an incisional hernia, you'd require a very large mesh. Is it possible to compare all these three different hernias in one study?
Sir, we actually were using a broader term of ventral hernias, and the ventral hernias are the broader terms which included all the three things. And we only took the cases in which we have to put a mesh. Those cases which were easily amenable or easily controllable with a primary repair or a Mayo's repair were not taken in our consideration. We only took the cases in which the size of the defect was significant enough to place a mesh, and we took only those cases which were requiring a mesh hernioplasty. And our broader word was, sir, ventral hernias, which sub-included these things.
Okay, Dr. Amit.
Yes, sir. Yes, sir.
Sorry, Dr. Wilkinson, please continue.
No, it's you ask her.
Okay, Dr. Amit, your sample size comes out to be.
Hello, sir. Yes, sir.
30 patients in each group, isn't it so?
Yes, sir. Yes,
Hello,
sir.
Dr. Amit, am
Yes.
I audible?
Yes, sir. Yes, sir. Yes,
your
sir. Yes,
sample size comes out to be 30 patients in each.
Yes,
You
sir.
should have taken at least 10% extra for design effect, other effects, and losses. Secondly, did you stratified your study for male and female in both the groups?
Yes, sir.
You have not stratified male and female in either of group.
Yes, sir. I have not stratified. I have not mentioned that stratification in the separate groups.
Yeah.
That should be done. And the sample size. Yes, sir. You are right. We could have increased the thing, but we only went with the previous year record as well as the literature survey. And because we were the first PGs of this institution, the PG started.
Okay, Dr. Amit, last question. What is the cause of seroma in so many patients in your study? It doesn't happen after hernia surgery in such a high number of cases. Your cases were 60 in total, and seroma occurred in somewhere around 12 cases. So what precaution was not taken so that it's not that high?
Sir, I think probably because the superficiality of the mesh and the lesser time which was given in the closure or the proper closure in the onlay led to the increased formation of seroma.
I feel if you don't handle the tissues properly, then all these things happen.
Yes, sir.
Okay. Thank you very much.
Thank you, sir. Thank you, sir.
Can we go to next speaker, sir?
Dr. Pitani, Pitanshi, Dr. Pitanshi, Dr. Pitanshi.
Yes, sir. Yes, sir.
You share your presentation.
Yes, sir. Should I start, sir?
Okay, please start.
Good afternoon, sir. I am Dr. Pitanshi Singh from Index Medical College, And my paper is on a case series of patients with COVID-19 developing skin infection and vascular complications requiring surgical intervention. So COVID-19 is an infectious disease with a range of symptoms typically manifesting from illness to severe acute respiratory syndrome, coronavirus 2, with multi-organ dysfunction and death. Individuals with COVID-19 COVID-19 may have number of complex and varied coagulation, which required evaluation and intervention to prevent and treat thrombosis. We report a case series of patients with COVID-19 who presented us with compartment syndrome, DVT, cellulitis, necrotizing fasciitis, diabetic foot, and that all these were complicated by venous and arterial thrombosis, which required immediate surgical intervention. My aims and objectives of patients with critical threatening ischemia or infection. Also, my aim of a case was to analyze the possible relationship between the infection and the diabetic foot ulcer. This case series also facilitates us our understanding of this complex disease, giving emphasis on the vascular manifestations so that we may better be equipped for the next pandemic. So my case materials methods, these are case series of 8 patients with COVID-19, which were confirmed with RT-PCR patients admitted in our ICU. They presented us with various signs and symptoms due to various reasons comprising of cellulitis, necrotizing fasciitis, compartment syndrome, DVT, which were confirmed with various investigations, which I'll be telling you in my next slides. For all suspected cases of COVID-19, collection of upper respiratory tract specimens were done and they were confirmed with RT-PCR. CBC, serum electrolyte, blood sugar levels, urea creat, PT-INR, D-dimer levels, C-reactive protein, ferritin, they were collected routinely, and USG local area color Doppler was done in patients which were suspicious of DVT. We did HRCT test in all inpatients. So these are the characteristics of certain skin infection and vascular complications which were seen in COVID-19 confirmed cases. Like you can see a 54-year-old female, she presented us with cellulitis over left upper limb. She presented us 1 week after the onset of fever and with signs and symptoms of swelling, redness, raised temperature over her right upper limb. She also had a severity of COVID-19 infection like cough and fever. Likewise, there were patients, both male and female, with compartment syndrome. They also presented to us few days after the hospitalization with complaint of swelling, tense skin, absent of pulse over left upper limb and over his right upper limb. Also, there was a patient of necrotizing fasciitis who was 38-year-old male. He also presented us 1 week after the onset of fever and cough with blackening of skin over his arm with pus and blood discharge. And there was also 80-year-old male who presented with diabetic foot disease. Patients with DVT, sir, I would like to tell you about the D-dimer levels which we studied in the patients of DVT, which were quite raised. That is, in patient 1, 550 nanogram per ml, 5 nanogram per ml. In patient 2, 430 nanogram per ml, and patient 3, it was 450 nanogram per ml. Also, PT-INR was raised in all the 3 patients. Yes, we have given treatment, subcutaneous injection of enoxaparin 40 mg OD were given to all the 3 patients of DVT. This was the treatment plan for all the diagnoses. Like in compartment syndrome, we did fasciotomy. For DVT and cellulitis, it was managed conservatively. And for diabetic foot ulcer and necrotizing fasciitis, we did debridement. So for the management of cellulitis, we did blood count and C-reactive proteins. Here also, I would like to tell you that C-reactive protein levels were high, that is 20 milligram per DL, and D-dimer levels were also high, 9.1 mg per DL. Color Doppler was suggestive of cellulitis. The management of necrotizing fasciitis, we observed raised counts with lymphopenia, with systemic infection, with poor glycemic control. Patient was immediately transferred to COVID ICU, and he didn't respond to antibiotics. So we have taken him to OT for exploration debridement under anesthesia. We found extensive gas and tissue necrosis and tissue liquefaction. By that evening, he found to have elevated D-dimer levels, but unfortunately, patient couldn't survive. With compartment syndrome, she presented with lymphocytopenia with platelet counts of 19,000 with elevated D-dimer and C-reactive protein. Her clinical course improved, but she started to demarcate her fingers. Compartment fasciotomy was performed. She remained on therapeutic anticoagulants and prophylactic broad-spectrum antibiotics. For diabetic foot, he had a history of diabetes since 8 years, and his 2 to 3 digits of left foot were auto-amputated. Despite antibiotics, his condition was worsening, and we did surgical debridement with daily dressings with USL, and antibiotics were continued. So you can see the patient with cellulitis. She was admitted in a COVID ICU. We did sumac dressing. Also, this male patient presented with necrotizing fasciitis. This patient was taken immediately to the OT, and we did exploration. So this male patient, 80-year-old male, he presented with diabetic foot, and you can see the compartment syndrome of left arm with the demarcation of fingers. The patient admitted in COVID ICU known to be at risk for thromboembolism. Watch out triad described 3 categories: venous stasis, vessel injury, and activation of blood coagulation. It has been suggested that systemic inflammation induces endothelial injury, which will activate the coagulation cascade and impair fibrinolysis. Still, though causal treatment for COVID-19 has been found, and management for COVID-19 is mainly supportive. Possibly, the virus enters the host cell through binding of the spike glycoprotein to the enzyme ACE2, sialic acid receptor, TMP-RSS2, and CD147. ACE2 enzyme is distributed all over the blood vessel and various organs. This, due to the cytokine waterfall, it increases the blood clotting problems and damage. This condition, which causes endothelial dysfunction, was exacerbated by the hypoxia and causes thrombosis by increasing blood viscosity as well as the signaling pathway associated with hypoxic transcription factor. Finally, the blood clotting can be caused by anything, but still the exact cause of DVT caused by COVID-19 is still unknown. Here is the so I would like to discuss about the diabetic foot, where the diabetes mellitus causes chronic low-grade infection. Cytokine was produced, and it causes imbalance between the pro and anti-inflammatory cytokines, which cause diabetic polyneuropathy, and finally diabetic foot ulcer was caused. Also, the COVID-19 induced coagulopathy, because of which arterial and venous thrombi occur, and this led to peripheral artery disease, and this was also causing diabetic foot. Sir, we would like to conclude by saying that some patients reported with these diagnoses are furthermore complicated by venous thromboembolism after the diagnosis of COVID-19. Blood clots or DVT was caused by injury to veins by multiple puncture, certain medication, and limited movement, of course. To ensure the best possible care to diabetic foot is to give more emphasis on telehealth driven approaches, emphasis on home care. And this case series unravels some complexities of virus, this COVID, severe acute respiratory syndrome, coronavirus 2 infection that can be managed surgically. Thank you, sir.
Dr. Pratansi, what was the lung condition of these patients? HRT was done. Did they reveal infiltration in lung?
Yes, sir. There were infiltration in lung. We did HRCT of chest. Various COVID score were found in the HRCT of chest, sir.
What was the range of COVID score in HRCT?
Sir, maximum were above 20 by 25. Only the 2 female patients who presented with compartment syndrome were found to between 15 to 20.
But is there any mortality in your study, or all became all
Yes,
right?
sir. Yes, sir. Yes, sir. I mentioned in my presentation, sir, one patient who presented with necrotizing fasciitis, the one we have taken immediately in OT, he couldn't survive.
What was the oxygen saturation of your patients? Oxygen saturation?
Yes, sir. Yes, sir. Oxygen saturation maximum was 95% on room temperature, and one was intubated. Only the patient with necrotizing fasciitis, his saturation was falling below 70 and 60. The fluctuation was
falling below
70. The fluctuation was found right after the OT. We shifted him to ICU, and then by that evening he collapsed, sir.
Did you take the weight of patients to give the dose of steroid? This thing the enoxaparin? Did you take the weight? You had given standard 40 units enoxaparin. It is 1 unit per kilogram body weight. You have not taken the weight of the patients. If somebody is say 60 or 70 kilogram, you should have given at least 70 units.
Yes,
Okay.
sir. Yes, sir.
Did you give IV remdesivir?
Yes, sir. Remdesivir to all the COVID patients admitted in our ICU. IV remdesivir was given.
What was the dose schedule? It was single OD or BD?
Sir, we are giving OD, sir.
Are you sure? Okay.
Sir, in my patient, they were given OD. But, yes.
Which is better? Did you give steroids also?
Yes, sir. In few patients, sir, we couldn't get time to give steroids since they were immediately taken for the fasciotomy. Rest, after the surgical management was done, we have given methylprednisolone. The patient was there on 1 to 2 milligram per kg.
What was the dose of methylprednisolone which you gave?
1 to 2 milligram per kg, sir.
It is again 1 milligram per kilogram body weight in 2 divided doses. Okay. Okay, thanks.
Okay, sir. Thank you, sir.
Dr. Wilkinson, please.
No, we can go to the next. Thank you.
Okay. Thank you, sir.
Next, Dr. Santosh Prakash. Dr. Santosh Paras. Santosh Paras.
Yeah, hello.
Please share your presentation.
Yes, sir.
Hello, yes.
Good afternoon, sir.
Good afternoon.
Good
Sir, can I start my presentation?
Yeah, please start. Please start.
I'm Dr. Santosh Parsekar, first year PG student in Goa Medical College. The topic is clinical profile, operative management and outcome of acute intestinal obstruction in adults, a 2-year study from a tertiary care institute. The primary aim was to analyze the surgical management and outcome of acute intestinal obstruction in adults. The secondary aim was to find out the sex and age and sex distribution, the etiology, the clinical presentations, if there was any delay in the presentation, the operative procedures which were performed, and the complications associated. So the methods, it was an institutional based retrospective study. The duration of the study was 2 years from November 2018 till November 2020. The place of study is Goa Medical College, Bambolem. The total number of cases were 170 consecutive cases which were operated over the period of the 2 years. The inclusion criteria, all the patients who had presented with intestinal obstruction and were admitted in our surgery department above the age of 18 years and who have undergone emergency surgery. Exclusion criteria is the patients who are below 18 years of age and patients who are planned for conservative management. The clinical features, almost all the patients had, most of the patients presented with the main complaint as pain and the other complaints which were in minorities were absolute constipation, spurious diarrhea and bleeding per rectum. The age and sex distribution, it was observed that the mean age was around 57.42. The maximum incidence was seen in age group of 60 to 69 years of age. The gender distribution, the male to female ratio was, it came to around 1.4 to 8, in which males, there were 59% of the patients were males and 41% of the patients were females. The time of presentation, almost more than 64.5% of patients had a delayed presentation. That is, they presented after 24 hours of onset of symptoms. The large bowel versus the small bowel. Small bowel obstruction accounted for almost 54.70% of the total cases. The etiology. It was observed that malignancy was one of the most common, attributing for 37.505%, followed by hernia, which came to 28.23%, then adhesions and bands, 20.58%, followed by intussusception, followed by stricture, intussusception, and volvulus, respectively. The procedures done. Resection and anastomosis was the most common procedure which was performed, which came to 28.18%. It was seen that only stoma was done in 16.77%. The other procedures, that hernia repair, came to 24.83%, followed by adhesiolysis and bands and division, that was 18.79%. Among strangulating and non-strangulating, strangulation was seen in 28.8% of the total cases. Post-op complications, the post-op complications is seen in elderly age group, that was above 60 years of age, among which surgical site wound infection was one of the most common complications that was seen in ICU stay. It was seen that 20% of the patients, that is 34 patients, needed ICU stay. Out of which 24 of the 34 patients were elderly patients, that is above 60 years of age. So using chi-square test, the p-value comes to 0.0057, so which comes as statistically significant, that age factor with respect to the ICU stay. 30-day mortality. 30-day mortality was seen in 6.4% of the cases, among which 87.81%, that is 9 cases, were above 60 years of age, and the p-value using chi-square comes to 0.048217, which is less than 0.05. So the conclusions of my study: in our study, we found that in our scenario, that colorectal malignancies were one of the most common, was the commonest cause of acute intestinal obstruction, which attributed for 37.5% of the cases. The mean age was found to be 57.42 years. The maximum incidence was seen in 60 to 69 years of age group. The 64.5% of patients had a delayed presentation, that is, they presented after 24 hours. Small bowel obstruction constituted for 54.70% of the cases. Strangulation was seen in 28.8% of the cases. Major complication was seen in 11.2% of the cases. ICU stay was needed for 20% of the cases. 30-day mortality was seen in 6.4% of the cases. The risk factors for poor outcome was an elderly age, for which the p-value came out to be 0.0057, the delayed presentation, and the third one was bowel strangulation. And all, according to the p-value, all three were statistically significant. Thank you, sir.
May I speak, Dr. Wilkinson?
Yeah, please go ahead, sir.
Dr. Santosh, I just want to convey, because you don't know the basics of the study designs. You are saying that this is analytical study. In analytical study, there are comparison groups, like 100 patients, one group, 100 patients, another group. Yours is simply a clinical profile and management of patients of intestinal obstruction in small and large gut. This is a prospective observational study. It is not analytical study. This is one thing which I want to clear. Secondly, you had mentioned retrospective study. Your study goes from 2018 to 2020. This is a prospective study. It is not retrospective study. Retrospective study should have been, if you are studying in 2020 and you are taking cases of 2018, then it would have been retrospective study. So this thing will be of great use to you in your future. What is prospective study, what is retrospective study, what is analytic study, what is descriptive study. Okay, this is one thing. Secondly, what was the most common cause of obstruction in small intestinal obstruction cases? Most common cause.
Most common cause was hernia was one of the most common cause, sir.
But literature says that adhesions are the most common causes of small gut
Yes.
obstruction.
Yes, sir. In
in
Western
your
countries and yes, that was the thing. In other studies which I had gone through, it said that adhesions. I agree to you, sir. Adhesions were the most common cause. In Indian setting, the previous studies, which were one of the study was by Adhikari as the acute intestinal obstruction, a review of 367 patients in Eastern India. They also had hernia as one of the most common cause, sir.
What is the investigation of choice in a patient of small gut obstruction?
Small gut obstruction investigation
of choice.
It would be a CECT.
It is plain X-ray abdomen. Investigation of choice is plain X-ray abdomen, erect and supine. Okay. Because with that you can find out whether the obstruction is proximally or distally. What is the distension of abdomen? All these things you can find out. Thank you very much.
One question I want to ask is: all the patients you managed by open surgery, open method, none of them you did laparoscopic?
All these were emergency-based procedure. Yes, sir.
Sir is asking whether you did laparoscopic procedure also in any of the cases, or all
no,
by open surgery?
No, all the patients were operated by open surgery. None of them were based on laparoscopy.
Okay. So could laparoscopy also have been a mode of investigation to see the what you call it, and the emergency? What would determine the emergency? Was there evidence of strangulation, evidence of peritonitis in each case?
Yes,
you did not manage. You did not
it's,
manage any of them conservatively. The ones, say, for example, a patient came with evidence of intestinal obstruction,
sir,
who did not have any sort of
the conservative,
who did not have any evidence of peritonitis. You'd also would manage initially conservatively and see whether it resolves, especially with adhesions, as Dr. Goel had said.
yes, sir. So the conservative cases were excluded from the study. We didn't consider the conservative management into our
adhesion
studies.
or even with hernia.
Yes, sir.
Because the
all
policy
conservative
is that you should wait for at least 72 hours, and if there is no improvement, then you go for laparotomy.
Yes, sir. But according to the inclusion and exclusion criteria which we had said, whichever patients were managed conservatively, those we had excluded from our studies.
Okay.
Okay. Chaliye. Thank you very much. Thanks.
Thank you, sir.
Next is Dr. Sarath. Dr. Sarath.
Sir, yes, sir.
Dr. Sarath, can you hear me?
Sir, can you hear me, sir? Sir, can you hear me, sir?
Yes.
Okay,
Please share your.
good afternoon, sir. I'm Chadri, postgraduate from NRI General Hospital, Guntur, sir.
A bit louder, please.
Yes, sir. And my study is a comparative study between 4-layer dressing versus WAC dressing in treatment of lower limb venous ulcers. Venous disorders of lower limbs are of common occurrence and their severity ranges from minor asymptomatic incompetence to chronic leg ulcer. They usually affect 10 to 20% population in Western world, but in India it is 5%. And varicose veins are defined as dilated, tortuous, subcutaneous veins more than 3 mm in diameter with a demonstrable reflux. And venous ulcers most commonly occur around the ankle, that is gaiter's zone, mainly due to the ambulatory chronic venous hypertension. And usually they are treated with 4-layer bandage. The 4-layer bandage comprises the orthopedic wool, crepe bandage, elastic bandage, and a final cohesive retaining the layer. All layers are applied from toes to the knee and usually require weekly renewal, but can be changed more often if there is soakage of the dressings. And compression bandaging is thought to assist the healing of ulcers by reducing the leg veins distension and also accelerating the venous blood flow. Vacuum assisted closure is also known as negative pressure wound closure. Applying the intermittent negative pressure of approximately minus 125 mm Hg appears to hasten the debridement and the formation of granulation tissue in chronic wounds and also in ulcers. A foam dressing is cut to the size to fit the wound, followed by a perforated wound drain is placed over the foam, and the wound is sealed with a transparent adhesive filling, and then a vacuum is applied to the drain. The negative pressure may act by decreasing edema, by removing interstitial fluid, and by increasing blood flow. As a result, bacterial counts decrease and cell proliferation increases, thereby creating a suitable bed for grafting and or also for flap cover. And my aim is to compare the efficacy of 4-layer dressing versus VAC dressing in the management of venous ulcers in the leg. And the time taken for healing and hospital duration of hospital stay were also studied. In our study, a total number of 60 cases were taken over a span of 2 years who came to NRI General Hospital, General Surgery Department. This prospective observational study, total number of cases were divided into 2 groups, 30 to 4-layer dressing and 30 to VAC dressing as per the inclusion and exclusion criteria. And in my inclusion criteria, all the lower limb ulcers of venous origin and age more than 20 years were included, and chronic smokers and patients with concomitant arterial occlusive disease were excluded. Based on the age distribution, most of the 4-layer dressing people are between 41 to 50 years, whereas in VAC dressing it is between 51 to 60 years. And the distribution based on the diabetes mellitus, 20 patients were having diabetes mellitus in VAC dressing group, whereas 16 patients were having diabetes mellitus in 4-layer dressing group. And distribution based on the hypertension, 19 patients were having hypertension in VAC dressing group, whereas 13 patients are having hypertension in 4-layer dressing group. Distribution based on the hemoglobin values between in less than 11, 11 to 13 and more than 13. 14 patients were having less than 11 grams of hemoglobin in 4-layer dressing, whereas 7 patients are having hemoglobin less than 11 in VAC dressing group. Distribution based on the wound size, it is divided between wound size less than 10 centimeters and more than 10 centimeters. And 18 patients in the 4-layer dressing group have wound size less than 10 centimeters, whereas 16 patients in VAC dressing have less than wound size less than 10 centimeters. And 14 patients in VAC dressing have wound size more than 10 centimeters, and 12 patients have wound size more than 10 centimeters in 4-layer dressing. So time for healing in groups, we divided it in between healing in 2 to 4 weeks and in between 4 to 6 weeks. And in VAC dressing, 27 patients were having healing within 2 to 4 weeks, whereas 9 patients in 4-layer dressing required 4 to 6 weeks. And distribution based on the duration of hospital stay, we divided between duration less than 3 weeks and more than 3 weeks, which are equally distributed in both groups. And following this, the patients who required grafting, 12 patients of 4-layer dressing needed grafting, whereas 15 patients in VAC dressing needed grafting. Others are healed by the secondary intention. So coming to the discussion, in our study, the mean age of patients with 4-layer dressing was 53 years, and among VAC dressing was 52 years. Based on time taken for healing, among the 4-layer dressing group, the mean time taken was 3.67 weeks, whereas it was 3.27 weeks in VAC dressing. And also the mean duration of hospital stay was almost equal in both groups, where it is 2.97 weeks in 4-layer dressing, whereas it is 3 weeks in VAC dressing. Among the 4-layer dressing, 40% went for grafting, where it was 50% in VAC group. So by observing the variables like mean time taken for wound healing, mean hospital stay, and number of cases underwent grafting, it can be summarized that VAC dressing is better than 4-layer dressing in the treatment of lower limb venous ulcers. Thank you.
Can I ask a question, Dr. Goel?
Yes, sir, please. Sir, please, by all means.
Dr. Sarath,
sir,
how did you randomize these two groups of who should get a VAC dressing and who should get a 4-layer dressing? How did you randomize it?
Sir?
Dr. Sarath, you understood my question?
Yes, sir.
How did you randomize that which patient should get a 4-layer dressing and which patient should get VAC?
Sir, it is just a alternate patient, sir.
You decided on that. Every alternate patient
Yes,
who
sir.
comes
Yes,
with
sir.
venous ulcer, you will
Yes, sir.
do with 4-layer and or a VAC, right?
Yes, sir.
Am I right?
Yes, sir.
Dr. Goel, any question?
Hanji sir, Hanji sir. Dr. Sarath,
sir.
That is okay. You assigned the group of the patients randomly, that one patient to this, next to that. But did you compare both the groups so far as age is concerned, hemoglobin level is concerned, condition of wound is concerned? Because otherwise these can cause biases. These can cause systematic error if you had not compared both the groups.
Okay, sir.
So you should have compared both the groups according to these lines. Okay.
Okay. Sir.
Secondly, this VAC dressings are little costly affairs. So you can conclude that since difference is not significant, so you may advise the patient to have 4-layer dressing.
Sorry, sir. Okay, sir.
Okay.
Okay, sir.
And thirdly, what is the pressure given by 4-layer dressing?
40 mm Hg, sir.
40 mm.
More than.
Okay. And what is the mechanism by which VAC acts?
Sir, the negative pressure usually causes the shrinkage of the wound and also increases decreases the edema and thereby microflora formation, sir.
It increases cell proliferation. It increases protein
Granulation tissue.
matrix. Okay. This is the main action. Of course, decreasing edema, improving lymphatic drainage, improving venous drainage, all these things are additionally there. Thank you very much.
Sir, thank you very much, sir. Thank you.
Thank you.
Next is Dr. Prateek Chaudhary.
Am I audible, sir?
Yes.
Yes,
Yes,
please.
you're
Yes, please.
you're
Yes,
audible.
yes, sir.
Share your presentation.
Okay, the screen is visible.
Yes.
Yes.
Yes,
Yes,
yes.
it's you.
Good afternoon, sir. I'm going to start my topic here. Surgical profile of geriatric patient with special reference to nutritional parameter and surgical outcome. It has been said that for old age, it is always said that you can't heal old age. You can just promote it, protect it, and extend it. We have seen that the age increase as the patient's age increase, the patient are more vulnerable for the various cardiovascular, respiratory, and gastrointestinal derangements. With the discoveries in a medical science and improved socioeconomic condition, it has always seen that there are large number of people who are present in health settings. Today, surgery are most frequently performed in elderly, not only the life-threatening, but also the elective procedures. Modern techniques in anesthesia has made all this possible, but we have seen that hospitalization is a double-edged sword. Hence, it has its own merit and demerits. It has an most common demerit of an iatrogenic infection. While operating a geriatric patient, a surgeon knows about the risk of operating a particular case, operative intervention required, and hazards of surgical failure. Most importantly, average life expectancy in India has reached up to 62 years. On another study, it has been seen that a person who crosses 60 years will live more 14 years in his life. Hence, there is the magnitude of the patient above 60 years of age has been increased in today's setting. Aims and objective. Aims of the study is to study the incidence of geriatric patient admitted in our surgical wards, to study the incidence of various surgical condition affecting elderly, to find practical, economical, and easy nutritional indicator for assessment of nutritional status in geriatric age group, and last is to compare the indicator which we have been using in our study, that is global indicator for malnutrition and its post-operative complications. Material methods. For the study, we have selected randomly 100 patients of more than 60 years, which were admitted in our hospital of Index Medical College for a period of 2 years. The patient which were included in the study was were of both sexes with a high, medium, and low socioeconomic status, rural and urban residents, and various systems involved. The excluded groups were mainly comprised of traumatic patient and the patients who were died shortly. Steps in study: the patient of more than 60 years was involved in a group, irrespective of the system involved. Randomly selected patient was randomly selected after the consent, and all tests were done according to the proforma created. For the global indicator for malnutrition, we have taken three main indicators, that is anthropometric measurement, malnutrition risk screening tool for hospital, and biochemical indicator, that is albumin, hemoglobin, and total leukocyte count. This is GIM indicator, but we have using GIM scale here because as we know that a malnutrition cannot be diagnosed on the base of a single indicator. Various battery of indicators are required to put a particular patient under malnourished category. On another hand, multiple indicators help us to remove error from our study. The indicator used in our study like BMI and biochemical indicators like hypoalbuminemia, anemia, and total leukocyte counts are gold standard indicators which we are using since past. For example, if a patient who is anemic and proteinemia and hypoproteinemia can't be called as malnourished if BMI and MRSTH score is negative according to the study. BMI calculated below 18.5, the patient is categorized under malnourished, and total protein, if the protein count is less than 6.7 or to 8.6, then, and hemoglobin, various parameters are mentioned here. MRSTH score. MRSTH score means malnutrition risk screening tool for hospitals. Various questionnaires are asked for the patients in order to observe the malnutrition present or not. For example, here we can ask about the source of income. If a patient has a per capita income of less than 5,000, it is included in our category, and he has been scored as 1. And unintentional waist loss has been also been included in our study. Mid arm and mid calf circumference has been also included. Material treatment of the patient were treatment of the patient was made according to the surgical intervention as indicated. Follow-up of the patient was done until the date of discharge. Post-operative complication includes which include minor complication and major complication. Major complication includes local and systemic, that is wound dehiscence, and systemic, which include pneumonia, pulmonary embolism, etc. Observation, total 3,404 admitted in our surgical ward, out of which 480 patients were more than 60 years of age. Young elderly were 44%, middle elderly 30, and old elderly were 26% in number. We have seen that the positive predictive in GIM score was 56%. Anemic patient were 67. BMI, which was predictive of GIM, was 37. MRSTH score predictive of malnutrition was 20, and serum albumin predictive in GIM was 47 cases. This is the diagrammatic representation of various system involved and number of cases. System involved in GIT were comprised of the diseases like esophageal carcinoma, peritonitis, intestinal obstruction, and the maximum cases in genitourinary syndrome, where genitourinary system was males, as in general surgery department maximum male patients are treated. This is now according to system, the GIM score was analyzed. GIM score significant in young elderly was 22, middle elderly it was 16, and old elderly was 18%. Post-operative complication of major type in GIM positive group was 33. Post-operative complication in minor type it was seen among 14 patients. And there was a patient who were having no complication in the GIM significant group. This is the group in which the GIM score was not significant, and 4 patients along which GIM negative groups shown post-operative major complication, and the patient with the GIM negative with a post-operative minor complication was 1. Now comparing this with in order to find the validity of our test, we have made sensitivity and specificity. Sensitivity was found to be 90.38%. Specificity was 81.25%, and the chi-square test was analyzed, which was p-value less than 0.001, which was significant for p less than 0.5. Major complications, these state that a patient with a major complication have mean hospital stay of more than 19 to 20 days. Mean hospital stay of the major complication patient was analyzed, and minimum hospital stay days was 9, and maximum hospital stay day was of 29 days. The result of our study, incidence of geriatric patient admitted was 14.10%. Malnutrition was present among 56 admitted cases, in which the GIM was predictive more than score 2. Combination of several measures in assessment of standard test GIM should be more accurate if we have the positive predictive value, hence more than 80%. In our study, we have got the positive predictive value of 83.93%. This states that this scale is able to calculate malnourished patients. Discussion and literature review, we have seen that the various literatures age in the study which was done by Pasari and his colleagues showed that age population age more than 70%, more than 70 was 34%. Decline in our study, we got that a patient living after the age of 70 years was 26%. This state that there is a decline in a patient in age group more than 70, might be because of lowering life expectancy below 70 years. Thank you, sir.
Dr. Goyal, would you like to ask any questions?
Dr. Teek.
Yes, sir.
I just want to ask,
Yes, sir.
You have admitted geriatric patients.
Yes, sir.
And whatever results are there,
Yes,
they are
sir.
of geriatric patients.
Yes, sir.
With whom you have compared your results in
Sir, it is a
study? Like you have asked, you have told about validity of study, you have told about sensitivity of study,
yes, sir.
specificity of study, but with whom you have
Sir,
compared
actually,
your results?
I am not comparing these. I am just taking the validity of my score.
Hello.
That is GIM score. GIM score, sir. I am using my GIM score.
No, I am asking about validity of your study,
Yes, sir.
sensitivity of your study. You have compared with whom? Actually, your study should have been listened.
Yes.
There is one group where you have collected geriatric patients.
Yes, sir.
And there are standardized performa that complication in all other groups, all other population, that includes general population. This includes pediatric also, adult also, geriatric also. So there is one combined result and one is result of your study. You should have compared your results with generalized population complication results. Then the study would be valid, otherwise not. Secondly, I want to tell you the normal p-value is 0.05.
Yes, sir.
If the results of study are less than 0.05, the
Yes,
results
sir.
are significant. It
Significant.
means
Yes.
error in your study is less.
Yes,
You
sir.
have mentioned p as
0.05.
0.5. You have
Yes, sir.
mentioned 0.5. It is
0.05.
0.05.
Yes.
Okay.
Yes.
Thank you very much.
Okay. Thank you, sir.
Thank you. Thank you.
Thanks, sir. Thanks, sir. Thank you very much.
Thank you, sir.
Thank
Sir,
you.
one more presentation. Doctor, waiting.
Yeah, please.
Sir, one more presentation.
Okay, no problem. Please carry
No
on.
problem. Please carry on.
Dr. Devendra.
हेलो हेलो
इसका हाँ बस हो गया, बस से लास्ट.
हेलो
Hello, yes, please start.
am I audible?
Yes, you're audible.
Good afternoon, sir. I am presenting my paper on the clinico-pathological study of necrotizing fasciitis. Sir, starting from the introduction, necrotizing fasciitis is a rare but aggressive soft tissue infection which involves the facial layers and the subcutaneous tissue, while skin and muscle initially remains intact. It is a surgical emergency resulting from microbial synergistic infections. This infection, which is usually induced by the virulent toxin-producing bacteria, can occur in any region of the body, but it is predominantly located in the abdominal wall, perineum, and extremities. On the basis of microbiological cultures, then NF is divided into two distinct groups. Type 1 infections are polymicrobial, involving aerobes and or facultative anaerobes and non-group A streptococci. Type 2 is usually caused by beta hemolytic group A streptococci alone or in combination with staphylococci. Predisposing factors of the disease are diabetes, alcohol, and intravenous drug abuse, as well as immunosuppression and peripheral vascular disease. However, NF has also been reported in young and previously healthy individuals. The diagnosis of NF is usually clinical and is important to find it as early as it rapidly progresses through septic shock. An early sign of NF is locally erythema and pain out of proportion to findings of physical examination as well as fever. Skin necrosis due to thrombosis of blood vessels at the facial level is a sequel of initiating process and often associated with severe sepsis. Histomorphological hallmarks are necrosis of the superficial fascia with blood vessel thrombosis, severe inflammation of dermis and subcutaneous fat as well as subcutaneous fat necrosis. Mortality is 30 to 50% even with the prompt operative interventions. Therefore, aggressive therapy based on early and extensive surgical debridement, antibiotics, and intensive care is necessary. In this study, a consensus of attempt is made to analyze factors affecting the outcome of patients with necrotizing fasciitis treated at a hospital. The study also aimed to determine the predisposing factors, bacteriological profile, and clinical pathological findings associated with the disease. We also aim to study various treatment modalities for management of NF. Aims and objectives. Aims is to analyze the factors affecting the outcome of patients with necrotizing fasciitis treated at our hospital. There were three objectives: to study the presentation of disease, to study the cause that predisposes to necrotizing fasciitis, and microbiology involved in infection, and to study the surgical and resuscitative management. Methods. This study was cross-sectional in observation in nature, which was performed at Index Medical College Hospital and Research Center, Indore. The patients presenting with with features of NF were admitted in our institute, and the diagnosis was made on the basis of clinical findings such as skin changes, fever, pain. The causative factors were studied by detailed interview with the patient. The physical examination of patients was done, biochemical investigations, radiological investigation, and microbiological study of wound was done. The treatment was started as soon as diagnosis was suspected, with included resuscitation of patient with intravenous fluids, antibiotics, and wound debridement. The surgical debridement of wound was done according to necrotic area of skin and subcutaneous tissue. Following initial debridement, the wound was inspected regularly, and subsequently debridement was done periodically whenever it was necessary. Daily dressings were done when viability of the remaining tissue was assured and the infection had been controlled. Patient underwent skin grafts, flaps, or secondary suturing for covering the wound area. All patients presenting with features of necrotizing fasciitis were included in the study, and pregnant women were not included. Sample size of 100 patients were included. Investigations like complete blood counts, random blood sugar, pus culture sensitivity, USG local area, serum electrolytes, urea, creatinine, urine routine microscopy, serology, blood group, histopathology, C-reactive protein was done. Coming to the observations, most number of patients were in age group of 51 to 60 years, in which 26 out of 100 patients were found. Coming on the gender distribution, most patients in our study were male. 85 patients were male, while only 15 patients were female. Incidence in male was also higher in 51 to 60 year age group, while in females it was higher in more than 60 year of age group. Coming to occupation of patients, most patients suffering from necrotizing fasciitis were farmers, followed by unskilled workers and then skilled workers. Coming to site of infections, the most patient had involvement of lower limb, followed by genitals and perineum. Coming to the presenting symptoms, most patients presented to us with a complaint of pain, followed by fever, then swelling, and then discharge from the wound area. Duration of symptoms. Most patients present to us within 1 to 7 days of onset of their symptoms, while followed by 8 to 14 days, and 8 patients came to us after 14 days of their onset of symptoms. Sign. Most patients came with a sign of edema, followed by tenderness, and then ulcer. Coming to etiological factors, most patients in our study had history of trauma following necrotizing, after which followed by necrotizing fasciitis. After that, thorn prick was also common. Eczema, allergic, and drug reactions was also common in our study. Comorbid conditions associated with necrotizing fasciitis. Most patients in our study had diabetes mellitus as an associated comorbidity with necrotizing fasciitis, followed by hypertension and then malnutrition. Composition of the isolated organism. Most patients, the isolated organism was E. coli, followed by Klebsiella, followed by Streptococcus. Number of isolated organisms. Most patients had 2 organisms isolated in the pus culture and sensitivity of the patient, followed by 1 organism, and 12 patients had none organism in their culture. Blood investigations, most patients had raised C-reactive proteins, raised WBC counts, reduced hemoglobin levels, raised serum sodium levels, raised creatinine levels, and raised random blood glucose level. In acute management, in most patients, 82 patients, wound debridement was done, followed by fasciotomy in 13 patients. While coming to the definitive management, SSG was done in 41 patients after the wound was clean and healthy. Secondary suturing was done in 27 patients. 15 patients healed by secondary intentions, and in 6 patients, flap was done. Mortality out of 100 patients, 11 patients in our study died even after full resuscitative and surgical management. coming to the photographs, as we can see, the patient coming with necrotizing fasciitis of left arm, and in the lower photograph, debridement of the wound is done. Coming to the next page, this is necrotizing fasciitis of left thigh, and we can see the different images comprising of wound after debridement and after the wound was healthy for split skin grafting. There is an early picture of necrotizing fasciitis of right lower limb. Coming to the second picture, after which fasciotomy was done. In the lower part, we can see the necrotizing fasciitis. Hello.
Time is up.
In this photograph, we can see the necrotizing fasciitis of the perineum, also called as the Fornes gangrene. Wound debridement was done. Daily dressing was done. When the wound was healthy, we covered it with the skin grafting and secondary suturing, as seen in the fourth picture. There are some pictures.
Tell the conclusion part. Tell the conclusion part, because your time is over.
Yes, sir. Necrotizing fasciitis is a lethal soft tissue infection mostly affecting males in elderly age group. Major predisposing factors include trauma, poor personal hygiene, age more than 50 years, low immunity, and diabetes mellitus. Field workers with low socioeconomic status are more prone to developing necrotizing fasciitis. Lower extremity is the most common site affected. Most patients presented with pain, fever, high-grade fever, swelling, and discharge from the affected area. Most infections are polymicrobial, with E. coli being the most common bacteria isolated. It is a surgical emergency. Early recognition of this rapidly progressing and life-threatening disease and aggressive wound debridement, often at repeated settings, are the mainstay in the treatment of necrotizing fasciitis, supplemented by the adequate antibiotics and supportive measures. Extensive raw area due to debridement can be managed later by the reconstructive procedures like SSG, flap, or secondary suturing. Most patients underwent split skin grafting once wound was healthy. In spite of early diagnosis, disease leads to significant mortality and morbidity. Hence, patients with provisional diagnosis of necrotizing fasciitis should be treated aggressively with wound debridement as early as possible, if necessary with amputations and broad spectrum antibiotics, in order to bring down the morbidity and mortality. Thank you, sir.
Thank you. Thank you, Dr. Devendra.
Yes,
one thing I would like to say is that you should improve the quality of your slides.
Yes.
It's not really a very effective presentation. Too much of matter in each slide, and therefore which you have overshot your time.
Yes, sir. I tried to include most pictures and the data which I studied in this study. Therefore, that's why there are like more pictures and data.
Dr. Wilkinson has rightly said, it appears that you are presenting a research paper. You should have prepared good PPT. You are reading essays. That is not the proper way of presentation. It's very secondly, you have mentioned that it's a cross-section study, isn't it? You have mentioned in your material and methods, you have mentioned this is cross-sectional study. It is not cross-sectional, dear.
It is observational as well as sir cross-sectional, because
listen, you don't know what is a cross-sectional study. You don't know what is observational study. Cross-sectional study is a snapshot study. Suppose we are finding the prevalence of diabetes or prevalence of malnutrition or prevalence of heart disease in a population at one point of time. That is cross-sectional study. Yours is not. Yours is prospective observational study. It is not cross-sectional. Secondly, what are the clinical stages of necrotizing fasciitis?
Sir, in early stages, the patients generally comes with blackening of skin and superficial.
There are three stages. Tell me about three stages. Stage 1, stage 2, stage 3.
Sir, in stage 1, patient come with superficial blisters and the pain. Sir, pain is generally, sir, more than the clinical signs are there. Sir, in secondary stage, sir, there is blackening of skin followed by discharge. In third stage, the patient comes with already necrosed area and foul spinning discharge, and also the involvement of of the deeper structures, sir.
Listen, stage 1 is fever and erythema. Stage
Yes,
2
sir.
is blister and bully, and stage
Yes,
3
sir.
is necrosis. Okay, this is the
Yes, sir.
staging. What is the difference between cellulitis and necrotizing fasciitis?
Sir, in necrotizing fasciitis, sir, mainly, sir, facial layers are involved, and sir, there is also
Yes.
collection of, sir, fluid, sir. Therefore,
Which antibiotics you gave? Which antibiotics you gave to the patients?
sir, in our setting, sir, we mainly give, sir, mainly, sir, covered with two antibiotics. Sir, first antibiotic was always, sir, the third generation cephalosporin, like, sir, ceftriaxone, and, sir, it was added with aminoglycosides like gentamicin or, sir, amikacin.
You did not give metrozil?
The time is
Sir,
over, sir.
You must add metrozil because there is
Sir,
anaerobic infection.
yes,
So
yes, sir, yes, sir.
metrozil must to be added.
Sir, we added metrozil to the patient in which, sir, sir, culture shows sensitivity for the metrozil.
Even without culture, you should add. Okay, thank you very much.
Yes, sir. Thank you.
Okay, thank you. Thank you, everybody. Thank you, sir. Go ahead, sir.
Thanks, Dr. Wilkinson. Thank you very much.
Thank you. Thank you, sir.
Jitendra, thank you very much. Yeah, बहुत शुक्रिया.
Thank you. Yes, sir. Thank you, sir.
हाँ, नहीं वो कोई बात.
डॉक्टर प्रभा मैंने तो मना दी अगर नहीं करवाते डॉक्टर प्रभा हमें खुद में लगा शो है.
Yes, yes.
गुड इवनिंग मैम.
हाँ, good evening. Are the presenters here?
मैम मेरे पास जो लिस्ट है उसमें सिर्फ दो प्रेजेंटर हैं, डॉक्टर पूर्वी और डॉक्टर कुमारन. तो अभी दोनों ने लॉगिन नहीं किया है. अभी कुमारन अभी लॉगिन कर रहे हैं, डॉक्टर पूर्वी अभी उनसे कॉन्टैक्ट नहीं हो पा रहा है.
Okay, we'll wait. What else can we do? We'll wait. Tell us when they log in, okay?
Yes.
Dr. Kumaran has joined. Present his
ma'am.
case.
Yes, ma'am. Dr.
Let him
Kumaran?
present.
Dr. Kumaran?
Yeah.
Yes. Please share your presentation.
I can hear you, sir.
Please share.
Sir, can you see my slides, sir?
Yes, yes.
Shall I start, sir?
Yes.
Yeah. So good evening, sir. Sir, I'm presenting a free paper, sir. A retrospective study of modified Puster's procedure done in a tertiary care center for management of chronic calcified pancreatitis. So introduction, chronic pancreatitis is a progressive inflammatory, once again, yeah, progressive inflammatory disorder characterized by irreversible destruction of the pancreatic parenchyma associated with the chronic pain and permanent loss of exocrine and endocrine function. Management of chronic pancreatitis is still challenging for surgeons due to the limited understanding of the pathophysiology process of the disease. So in our institution, the modified Puster's procedure has its recognized application in decompressive management of the chronic pancreatitis with intraductal calculi. Record the screen. Yeah. So aim of this study is to analyze the demographic and the spectrum of clinical presentation and indication for surgery, type of surgery, and outcome of the surgery. The aim of this retrospective study was described was last 3 years experience in our institution using a modified Puster's procedure in consecutive series of patients in a tertiary care center. So materials and methods, it is a retrospective study conducted in 8 patients of chronic calcified pancreatitis who underwent modified Puster's procedure in our institution during the year of 2016 to 2018. This study includes the following parameters of age group, sex, occupation, etiological factors, symptoms, duration of symptoms, and various investigations and type of surgeries performed and outcome were analyzed. So inclusion criteria, patient who had presented with classical history of chronic pancreatitis with relevant radiological investigation with intraductal calculi. And exclusion criteria, patient who had a parenchymal classification.
Kumaran, 1 minute.
Yeah.
You had to present innovation of local wound care management here. What are you presenting?
Oh, sorry, madam. Yeah, madam. Oh, sorry. Sorry, madam. Sorry. I will. Ma'am, I will come back, madam. Sorry, madam. I will come back, madam. Sorry. Sorry. Ma'am, give me your 10 minutes, ma'am. I will come back. Sorry, ma'am.
Okay.
Okay. We can have the second presenter.
Hello. Dr. Nikhil?
Yeah.
Yes, sir. 4:30.
I know. Can you leave the screen?
So please sir login कर दीजिए मैंने जो आपको आईडी भेजी है.
இதுல என்ன விஷயம் இருக்கு? இதுல என்ன இருக்கு? எனக்கு ஒண்ணும்
डॉक्टर परवा अभी हमारे पास 2 ही प्रेजेंटेशन है उनमें से एक आई नहीं है डॉक्टर सैयद नागी साहब कुमारन अभी 10 मिनट बाद आएंगे.
नहीं वो दूसरी कौन है?
डॉक्टर पूर्वी.
She has not come?
नो. और उनका नंबर भी गलत बता रहा है. मैंने कांटेक्ट करना चाहा तो रॉन्ग नंबर दिया.
मेल करो.
मेल किया हुआ मैम. साइट तो कर लीजिए.
Kumaran, you don't have your presentation on this laptop? Kumaran? You don't have the presentation on this laptop?
Yeah, ma'am. Sorry, ma'am. I want 10 minutes, ma'am. I didn't get that message, ma'am, actually, for this wound care management.
So you don't have the presentation?
I have, ma'am. I have to just, I need over 5
Upload it.
10 minutes, ma'am. Yeah, loading, ma'am. Can I come after over 10 or 20 minutes, ma'am? At the last of the demo.
Dr. Nikhil, what to do?
Okay, ma'am.
Give him
Thank
10 minutes, we can give him maximum
Okay.
because it's already 4:10.
you.
So,
Okay.
Within 10 minutes, I will come.
Sure.
Before 30 minutes, you are allowed. Okay. Thank you. मैंने आपको एक टेक्स्ट मैसेज किया सर उससे आपका ये जो जूम का सर मीटिंग आईडी से लॉगिन कर लीजिएगा सर 5:15 to 6:15 सर आधे घंटे पहले लॉगिन कर लीजिएगा ओके सर थैंक यू ओके थैंक यू यस सर बता दिया उसके लिए भी बंद कर रहा है थैंक यू भैया हो गया अरे एक बात है बोल के कह रहा थैंक यू भैया मेरा हो गया और डॉक्टर थैंक यू भैया मेरा हो गया उसका प्रेजेंटेशन इसी सेशन में हो रहा था मैं भैया इन्फॉर्म कर रहा हूँ फोन करके उसका हो गया तो मैंने कॉल किया थैंक यू भैया मैंने अपना प्रेजेंटेशन प्रेजेंट कर दिया यार गूगल पे फोन पे यही है तो नंबर पे ना व्हाट्सएप पे भी है व्हाट्सएप पे तो आ गया उनको लगाव चलाते हैं पर मैंने आपको अभी मैसेज किया यस सर एक बार उसी से लॉगिन होइएगा सर आपका रजिस्ट्रेशन टाइम का प्रेजेंटेशन है 5:15 से 6 नंबर तो सर आप आधा घंटा पहले सब लॉगिन कर दीजिए थैंक यू सर वो जो आईडी भेजी है सर उसमें कुछ वो गलत है आप उस पर खोलिएगा तो आप किसी और स्टेशन पे चले जाइएगा कहीं और
Slide on madam. Hello madam. Hello Agil. Oh, yeah, okay.
Yes, Kumar, start.
Yeah, start. I am starting the presentation, madam. Share screen, huh? Okay.
Dr. Nikhil? Dr. Nikhil?
Ma'am.
1 minute. Dr. Nikhil?
Yeah, okay, madam.
Yes, ma'am, I'm here. I'm here. I'm very much here.
Okay. Start, Kumaran.
Yeah, ma'am, it's innovative methods for local wound care management, madam. In our actually we in our hospital all we are doing all the surgeries for free of cost, ma'am. So all the patient coming here are cost effect. They are like poor patients only, ma'am. So what we thought for the intracutaneous fistula, management of intracutaneous fistula for a post-op resection and anastomosis case, the patient had around 600 to daily output of around 600 to 400 bile from the abdomen drain, ma'am. So what we thought, patient going for the skin necrosis and skin excoriation. So what we thought of direct suction on the midline wound, ma'am, with the low pressure. We are keeping the pressure in the wall mount section around 10 to 30 or 40 pressure, ma'am, so that the wound we are able to manage the wound very nice, ma'am. So the rate of skin exoration is very less, and we kept the wound dry, and this is very cost effective for the patient side, ma'am. Only the suction tip is required from the patient side, ma'am. Other everything is free of cost we are providing for the patient, ma'am. When compared to the back dressing and other dressing, this is very cost effective, and we also manage the patient very well and discharge the patient well, ma'am. The wound was very good, ma'am, for this patient. So only thing what I want to tell in this presentation is wall mount section for the high output intracutaneous fistula. This method we can try in other setups also, ma'am. It is very effective for the patient and cost effective also, ma'am.
So you put the suction for how much time?
Ma'am, actually it is continuous, yes, ma'am. Continuous. Very less pressure, ma'am. Less than 50, ma'am.
No, it was not intermittent.
No, ma'am, it is not intermittent, ma'am. We usually keep the suction 24 hours, ma'am. When it came to less than 250 or less than 100, ma'am, we stopped suctioning, ma'am. Initial 5 to 10 days, we kept the suction directly on the wound, ma'am. Over the wound, we will keep one gauze piece, ma'am. After that, we will keep the suction tip, ma'am.
No, from what I can understand that you're trying to tell us is that the intracutaneous fistula, you just keep a suction. There's no bag there, right? You just need a gauze piece.
Ma'am. Yes, sir. Yes, sir. One
And
gauze
put
piece.
a
Over that, I
suction
will
tip.
keep this.
Suction tip.
Yes, sir. Yes, sir. Yes, sir. Suction tip, sir.
So that means you'll have to put the suction tip. Do you put the suction tip inside the fistula or you leave it outside the fistula?
Outside, sir. Over the fistula, I will keep one gauze, sir.
Mm-hmm.
Over the gauze, I will keep one that suction tip, sir.
Suction tip.
Suction tip.
Okay. And
above that, I will keep that zinc sulfate and G-pad, sir.
Okay. And in the meantime, the patient is not allowed orally.
No,
or
sir. No,
is
sir.
the patient allowed orally?
No, sir. No, sir.
So that means only fluid that you're getting there. There are no solid particles.
No,
That is
sir.
why you keep a gauge piece out there.
Exactly.
Right?
Yes, sir. Yes, sir. Exactly.
So do you feel that this enhances your wound healing also?
What, sir?
Does it enhance your wound healing in the sense that if the wound was supposed to heal in 3 months, does it heal in earlier?
Sir, yes,
significantly?
sir. It was healed in 1 month, sir. Within 1 month, we are able to heal the wound, sir.
All right. So the patient is there in your hospital for 1
Yes,
month.
sir. Yes, sir. Patient was there for 1 month, sir.
You were using the suction
Not,
continuously
sir.
for
Not, sir.
1 month.
Only 1 week we put suction, sir. When it came to less than 100, sir, in the suction tube for 24 hours, we
Okay, then you discharged the patient or you kept the patient in the hospital only?
we kept the patient in the hospital only, sir, for around.
See, I'll tell you, it's just my
Yes, sir.
personal experience that always I've seen that if you discharge the patient, they
Okay,
come back
sir.
with this excoriation and things. But if you keep the patient in the hospital,
Oh.
the excoriation is practically minimal anyway.
Okay,
So,
sir. Okay, sir.
I mean, you're getting my point, right?
Exactly.
The
Exactly. Yes,
care
sir.
that we can give in the hospital is also is bias out
Biased
here
out.
for
Okay, sir.
your
Okay, sir. Okay.
study.
Till the wound healed, he was here, sir. But he was very comfortable, and since
So it's okay. You mean to say that in the first 1 week at least you didn't have any
no,
excoriation.
sir.
So
No,
that is
sir.
also in a way it is good.
Yes, sir.
All
Yes,
right.
sir.
Also, the
So you've done that.
fistula, output of the fistula is how much?
So output of the
What was the
initially it was 600, ma'am. Initially
okay?
it was 600.
And did you
I have the wound photo also, ma'am. The post-op wound photo. Exactly.
Yeah, ideally you should have shown the wound photographs in between
yeah?
Oh, okay, sir. Okay. It was very. I have, sir, actually. I can able to show, sir. So for multiple jejunal perforation, we did this method, sir. The wound was healed very well, actually. We did for 2-3 patients, sir. It was good, actually.
So for multiple jejunal perforations, did you close the
Sir,
multiple jejunal
sir,
perforations?
sir, can you see the wound, sir?
No, it's not coming on the screen at present.
Okay, sir. Oh, okay, sir. Sorry, sir. Can you show? Can you? One second. Sir, one second. I will show the wound, sir. I will show the wound, sir. Sir, it is in the mail, sir. So, sorry, sir.
Okay.
Sir, can you have?
We saw it. We saw it. We saw it.
Sir, sorry. Sir.
This is the heat wound.
Yes, sir. Post-operative wound.
And the first one?
Oh, initial wound, sir. Sir, actually, it was
Before
a
you put
midline. It was healed wound, ma'am. It was initial wound was a post-operative period, 1 week. Patient, I will show the post-operative. This was the wound, ma'am. Actually, midline wound, ma'am. Sir, after post-operative, the patient developed intraoperative fistula, sir.
Okay, but you've left the wound open, right?
Yeah, yes, sir, yes, sir.
The wound was left open in the per op. I mean, per op only you decided to leave the wound open.
No, sir. No, sir. After resection and anastomosis, 3 or 4th day, patient developed a bile leak from the drain, sir.
Okay. All right.
Drain. So midline wound also patient developed a discharge of bile, sir. So what we thought, so resection was not proper. So midline wound also bile is leaking. So midline wound was managed with this wall mount section, sir. So that time you can see that bile from the abdominal drain also was leaking only, sir. Yes, sir. Yes, sir.
Okay.
It was very challenging, sir. And recently also we are doing this practice, sir. It has a good effective, sir. It was effective, sir.
Yes, we can see that.
Since there was ventilation inside the wound, the oxygenation supply is also good, sir. So, like patient is having good wound healing, sir, in this type of wall mount section.
Okay.
Yes, sir. Only thing we are keeping the pressure very little, sir. Yes, sir.
So I think this is okay, ma'am.
Ah, okay.
Thank you.
Thank you, sir. Thank you, sir. Thank you, sir.
All right.
Purvi is in surgical ICU. She is having a duty. I just
Acha.
failed. So she cannot present.
Sorry. Yes, sir.
So
I think information gayi nahi hogi. Like he was also saying that he had some problems with the information, or it might have gone in the morning today. She might not have arranged her duties in that manner.
so
So I don't know.
okay. So
चलिए
बाय करते हैं फिर इनको.
ठीक है मैडम 5:30 we'll meet then. Okay.
Yeah, 5:30. Yes.
Okay.
Thank you.
Hello.
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 Dr. Vivek Srivastava.
Yeah, am I audible?
Yes, yes.
Okay.
सर आप चेयर कर रहे हैं ना इस सेशन को?
Pardon?
आप चेयर कर रहे हैं सेशन को?
Ah, chair session 4.
Yes. Yes, sir. Session 6, station 4.
Session 4, session 6. Yeah.
सर अभी तक तो कोई प्रेजेंटर लॉगिन नहीं किया है, मैंने सबको लिंक सेंड कर दिया है, बात भी की है, मगर अभी तक कोई लॉगिन नहीं कर पा रहा है। जैसे जैसे लॉगिन करेंगे मैं आपको इन्फॉर्म कर दूंगा। ठीक है सर। डॉक्टर वैभव है आपके को?
Dr. Vaibhav is joined?
यस सर।
Hello, Dr. Vaibhav?
Sir, 7 minutes and 2 minutes question.
Hello, this is Dr. Vaibhav. I have joined in.
Yes, Dr. Vaibhav. I am Dr. Vivek Srivastava from BHU, Surgery Department. How are you, sir?
Dr. Vivek, how are you?
I am very fine, thank you. I think we shared last ASICON. We were on the same bedside procedures.
Right. I was showing a video on urethral catheterization, and perhaps you were on that surgical bandaging and all, no?
Bandaging, yeah.
Last time we met when we came to our institute when to take the exam, no? MBBS exams.
Yeah. Then also.
Yeah.
Then also. Now, how is the post-COVID recuperation going on at your hospital?
At the hospital now, the COVID ward, they have shifted it to that new PMSSY block.
Okay.
So
you are
at
doing
present,
surgeries,
we are having
elective
elective surgeries are basically routine OPDs are not being done. Only telemedicine OPDs are being done. So what are the patients that we are able to get through them, we are operating them. But mostly emergency surgeries.
Okay. So we have started with our elective also, OPD as well as OTs also. So there is a ceiling of 100. We see around 150, 160 patients in the OPD. And
that's quite a good number.
We are getting. Yeah, it's good number. Almost say 60 to 70% of the normal what we are doing in the OPD. And we used to get 2 OTs, 2 days of OT and 3 tables previously. Now we are getting say 1 GA and 1 spinal table every week. We are operating around say 7 to 8 per unit. Basically.
But here in Allahabad also now we are having less of COVID patients. Since previously we were having around 200 patients who were admitted at SRN. At present they are around 60.
Okay. No, the number and probably the infectivity has also gone down. But still we are finding some cases, young cases also they are getting,
People are dying.
It's also not, yeah. It's not clear whether the prime cause is COVID or something else, but they are COVID positive or being labeled COVID. That is always a discrepancy which remains there.
Over here we are seeing that many patients turn COVID negative and they are dying.
Yeah. No, definitely there is a lung injury which happens in these patients. There is no doubt in that. Those who become positive, they show radiological and clinical evidence of having lung compromise.
How is Dr. Puneet?
He's fine. Yeah, we had actually we have our institute presentation of mortality. So in the coming week, we have the mortality presentation from surgery department. So I've just came down to the telemedicine facility here from the department only. So it's fine, everybody is okay here.
At your place, have you started the classes? Like over here, we are still going for online classes.
No, the classes are still online. Online
We have,
classes here also.
we have received letter from the secretary to start for classes, but still the students haven't turned up.
I don't think it's a very wise thing to start with, because online classes they are going on mainly is the patient and the clinical ward rounds and all these for MBBS students, because residents they are also lacking, but still they are doing some work in the department or in the COVID or whatever. Mainly the MBBS batches they are suffering because now it's almost near about 9 months. So, but still the classes are not going on for MBBS students.
Whatsoever, at our place now we are having 150 students. To accommodate them
Yeah.
and to have physical distancing and social distancing, it's too
It's
Herculean
not
a task.
possible. Not possible at all. In government hospitals, although they look very, magnanimous, but still the, corridors and wards, they're all very, beds are very nearby
Definitely.
and everything.
Means previously at Allahabad we were having 100 students. So now that has gone to 150 plus 30 students from economically weaker sections. So that puts it to 180. And they are planning it to increase it to 200. But the infrastructure has not expanded that way.
Yes, who is from the Webcon events? Who is the contact person?
My name is Manoj.
Manoj.
Yes. Sir, दो presenter आ चुके हैं, Dr. Prem और Dr.
So we have Dr. Prem Kumar and
Dr. Prasanna.
And Dr. Prasanna. Chitturi Prasanna. So we can start with Dr. Babu.
Yeah, sure, sir.
So we have got a list. Dr. Nakiran S has not joined, so we'll start with Dr. Prem Kumar.
Dr. Prem. जगह देखनी है, देखो भैया से बात कर ले, सेंटर फॉर साइट द्वारका 20 तारीख को लाइव है इसका, 20 तारीख को लाइव है, कुलदीप मिलेगा तेरे को वहाँ पर या नेकी, दोनों में से कोई होगा, ठीक, दीपू से बात करने से टाइम फिक्स कर ले कभी भी, सुबह का 9 बजे रोज 5 बजे 8-9 बजे, और क्योंकि तेरा वो कह रहा था मैं सुबह से चलवा लेगा, क्या नाम है, कर रहा है, जो भी कर चला लेगा, तो तू जगह देख के फिर 20-25 MBBS की फीस लाइन चाहिए.
Dr. Prem Kumar, are you there? So we'll start with Dr. Chitturi Prasanna.
Yes, sir.
Are you ready?
Yes, sir.
Dr. Prem Kumar.
So the timer shows 7 minutes of time, 6 minutes for presentation, and 1 to 2 minutes for questions or discussion. Okay. We can start, Dr. Babu. Yeah, please start. Dr. Prasanna, you can start.
Okay, sir.
Hello.
Sir, can I start? Okay, sir. My paper is on a comparative study on diathermy versus scalpel skin incisions in abdominal surgeries. Introduction. Surgical incisions are generally made with scalpel. Usage of scalpel results in skin bleeding, which obscure the operating time.
Slides
Other
are not
alternative
changing,
method in making
Dr. Prasanna.
skin incision is
The slides are not changing. Yeah.
usage of scalpel results in skin bleed incision is diathermy. Diathermy is mainly used for tissue destruction, especially for diathermy for making. Okay. టైం అయిపోతుంది. Sir, is visible?
Yes, it's visible. Make it.
Dr. Prasanna, stop your video camera, switch off, please. You start.
Post stop video అంట. Okay, okay, okay.
Dr. Prasanna,
you just go to show the slide full screen.
Yes, sir. Yes, sir.
start with slideshow and open your video camera.
Switch off your video camera. इनका bandwidth issue है, इस वजह से इनका audio कट रहा है, break हो रहा है.
Diathermy incision has certain significant advantages compared with scalpel because of reduced diathermy incision is not a true cutting incision. Diathermy hit cell within tissues rapidly that they vaporize, leaving the cavity within the cell matrix. Heat created disappears as steam instead of being spread to adjacent tissue. The moving electrode contracts and aims and objectives. Sir, is it visible, sir?
Yes, carry on.
Aims and objectives, sir. This study is to compare the outcome of diathermy incisions versus steel scalpel incisions in abdominal surgeries with regard to incision time, incisional blood loss, postoperative wound infection, and scar character. Materials and methods, sir. Study design prospective comparative study. Period of study August 2019 to March 2020. Place of study Department of General Surgery, ASICON Hospital. Sample size 90 patients. Group 1 patients, 45 members will be operated by scalpel incisions and 45 members will be operated via diathermy incisions. Ethical clearance approved by Institute of Ethical Committee ASTRON. Consent, informed and written consent from all patients between 15 to 70 years and who undergone electrolaparotomies. Exclusion criteria was emergency surgeries and individuals with cardiac pacemakers, those who did not give consent for the study. Procedure, all patients will receive preoperatively 1 gram ceftriaxone 30 minutes before surgery and repeated 12 hourly for 3 days. All the patients were operated under spinal or general anesthesia. Subcutaneous layer will be closed with Vicryl and skin with 2-ethylene. Skin sutures will be removed at postoperative day 10 after checking the tensile strength. Injection tramadol 100 mg will be given 8th hourly for 2 days. Incision time will be recorded, that is time taken from the initial skin incision to complete opening of peritoneum. Incisional blood loss will be assessed by weighing the Sock's pads. Wound infection will be assessed by asepsis score. Scar assessment will be assessed by Manchester score. Statistical analysis performed by using SPSS software 25th version. chi-square test to check the significance and measure exact value for p-value. Statistical difference level was set at p-value less than 0.05. My results are, in this study, mean age of patients was 50 years in diathermy group and 48 years in scalpel group. And in both groups, male predominance was seen. It is bar diagram showing hemoglobin level among patients operated with scalpel and diathermy incisions. Here, majority of patients had a normal hemoglobin. Mean hemoglobin was 10.9 gram percent, and it was similar in both the group of patients. None of the patients has hemoglobin less than 9 gram percent. It is diagram showing amount of blood loss in diathermy incisions. Lost 60 to 10 ml of blood, and in the steel scalpel incisions, majority of that is 88% members we lost significant here, less than 0.001. P-value was significant with relation to amount of blood loss. In diathermy group, 2.2% has blood loss in range 1 to 5 ml, and 53.3% has blood loss in the range of 6 to 10 ml, and 44% 4% has blood loss in range more than 10 ml. While in the scalpel group, 88% has blood loss more than 10 ml. P-value is calculated statistically significant. And here it is bar diagram showing wound assessment score in scalpel and diathermy incisions. Post-operative wound infection rate was similar for both groups and was not statistically significant. And in diathermy group, 31% of cases developed disturbance in wound healing, 64% developed satisfactory wound healing, and 4% developed minor wound infection. While in scalpel group, 66.6% developed satisfactory wound healing, and while 33.3% developed disturbance in wound healing. Mean incision length was 12.4 centimeters in group 1 and 2, and mean length of incision was comparable. The result showed significantly less incision time. Discussion. This study demonstrates that diathermy incisions were faster and were associated with significantly lower blood loss, and results are consistent with the study conducted by Shamim et al. In other study, Hussain and Hussain, it was concluded that postoperative pain is significantly less following the diathermy group. There was no significant difference in wound or postoperative complications between the two groups as noted by Kearns et al. Dix et al. Has shown that diathermy incision is more rapid than scalpel incision. Asepsis at surgical site. The percentage of surgical site in Gru et al. Concluded that Elfrock established a similar finding and said that postoperative infections are comparable in diathermy and scalpel groups. Ali et al. In the year 2019 proposed that diathermy can be used safely to make all type skin incision and started that SSI is 12.5% cases in diathermy, and the scalpel group it was 17.5%. This difference was not found to be statistically significant. Patil Shivagowda in his study 2005 pointed that electrocautery is safe in skin incisions, as his study showed a comparable result. My conclusion is diathermy incisions are equally prone to get wound infection as do the incisions made scalpel. Furthermore, lower incidence of less incision time and minimal blood loss are the encouraging facts after taking adequate precautions. Wound infection rate and scar character are insignificant among both incision techniques. Furthermore, recent increase in blood-borne diseases such as hepatitis C and human deficiency virus infection makes exclusion of scalpel from the operating field an attractive option. These are my references. Thank you, sir.
Dr. Prasanna, what are the drawbacks of your study? Am I audible?
Dr. Prasanna, there was a question. Answer that question.
Your sample size
Wound
was
infection rate
45.
was similar in both the groups, sir.
What would be an adequate
sir.
sample size? You had 45 patients in each sample.
Yes, sir.
So was
Yes, sir.
this an adequate sample size? Okay. You have measured blood 1 ml, 2 ml, and 5 ml. How did you measure the amount of blood loss?
Showcase of pets, sir.
How can you say it was a 1 ml or 2 ml or 5 ml? You have quantified these separately.
Yes, sir.
Okay, thank you. Dr. Vivek, would you like to ask something?
You took all the elective cases, no?
Yes, sir. Yes,
What
sir.
were the cases?
Only
Because
electric.
you said that 12.8 centimeter incision was the average incision size in both the groups. So what were the cases? Because the incision length will depend upon the
Elective
type.
laparotomy, sir.
Laparotomy for what? Laparotomy incision can vary from GP sternum to pubic symphysis to upper midline, lower midline, mid midline. That will be very variable.
Yes, sir. GP sternum to pubic symphysis, sir.
So all these patients were from GP sternum to pubic symphysis.
Yes, sir.
What was the indication for these cases? 90 cases.
Um,
Okay.
Malignancies.
You cannot give such a large incision in 19 cases in for any length of time. Either one or two cases is sufficient for 1 year to have some patient who requires such a big incision. Probably that may also not be required. And you said that the antibiotic protocol gave one dose of ceftriaxone at the time of induction and again 2 doses or 3 doses.
Yes, sir.
So based on what this antibiotic protocol was set, based on what policy, hospital policy or what thing, because all cases were elective, you didn't specify whether, how does the antibiotic, post-operative antibiotic protocol decided upon, based on what?
Based on wound characteristics, sir.
Wound characteristic. Wound will happen after the surgery. But then
We will
you have,
continue the antibiotics after surgery, sir.
in all cases.
Yes, sir.
Do you know what is the classification of surgery based on which you will decide the antibiotic, post-operative antibiotic? Some classification is there based on the type of wound, surgical wound, which will decide the antibiotic protocol.
Hello?
Yes. You know,
Hello?
clean surgery, clean contaminated
Yes, sir.
surgery like that.
Clean, contaminated, contaminated and dirty wounds.
So in all these, you will have a fixed antibiotic protocol.
No, sir.
Then you said that the antibiotic was fixed in all these patients. How did
No,
you
sir.
calculate the sample size of 45 in each group?
According to previous studies.
So whatever references you have quoted, they are all very old references, 2001, 2005, like that. Now this is 2020. So
Yes, sir.
probably this has been proven quite a long back that diathermy incision is, if not safer than the scalpel incision, it has got no difference. In some ways, it is better. Okay, thank you very much.
Yes. Thank you.
Do you have any other presentation?
No, sir.
Yes, sir. Dr. Prem Kumar.
Yes, Dr. Prem Kumar.
Dr. Sir, I'm Dr. Nakiran. I have just joined.
Dr. Nakiran.
Nakiran, yeah.
First one.
Okay, preoperative risk factors assessment.
Yeah.
Yeah, you can start with the presentation. 6 minutes is presentation time and 1 to 2 minutes for discussion. You can start.
Oh, are you seeing my slides, sir?
Not yet.
No. Share your screen. ये नहीं हुआ है वो तो भाई मेरे घर पे पड़ा है वैक्सीन को 50% जितनी ज्यादा जल्दी है मैं एक जैसे खत्म जल्दी करने पड़े पड़ी होती दूसरी को
Okay, good evening, sir. Assessment of preoperative risk factors in correlation with intraoperative difficulty in elective laparoscopic cholecystectomy. This is my paper presentation today. Introduction, cholelithiasis is one of the most common problem affecting the digestive tract. Laparoscopic cholecystectomy is the standard of care for the treatment of symptomatic cholelithiasis. Even though it's mostly safe in experienced surgeon hands, it can become difficult at times, resulting in complications like bleeding, bile duct injuries, and conversion to open procedure, resulting in increased morbidity. The most dreaded complication is common bile duct injury and its associated morbidity. So there is increased in the number of elective laparoscopic cholecystectomies nowadays, and it's being performed even in smaller hospitals with limited resources. In elective surgery, if cases have been identified, that is high-risk cases have been identified preoperatively, we can help in minimizing the complications and morbidity of the patients with resultant better patient care and satisfaction. And we can counsel the high-risk patients better, and we can counsel them about the chances of subtotal cholecystectomy and also the risks of open conversion. And we can also plan high-risk cases with well-experienced surgeons and who are good at bailout procedures so that patient morbidity can be minimized. So the aim of my study is to assess and identify the preoperative factors that are associated with intraoperative difficulty in elective laparoscopic cholecystectomy done at Department of General Surgery, Southern Railway Headquarters Hospital, Perambur, Chennai. And the materials and methods, study settings. This was study done at Department of General Surgery, Southern Railway Headquarters Hospital, Perambur, Chennai. And it was a prospective observational study. And the study population comprises of patients undergoing elective laparoscopic cholecystectomy in Railway Headquarters Hospital, Perambur, Chennai. And the study duration is from December 2018 to March 2020. And all the preoperative data, clinical and imaging ultrasound and the laboratory parameters were collected and they were put in the worksheet, and the intraoperative events were recorded and the results were analyzed using IBM SPSS version 22 software. And the inclusion criteria, patients admitted for elective laparoscopic cholecystectomy, and the exclusion criteria, and those patients who underwent laparoscopic cholecystectomy with CBD exploration and laparoscopic cholecystectomy done with other laparoscopic procedures in the same sitting, and patients who have absolute contraindication to general anesthesia. And the results, a total of 123 subjects were included in the analysis with mean age of 50 plus or minus 14 years, and the age range between 19 to 79 years. And the most commonest sex is female, about 61.6%, and 48 subjects were males. And difficult laparoscopic cholecystectomy was the outcome in 38 patients. And in my study, age, gender, and body mass index were not significantly associated with intraoperative difficulty. And previous history of previous admission for acute cholecystitis, prior history of ERCP, and history of chronic alcoholism and elevated alkaline phosphatase were associated with difficult laparoscopic cholecystectomy. And the ultrasound findings associated with intraoperative difficulty were contracted gallbladder and a GB wall thickening of more than 3 millimeters, and the presence of CBD stent and association of multiple gallbladder calculi. They were associated with a significant p-value. And these are the ultrasound findings and its relation with difficult laparoscopic cholecystectomy. You can see the contracted gallbladder and multiple gallbladder calculi and GB wall thickness more than 3 millimeters. Our p-value is significant. And comparison of difficult cholecystectomy in multiple studies. In my study, about 30.4%, that is 38 patients out of 125 had difficult laparoscopic cholecystectomy. And the difficult laparoscopic cholecystectomy, the end outcome in my study was chosen as either conversion to open procedure or a laparoscopic subtotal lap or open subtotal cholecystectomy, or the time duration more than 90 minutes. And these are the endpoints taken for a difficult cholecystectomy in my study. And it is similar to other studies. In Nidoni et al., it was around 30%, and in Bourgain et al., it is 35%. And in certain studies, the difficult cholecystectomy was higher because the patients included acute cholecystitis patients. And the commonest intraoperative difficulty findings in my study is moderate to severe adhesion, which contributed to the difficulty. And a contracted or fibrotic gallbladder is the next one. These two were the commonest findings associated with intraoperative difficulty. Vessel or duct anomalies contributed to 8 patients. And extraction difficulty due to over distension due to multiple calculi in 2 patients, and bleeding led to an difficulty in 1 patient. So these are the comparison of preoperative risk factors in multiple studies. In my study, as I already told, previous history of acute cholecystitis, prior history of ERCP, elevated alkaline phosphatase, alcoholism, gallbladder wall thickening more than 3 millimeters, contracted gallbladder, multiple GB calculi, and the presence of CBD stent were associated with increased intraoperative difficulty in elective laparoscopic cholecystectomy. These are the comparison with other studies. And in my study, there was no history of bile duct injury and there was no open conversion. And these are the comparison with other studies. So in conclusion, there are a lot of preoperative factors that are associated with difficult laparoscopic cholecystectomy. History of previous admission, prior history of ERCP, elevated LFT and alcoholism, and ultrasound findings, contracted gallbladder, wall thickening more than 3 millimeters, multiple GB calculi were useful in predicting high-risk cases. Adhesions were the most commonest cause for intraoperative difficulty, followed by contracted shrunken gallbladder. And the limitation is study population comprised only of railway workers and their family. This doesn't represent the general population profile, socioeconomic differences, and the variations in healthcare accessibility. And preoperative scoring system with the difficulty grading is not done in the present study. And the study population comprises only of 25 subjects. A large-scale prospective randomized control trial with difficulty grading and scoring system is required to provide more information on this topic. And so what are the recommendations from the study? The preoperative factors were useful in predicting high-risk cases in elective laparoscopic cholecystectomy, and a grading system can be developed with the above risk factors, and acute cholecystitis patients can be included in future studies, and comparison can be done about preoperative factors in elective and emergency settings. And in patients with preoperative difficulty factors, laparoscopic cholecystectomy can be planned with experienced surgeons who are good at bailout procedures, and resident training case allocation can be done by preoperative risk factor assessment. And these are my references. And thank you.
Okay, Dr. Nakiran.
Yes, sir.
Which lap cholecystectomy do you say that it is a difficult lap cholecystectomy?
In my study, any procedure that is converted into open or convert either a lap or open subtotal cholecystectomy, and a procedure duration more than 90 minutes is taken as difficult lap cholecystectomy. In the each steps, if there is more than 2 Veris needle attempts, then it is taken as also as a difficult access.
But you never in your presentation you said that all these points, what was the difference? How many patients had time duration more than 90 minutes? How many patients had multiple attempts of creating a pneumoperitoneum? How many patients they had a hemorrhage which was not controlled on laparoscopically? How many patients had a anomalous CBD biliary or arterial anomaly was seen intraoperatively?
I have mentioned there are 8
You have mentioned, but what were the numbers? What were the numbers? How many patients
only
took
one
time
patient.
more than, because you said that none of the patients you converted?
Yes, sir.
So by that one definition, that if it is taking more than 90 minutes, it becomes a difficult lap cholecystectomy. So this criteria was not met in any of the patients. So because once you are defining to identify the number of cases who had difficult lap cholecystectomy, you have to pre-operatively decide. These are the criteria based on which I will say that this is difficult lap cholecystectomy. Intraoperative difficult lap cholecystectomy. So you never mentioned what was your criteria of the, because one lap chole which may be difficult for me and I will convert it. At your center, the patient can be operated. A patient which I will take 2 hours can be operated within 30 minutes at your center. So you have to define, depending upon your expertise or your center, these cases I will label as difficult lap cholecystectomy. Second is that you said that you excluded those patients in which general anesthesia was not possible, and you included all the patients who underwent lap cholecystectomy. So were there any patient at your center who were operated without general anesthesia? That means in a spinal epidural or any other sort of anesthesia.
No, sir, open cholecystectomy. No, lap chole we didn't without
You
general
said that
anesthesia.
all patients who underwent lap chole were included, and in the exclusion you said the patient whom GA general anesthesia was not possible to give. So how these are two contradictory things. You understand my point?
Yes, sir.
Once you have included, out of those inclusions, you have to exclude now.
Okay, right.
How can you explain that multiple stone becomes a factor for different lap cholecystectomy?
Multiple stones may be due to hugely distended gallbladder with extraction difficulty.
Which gallbladder becomes more distended? A gallbladder which has got a single stone or a gallbladder which has got a multiple stone?
A single stone, if it is impacted at the GB neck, then it can get
Which gallbladder
over-distended.
is usually distended?
That will go for acute cholecystitis or acute presentation. Whereas patients with loaded with multiple stones can be due to the stone volume, the extraction difficulty can be there.
So all these factors, they are pointing towards your operative time, which you have not mentioned what was the time during surgery.
Okay.
Usually the single stone, if it has got more chance of getting impacted and causing all sorts of complications locally in the gallbladder. Small stones, they cause complication if they slip out of the gallbladder. Okay, Dr. Babu, you can go.
Yes, Dr. Nakiran, how was your study different from previous studies?
There was many studies that were done, but all included acute cholecystitis patients. Because in nowadays there are a lot of elective laparoscopic cholecystectomies, and also in our hospital we perform almost a majority of the patients with elective laparoscopic cholecystectomy. So we started the study only including elective laparoscopic cholecystectomy. So how the factors and the parameters are helpful in predicting it.
I think these studies have been conducted previously also. So was it anything new that you found in your study?
In my study, the laparoscopic subtotal cholecystectomy we have done in about 22 patients, which helped in avoiding bile duct injury and also open conversion.
In your study, you have said that sex is not a predisposing factor, whereas various studies say that in a male gallbladder is more difficult.
Yeah. There are many studies who show male sex has increased incidence of complications. That is due to the male having tendency to bear pain and presenting it late. And in my study, sex is not an significant risk factor.
Next, coming to obesity.
Yes, sir.
In your study, obesity was not a risk factor for conversion to open.
Yes, sir. In my study, obesity is not a risk factor for conversion to open. There are many studies having contradictory views. Some studies show BMI is a significant factor. Some studies didn't show BMI as a significant factor.
What was the BMI you were considering as obese patients?
About 30, sir. 30 and above.
Okay, fine. Okay.
Sir, you are not audible, sir.
Hello.
That's fine. Dr. Vivek, we can go ahead.
Yes, yes. Next presenter, Dr. Prem Kumar.
Thank you, sir.
This is Dr. Prem from KPU Medical College, Tiruchi.
Dr. Prem Kumar.
From KPU Medical College, Tiruchi, sir. Hello?
Yes. Please share your screen.
Yes, sir. Share my screen. Yes, sir. Sir?
Is my screen visible?
Hello, sir.
Hello?
Hello?
Dr. Prem Kumar, please share your screen.
Yes, sir. Sir, someone has shared a screen. I couldn't share. I'm not able to share the screen, sir.
Share your screen.
Yes, sir. Sir, a case presentation on walk syndrome. Can you see, sir?
Yes, yes.
Make it slideshow.
Yes, sir. Sir, can you see, sir, a case presentation on walk syndrome? Can I present, sir?
Yes.
Yes, sir. My name is Prem. I would like to present a case presentation on walk syndrome. A series of 3 cases will be presented in the following PowerPoint. So it was stuck. Hello, sir.
Yes, sir, go ahead.
Yes. Case 1. Hello, sir. It's stuck.
Hello. Hello. Hello, Dr. Prem Kumar.
Yes, sir. I'm here, sir.
You share your screen.
Yes, sir. Someone is interrupting.
Any problem, sir?
Yes, sir.
Some problem?
Yes, sir.
You just go. First, you open your presentation and go to share screen.
Yes, sir. Not able to share the screen, sir. Here.
You use a laptop, iPad. Hello.
Sir, not able to share my screen, sir. No, sir. Wait a minute. Wait a minute, sir.
Okay. Next is Dr. Shehul Anna. Dr. Shehul Anna. Dr. Shehul.
Hello, sir.
Can you hear me?
Yeah, I can hear me, sir. Can you hear me, sir?
Yeah, just share your screen.
Yeah, one second. Hello, sir. Can you hear me, sir?
Yes, yes. You start.
Sir, good evening, sir. This is Dr. Shehul from SRM Medical College, postgraduate. Hello?
Slideshow, please.
One second, sir. I shared already. So can you see me the slideshow, sir?
Yes, slide is see.
Yeah.
Not full screen. You try again. Stop screen and try again. Share screen.
Okay.
Yes.
I am next presenter, Dr.
Sir,
ऑल इंडिया लेवल और सर इसका पेपर नंबर जो है ना नीचे सर इसका पेपर नंबर और ये
sir, 1 second, sir.
डॉक्टर
So someone has shared the. Someone has shared, sir.
Sir, this is Dr. Hello, sir.
Okay.
Hi, sir. I would like to start. Can I present, sir?
Yes, yes.
Go ahead.
Yes, sir.
Okay.
Last week, Jama.
Sheol, after this, you.
Yes, yes, sir, sure.
Dr. Prem?
Yes, sir. Case presentation on walk syndrome, sir. A 2-year-old female brought to the emergency room with the complaints of abdominal pain and vomiting of one day duration. On examination, the child appeared dehydrated and tenderness, fat tenderness all over the abdomen, with rebound tenderness in the left iliac fossa. The abdomen had a fullness over the left iliac fossa with a decreased bowel movement. On digital examination, per rectum was found to be normal. On nasogastric aspiration, bilious fluid was aspirated, and we have done all the biochemical investigations which are within the normal limit, except there is a leukocytosis. And the ultrasound of the abdomen was suggestive of small bowel intersusception. Patient was taken for immediate laparotomy, and before which patient was adequately hydrated and was taken up for the exploratory laparotomy with a preoperative diagnosis of jejunal perforation, jejunal intersusception. Upon exploration, and long segment of the iliac intersusception without gangrene was found. A simple reduction of the intersusception was done. The findings were found to be hypertrophic Peyer's patches was noticed with a viable intersusception. On further inspection of the abdomen cavity, a malrotation of the gut was found, along with a cecal mass. LAD band, LADS band were found, and they were released with the resection of the cecum from 2 cm proximal to the ileocecal junction, and followed by the end ileocolic anastomosis was done. The cecum was the gangrene, so it was removed. So cecum was removed, gangrenous portion was removed, and then ileocecal anastomosis was done. This is a picture showing the LADS band and the gangrenous cecum, which was removed. And then the fourth picture, which was showing the ileocolic anastomosis, which was done. And the patient was on POD4. The patient was improved well and taking oral feeds. After POD7, the patient was prognosis was good. Just prognosis was good in this patient with a case of malrotation of gut with intersusception, a case of walk syndrome. And then the similar case I found in the emergency department. A 1-year-old female child came with the complaints of bleeding per rectum for past 1 day. 3 episodes of bleeding per rectum were noticed by her mother. On examination of the abdomen, there's a stepladder pattern was seen and a mass palpable at the epigastric region. On doing PR, there's a bleeding per rectum was present. Patient was clinically diagnosed as a small bowel intersusception with obstruction. On doing ultrasound, we have found an intersusception of the small bowel, and the patient was hydrated and resisted, and the patient was immediately taken up for laparotomy. This was the child, 1-year-old child. You can see the step ladder pattern here. The first picture which was shown here was the intersusception, and the second picture was shown here was a LADS band, which is associated with the malrotation of gut. And the findings after proceeding with the laparotomy, we have found ileocolic intersusception, which was present, and the LADS bands also present, and dilated duodenum with the DJ flexure found to be on the right of spine. Usually DJ flexure usually found on the left of spine. Usually warm and the procedure were followed. Using warm pad, the interception was reduced manually. Malrotation was confirmed, and by the presence of free ascending colon with the lance band. And the distal flexure was noticed to the right of the spine, which was abnormal. And the lance band were released from right paracolic gutter to the right colon and to the gallbladder over the duodenum. Duodenum were cock-raised and straightened. And the duodenocolic isthmus, which was the mesentery, was widened. This is the last procedure which we have done. And then the appendicectomy was done. Then the small bowel placed over the right side and the large bowel placed over the left side. Then the wounds were closed in layers. And the patient was, in this patient, prognosis was good because of the immediate laparotomy. And the patient was at the POD6, the patient was improved well. And the sips of fluids were started on POD6. And then the patient was discharged on POD10. And the case 3, a 2-month-old child present with complaints of similar abdominal distension with bleeding per rectum, 1 episode. On examination, the abdomen was distended with absence of bowel sound. On doing PR, we have found the similar findings. Blood staining was present. Then we have done serial ultrasound immediately. Then we have found the interception as a diagnosis. Patient was taken for emergency laparotomy. Intraoperatively, patient found to have a ileocolic interception with latch band, and the patient was immediately proceeded for laparotomy. And the similar latch procedure were performed. In latch procedure, usually the first thing we have doing was reducing the interception. Then the second thing, cock-raising the duodenum. Then releasing the latch band, third step, and then we will do appendicectomy, is the fourth step. Then placing the small bowels on the right side, on the colon on the left side. In this patient, on POD5, patient was started on oral fluids. Child able to take milk, and then patient was passed stools on POD7, and then POD10, the patient was discharged. This is the interception found in this child. On discussion part, interception may be associated with malrotation in a condition called Walk syndrome. The pathophysiology involves easy prolapsing of the ileocolic region into the large colon found in children with malrotation. Because of the ascending colon was not fixed to the retroperitoneum. The interception was advanced into the descending colon and rectum without compromising the vascularity of the bowel. At the time of the surgery, these dual condition, the diagnosis is made by the pathological presence of peritoneal band from the ascending colon across the duodenum and the location of the cecum. Yes, sir. My conclusion was, Walk syndrome must be kept in mind while managing any acute condition. In additional clinical signs should be suspected to rule out malnutrition. So, in my conclusion was that in any acute condition, neonate or a pediatric age group, we should suspect a malnutrition with the interception. This is my paper, sir.
Nice work done, doctor.
Sir?
In your institute, nice presentation. In your institute,
you,
all
sir.
patients of intussusception,
Yes,
do
sir.
you take them for surgery or do you plan for conservative measures also?
Sir, in my institution, we usually doing laparotomy, emergency laparotomy, sir. No
Once the
conservative.
diagnosis of intussusception is made, you will take all patients for laparotomy.
Sir, depending on the vitals, no, I have not
It's
seen
a VAS syndrome, so that
Yes,
is an intra-op finding. In that case, you have to go for surgery. If supposing it's a simple ileocolic intussusception,
Yes, sir.
that's why I'm trying to ask, will you like to go for a manometric reduction or straight away put the patient for surgery?
Sir, manual reduction, we have tried, sir. In the previous cases, I have tried, but the recurrences are more common, sir. Because of the we are doing only the reduction of the intercepts there, and the latch band malrotations are missed. By doing so, we have been missing the malrotation, sir. That's what I'm stressing in this paper, sir.
So how common is VAS syndrome?
Sir, in our institution, so far I have seen 6 cases, sir. Now I have presented only 3 cases, sir.
Actually, it's a rare diagnosis.
Sir? Intraoperatively
Actually,
only we have diagnosed, sir. Preoperatively it was diagnosed only as an intersusception we have diagnosed, sir. Only it's these presentations all are intraoperative diagnosis, sir. It's all made only intraoperatively, sir. Sir, am I audible, sir?
Dr. Vivek.
Sir?
Yes, yes, yes.
Sir,
Dr. Prem Kumar.
yes, sir. I couldn't hear any questions.
Yeah. To which institute do you belong?
Sir, I am from KP Medical College, Trichy, sir.
Not mentioned it in your introduction slide, your institute name.
Yes,
What
sir.
is LAD procedure? We have written the spelling 3 times at 3 places of the LAD.
Yes, sir. Sir, yes, sir.
What is the LAD procedure? What is the correct spelling?
LADDS. That's procedure.
Apostrophe.
Yes, sir. Apostrophe, yes, sir. Yes, sir.
We have written it all capital, somewhere only LAD. What
Sir,
is
because
this actually?
not very mature in typing, sir.
Okay.
Yes,
So
sir. That's what.
what is the procedure exactly?
So the procedure was done in malrotation of guts, where the large bands are present, sir.
What are the LAD bands?
Large bands are the retroperitoneal band, which is attached from cecum and the part of acetylcholine to the retroperitoneum of abdomen, sir. The duodenal jejunal flexure usually lies to the left of the spine, sir. In these conditions, DJ flexure usually lies at the right of the spine. So we are doing cauterization of the duodenum, sir. And then we are doing the release of the large bands, sir. Then after the large bands are released, we are doing appendicectomy, sir. In future, in order to avoid we have confusion with appendicectomy. We are doing the appendicectomy, sir. Then placing the small bowel on the right side, large bowel on the left side, sir.
Why do you add appendicectomy in the LAD procedure?
Sir? Sir?
Appendicectomy.
Sir, appendicectomy was done in future. In future, the child may face conditions will confuse, sir. The terminal might be in right, left hypochondrium, left iliac fossa. So in order to avoid confusion with the acute abdomen, we are doing appendicectomy.
Reason from what?
Sir, sir, I couldn't hear, sir.
I think weapon events, lots of background noise is coming from your side. So
Yes,
mute
sir.
your mic.
Sir.
So how you have to rule out the confusion of appendicitis with what condition?
Yes, sir.
With what condition?
Sir, in acute cholecystitis, pancreatitis, might mimic like appendicitis, sir.
That happens to any patient. So whenever there is a laparotomy, you should do appendicectomy.
Sir, whenever there is a sir.
So that may happen to any individual. So whenever you are doing opening the abdomen, you should always remove the appendix.
Sir, but malrotation in these childs are different, no, sir. Malrotation child, we are placing the small bowel on the right side, sir.
What is more in malrotation as compared to a normal child or a normal individual?
Malrotation, there are 3 types, sir. Malrotation, non-rotation.
Okay, no problem.
Yes, sir.
Next presentation.
Dr. Priyank.
Yes, sir. Am I audible?
Yes, yes. Please share your screen.
Is it visible, sir?
Yes, yes.
Okay. Okay. So my today's topic is study of myself, Dr. Priyank Menon, and I'm from BJ Medical College, Ahmedabad. Today's my topic is study of clinical presentation of polylithiasis and predictive factors that are responsible for difficult laparoscopic cholecystectomy.
Please start the timer.
Of the studies to analyze the patient profile and their management with possible outcome of complications in these patients. 100 patients were selected who were admitted to Civil Hospital Ahmedabad, and they were studied retrospectively. And parameters like age and gender distribution, mode of injury, clinical presentation, investigation, hospital stay, conservative or either operative management, and their possible outcome were studied in these 100 patient cases. And the results were out of 100 patients, 23 were male patients and 77 were female patients. 36% patients are from the 31 to 45 years of age, with mean age of 44.96 years. And the age group of the patients in this study ranged from the 17 years to 81 years old. And out of 25 patients, 97% patients had a chief complaint of pain in right hypochondrium and epigastric region. 47% patients presented with nausea and vomiting. 9% had the jaundice, and 25% patients had a tenderness into the right hypochondrium. 3% patients were asymptomatic and were diagnosed incidentally. 4 out of 25 patients had past history of cholecystitis present. Difficulties found during laparoscopic cholecystectomy included the extraction of gallbladder after resection in 12% of cases, difficulty in grasping of gallbladder in 10% of cases, clipping of cystic duct 9%, dissection of gallbladder from the liver bed 8%, callus dissection 7%, while bleeding 5%, and port entry difficulty 4% in these cases. Introduction. In 1985, Eric Murray and Moret from France performed the first laparoscopic cholecystectomy. Since then, the laparoscopic cholecystectomy has evolved progressively due to its improvements in optics and instrumentization due to miniaturization of instruments, and trocar sites are continued. It is now possible to perform a straightforward elective laparoscopic cholecystectomy, avoiding the open surgical procedure, using one 10 or 12 mm port and 2 or 3 ports as small as 2 to 3.5 millimeter. And this procedure is a flagship of laparoscopic surgery and the benchmark for all laparoscopic surgery in terms of efficacy, safety, patient acceptance, and market penetration. It is the foundation of laparoscopic surgery. Like any other surgery, cholecystectomy can be difficult to perform in the disease state due to anatomical abnormalities or due to patient or surgeon factors. These factors can make laparoscopic surgery difficult and increase the chances of complications in these patients. Higher conversion and iatrogenic injuries are associated with difficult gallbladder operations, and conversion rates ranging from under 5 to 30% have been reported. Commonly encountered difficulties are peri-gallbladder adhesions and mass formation, difficult port entry and access to the peritoneal cavity, whereas distended and friable gallbladder with difficulty in holding adhesions around the callus triangle and during gallbladder dissection from the liver bed and while extending the gallbladder have been evident. I have studied a total number of 100 patients from October 2017 to October 2019, and that fell in the inclusive criteria. And patients were followed from the time of admission, perioperative period, till the time of discharge with a preoperative routine investigation. And the operating details like circumstances of conversion or reasons for conversions were recorded in the cases. Cases were selected on the basis of the following criteria. Inclusion criteria included the patient undergoing laparoscopic cholecystectomy straightforward for gallstone disease, age more than 18 years, and patient giving consent. While we have excluded the patients less than 18 years and who were unfit for general anesthesia, ASA 4 or more, and not giving the consent. And after initial resuscitation, initial assessment, all patients were investigated by detailed history, physical examination, routine blood investigation, and radiological imaging, and USG, abdomen, pelvis, and thorax for the assessment of the patient preoperatively. The results shown in this group is as we have included from 17 years to 81-year age group of the patients, maximum age distribution for laparoscopic cholecystectomy falls between 31 to 45 years age, that is 34% range. The second most common group is 46 to 60 year group, and accordingly 20%, 22% is carried by 15 to 13 years, and more than 60% concentrates on 12% of patients. In my study, out of 100 patients, 23 patients were male and 77 patients were female, more contributing the gender distribution towards the female aspect. Percentage of female and male patients converted to open surgery. In my study, the male preponderance was more towards the male sex, converting the surgery to open cholecystectomy. Percentage of symptoms in patients of gallstone disease, that's 97% majority of patients had complaint of epigastric and right hypochondrial pain, followed by some 47% having encountered nausea and vomiting, and 25% patient had right hypochondrium tenderness present, and 9% had evidence of jaundice present. Different radiological factors and included in this data, and its a percentage of prevalence in different studies were evaluated. Gallbladder thickness was in my study, the gallbladder wall thickness was the parameter which was deciding the conversion, as less than 4 mm of thickness had the safe laparoscopic cholecystectomy, while greater than 4 mm of thickness had conversion into open cholecystectomy. Status of gallbladder, 92% of patients had distended gallbladder, while 8% had the contracted gallbladder, and full fluid collection around the gallbladder was present in only 8% of patients, while 92% had absence of it. And number of calculi, patient with undergoing the laparoscopic cholecystectomy in my study had a majority, 56% had multiple calculi, while the remaining had the single calculi. As we can see from the diagram also, the percentage of the main concentration is based upon the gallbladder thickness having less than 4 millimeter of thickness, with distended GB, with absence of pericholecystic fluid collection, and having calculi having going towards the laparoscopic cholecystectomy. And here is the main factors that are deciding the percentage of various difficulties encountered in present study. Majority is found with the extraction of GB after resection, that is 12% in this case. Then grasping of GB as a difficulty is found in 10% of patients. Clipping of cystic duct is difficulty as a difficulty found in 9% patient, and dissection of GB from the liver bed due to its dense adhesion and a conversion into open surgery is found in 8% of patient, and callus dissection difficulty is found in 7% of patient, and bleeding from the cystic artery or right hepatic artery is found in 5% of patient, and port entry difficulty was found in 4% of patient. Conversion to open surgery, the main reason while converting the laparoscopic procedure into open surgery in my study was bleeding in 4 out of 5 patients, and difficulty in Calot's triangle in 1 out of 5 patients. The surgery was performed by experienced surgeon in all patients, so who had performed more than 15 laparoscopic cholecystectomy, so that aspect was excluded. Source of bleeding was cystic artery in 3 patients, from the liver bed in 1 patient, and possibly from aberrant right hepatic artery in 1 patient. The surgery that were converted to open surgery was performed by experienced surgeon only. So there was no association between surgeon's experience and difficulties encountered in present study. Intraoperative difficulty found, as we had seen from the graph, these were the points which were deciding the difficulty found in the intraoperative procedure. Either it could be dense adhesion or a separation of gallbladder from the liver bed, or a clipping of the cystic duct or cystic artery, or port entry or the operative time. Definition is a difficult port entry means more than 20 minutes required to create a pneumoperitoneum after induction. Second is a difficult grasping gallbladder that needs a special instrument for grasping, or need of evacuation of gallbladder before grasping is required.
Are you able to hear me?
Yes, sir. Yes, sir.
You conclude now.
Conclusion and recommendation. In my present study, gallstone disease were more common in females than to males with a ratio of 1:3. The most common age presentation is between 31 to 45 years with a mean age of 44 years. And majority of patients, 97% had chief complaint of right hypochondrial pain was present. USG is the most economical, simplest, easiest, and initial tool for the evaluation and assessment of gallstone disease and for the assessment of the hepatobiliary system. Thickened gallbladder with the wall thickness greater than 4 mm, pericholecystic fluid collection are the significant predictors of difficult laparoscopic cholecystectomy. Previous history of acute cholecystitis and BMI of greater than 27 were the also significant predictors for difficult laparoscopic cholecystectomy in my study. 5% of patients were converted to open surgery, and main reason being the bleeding and difficult callus dissection. Laparoscopic cholecystectomy is a safe and reliable surgery.
Okay, I think we should stop now. Any more
Yes,
slide
sir.
is there?
Yes, sir. It's the end of the slide.
Okay. So did you hear the previous presentation?
Yes, sir.
I think you both have common problems with the presentation. But still 2 points which are there, that if you include a patient who has given consent,
Yes,
then
sir.
you cannot exclude that patient in the way that the patient did not give consent. There were many mistakes in your presentation, like all the patients after adequate resuscitation. What resuscitation you need to do in a lap cholecystectomy patient?
No, sir. Primary assessment, sir.
USG abdomen, pelvis, and thorax. What is USG thorax? You said that almost 44% out of 44 out of 100 patients they presented with single stone. What is the cause of single stone?
Cause of single stone.
What type of stone is a single stone? How common
Pigment
is
stone.
Pigment stone is a single stone. How common do you find? Almost reaching 50% of the stones they are single stones.
Yes, sir.
No, that is wrong. How many surgeons have operated?
Sorry, sir.
How many surgeons operations you have recorded? Was it all the cases were operated by the single surgeon or different surgeons?
No, it was performed by different surgeons.
Okay, thank you.
Yes, sir.
Dr. Babu?
You have said that your period of study was almost this year, 2020, and we have been having COVID over here. And most of the associations were giving guidelines that do not go for laparoscopic cholecystectomy. So what were the guidelines you were following at your institute?
Sorry?
Almost whole of this year, due to COVID, most of the surgical associations were saying
Yes, sir.
that avoid laparoscopic cholecystectomy. And you had done laparoscopic cholecystectomy during this period. So what were the protocols that you were following?
First, we have to rule. First, we have to.
I meant to ask that were you routinely performing laparoscopic cholecystectomies during this period?
No, sir. No.
But in your study, you have said that the period of study is almost this year only.
No, sir. It is from October 2017 to 2019.
Dr. Srivastava, time is up.
Okay, sir. Let's move ahead.
Time is over.
Dr. Vivek, let's move ahead.
Hello.
Hello.
सर आपका हो गया?
Sir, I'm Shaykhul now, sir.
Shaykhul है ना?
Yes, sir.
Yes, please.
I'll share my screen, sir. Sir, you can see my screen, sir?
Yes, yes.
So good evening, sir. This is Dr. Shaykhul Anam from SRM Medical College, sir. My case study is I'm doing prospective study comparing the clinical abdominal scoring systems with the blunt trauma blunt abdominal trauma severity scoring in predicting the necessity of the laparotomy admitted in the SRM Medical College and Research Center, Chengalpattu, Chennai. So, abdominal trauma is one of the most common causes among the injuries caused mainly due to road traffic accidents, accounts for 75 to 80%. The knowledge in the management of blunt abdominal trauma has progressively increasing due to inpatient data gathered from different parts of the world. In spite of the best technique and advances in diagnostic and supportive care, the morbidity and mortality remains at large. The reason of this could be due to interval between the trauma and the hospitalization, delay in diagnosis, inadequate and lack of appropriate surgical treatment, post-operative complications and associated trauma, especially to the head, thorax and extremities. In view of increasing number of vehicles and consequently road traffic accidents, this topic has been chosen to study the cases of blunt abdominal trauma with reference to the patients presenting at SRM Medical College Hospital Research Center, Chengalpattu. To evaluate the most common cause of blunt abdominal trauma, to evaluate the objectives includes to evaluate the most common cause of blunt abdominal trauma, to evaluate the impact of a blunt abdominal trauma on intraperitoneal organs like liver, spleen, hollow viscera like stomach, small and large intestine, and to evaluate the various mode of presentations in the abdominal trauma. To determine the value of clinical abdominal scoring systems, a new scoring system based on clinical science comparing with the blunt abdominal trauma severity scoring system in predicting whether a blunt trauma abdominal patient needs laparotomy or not. Pathophysiology, the patients with the blunt abdominal trauma in general injuries can be classified as higher energy or lower energy. Blunt trauma causes damage from combination of compression, shearing, and bursting forces. Sudden pronounced increase in intra-abdominal pressure created by outward force can cause rupture of hollow viscera or can cause burst injuries of solid organs. Compression of abdominal viscera between the applied force to the abdominal wall and the posterior thoracic edge of the vertebral column can produce a crush injury. Abrupt shearing forces can cause a tear of organs or vascular pedicles. Oblique forces and deceleration injuries causes shearing of viscera where anchored, such as at the due to DJ flexion and peritoneal attachment of the bowel. Deceleration injuries occurs in high-speed vehicular accidents and fall from greater heights. On impact, the organs continue to move forward at the terminal velocity, tearing of the organ at the site of attachment. So the organ-related incidents, most common is the spleen, 46% is the most common injuries. Next is the liver, 33%, and mesentery, 10%, and urological, 9%, pancreas, 9%, small bowel, 8%, colon, 7%, and duodenum, 5%. Vascular injuries will be 4%, and least will be the stomach, 2%. So diagnostic methods includes ultrasound of abdomen that demonstrate the presence of free intraperitoneal fluid as well as the extent and precise location of solid organ hematomas. FAST includes evaluation of the torso for free fluid, suggesting injury to the peritoneal, pericardial, and pleural cavities, particularly in case of trauma. E-FAST examination includes view of bilateral hemothorax to assess for hemothorax and view of bilateral upper anterior chest wall to assess for pneumothorax. Plain radiography and contrast studies. So air under the right dome of diaphragm may be found in patients with the gastric, duodenal, intestinal, and colonic perforations. Abdominal CT scan is the next one. Step important role in the evaluation of blunt abdominal trauma when applied in appropriate settings, like when higher multi-specialty hospital. Angiographic studies, limited value, abdominal iotography or selective visual angiography is useful in the diagnosis and management of solid intra-abdominal pelvic bleeding. Radionuclide imaging, a non-invasive nature of isotope studies, screening procedure not freely available in most centers, and laparoscopy, the final court of appeal in diagnosing blunt abdominal trauma. Clinic injury, it is a single commonest visceral organ to rupture following blunt trauma. It is usually an avulsion from the pedicles, multiple fissure fractures, and an enlarged spleen, splitting on its outer aspects to produce either a tear or a subcapsular hematoma. Less usually is a small tear in the anterior aspect of film, which may produce severe bleeding but will escape from the direction. Secondly, most commonly injured organ. Secondly, most commonly injured organs, incidence being 35 to 45% of patients with abdominal trauma, 40% of the patients with stab injury, 40% of the patients with stab injury to the abdomen, and 30% of the patient with the gunshot wound to the abdomen. Mechanism of injury. Blunt injury results from direct blows, compression between the lower ribs of right and the spine, or shearing at a fixed point secondary to deceleration. CT has clearly become the gold standard among the imaging modalities. Management of active bleeding liver by various techniques like manual compression, portal triad occlusion, placement of perihepatic packs, direct clamping of liver parenchyma, direct suture of the liver, and application of liver tourniquet. Small bowel injuries, owing to the large volume of peritoneal cavity occupied by the small bowel, is the third most frequently injured organ following the liver and spleen in blunt trauma. Small intestine injury occurs 5 to 15% of cases of blunt trauma. Three mechanisms: crushing or direct impact injury, shearing injury, and bursting injuries. Cave injuries, kidney ureter bladder injuries, 8 to 10% of all blunt and penetrating traumas. Minor injuries, contusion, there's a bruising of renal tissue and macro or microscopic hematuria. No gross parenchymal damages. Lacerations, when there is a radial laceration across the kidney up to the surface or up to the calyces, but no fragmentations. Major injuries, rupture. When laceration are through and through, thus causing fragmentation of kidney. Blood supply of the small fragments may be jeopardized. Shattered kidney, when there is a multiple fragment of kidney, many of them are devascularized. Pedicle injury to the major blood vessels of the renal pedicle or without parenchymatous injuries. Effect of injuries can be classically described as an intraperitoneal and extraperitoneal injury depending on the site of injury.
Anam, you are going to present your study, still you have not started with your study. Is it something review what you are presenting? Your time is already over.
So case study, the
Your time is already over. Can you see the timer?
Please.
You come to your results straight away.
So based on the comparative study in the both, sir. So conclusion is that it is demonstrated by this study that CASS scores was significantly higher in patients during requiring laparotomy. Calculation reveals CASS as specificity of 100% sensitivity of 50% is positive predictive value of 100%, negative predictive value of 78.7%. And blunt abdominal trauma severity score, clinical examinations combined with the radiography and USG to obtain this score. Our study report that a value more than 12 can be stronger predictor for laparotomy with the specificity of 100% sensitivity of 83% of false predictive value and negative predictive value of 91.3%. A value of 12 or more in either scoring system is associated with the need of laparotomy, and such patients should be planned for laparotomy as soon as the patient is receiving casualty. A value of 8 or less in bad scoring systems are associated with no mortality or no need of laparotomy and no need further imaging. Hence, could be superior to CASS. This was a prospective study for 100 cases of penetrating, non-penetrating abdominal trauma in SR Medical College. So non-penetrating abdomen is a major cause of morbidity and mortality of young and economically productive age group. Road accident is a major cause of agents. Males are predominantly affected. 21 to 30 years is the most common age group. Most common organ injured in the present study was spleen. So small bowel is the second most common injury. Majority of them are injured with managed by suturing. The present study shows a mortality of 8%. So a conservative line of management is safe and effective and hemodynamic. So CAS and bad systems of trauma severity scoring and setting of blunt abdominal trauma and segregating patients into low risk, medium risk, and high risk categories. So lower values are associated with no or low need of laparotomy and no mortality, no need of further imaging like CT scan. Higher values are associated with increasing need of laparotomy and increasing mortality. Thank you.
Your study is a clinical scoring of patients of blunt abdominal trauma, but from this whole presentation, we could not know how did you do the clinical scoring.
Sir, let me show it, sir. Let me show the screen.
Sir, next
So based on the ultrasound examinations, we have 100 we have subjected, we started the study, sir. So 37 patients has scan detected the solid organ injuries. 90 patients scan detected.
Your topic is clinical assessment of abdominal traumas.
Yes,
So you are trying to say that ultrasound is an extension of clinical examination.
Ultrasound is yes, sir, yes, sir. It's the initial and emergency fast we have to do it, sir.
Like you have SOFA for shock. Similarly, do you have some scoring systems, clinical scoring systems for abdominal trauma?
So clinical abdominal scoring system is the classified based on the pulse rate, systolic blood pressure, Glasgow coma scale, abdominal clinical findings, sir.
Hello.
Hello.
Dr. Vivek,
so
please.
Time is over, sir.
So low risk up to 8, medium risk will be 9 to 11, and high risk will be 12 or more.
Hello.
Hello.
Do we have any other presentation?
Hello. I think it's always on. Hello.
Hello. Is it over?
Yes, sir.
Okay. Dr. Samrin Zafar is not there, I think.
Hello. The next session is presenting. Hello.
The
So,
session is to start now, na?
okay. So this session is over.
Yes, sir. Hello.
You can leave the meeting.
Yes, sir.
Okay, Dr. Vaibhav. So, what about the marks? How to give the marks? You have to mail it. Hello, Dr. Vaibhav.
Sir, this is a free paper session. So in this, do we need to give marks?
Because they have given a chart paper in the mail.
Right, sir. Okay,
Okay. So we'll revert back on the mail itself.
That's all for now, sir. Should we leave?
Yeah, I think so. Okay, thank you.
Dr. Paramiti. Dr. Paramiti.
Yes, I'm here.
मैं बैककॉम
Hello.
साइड से बोल रहा हूँ. नेक्स्ट सेशन स्टार्ट.
Can you hear me? Yeah, yeah. Next session starts, right? Okay.
Yes.
Session 7, ma'am.
Yes.
Yeah, thank you, thank you.
Dr. Yogendra Datta. Yogendra Datta.
Session 7, yes.
Yes, sir.
Please share your
Hello.
screen.
Okay, sir. I'm good.
Hello. Hello.
Hello. Yes. Yes, Dr. Rath, please start.
Yeah, okay, ma'am. Ma'am, I'm going to. Ma'am, am I visible, ma'am?
Yes, yes. Please
Hello.
start.
My screen is visible. My
Yes,
slide.
you are visible, but I think you need to go back to your first slide. Yeah. Yes, your
Good
screen is
evening,
visible.
everyone.
You can start, doctor.
Okay, ma'am. Good evening, everyone. Myself, Dr. Jagannath Ratha from High Tech Medical College. I am going to present a paper, study of clinical and methods to differentiate perforated appendicitis from the non-perforated appendicitis. Introduction. Appendicitis is one of the most common acute abdomen and one of the most common cause for which emergency surgical intervention required. There are two types of appendicitis, simple and complicated. Treatment mortality rate increases in many folds in case of complicated appendicitis with respect to simple appendicitis, as in case of gangrene appendix. In the continued absence of 100% accurate test for appendicitis, any investigation test that can contribute to its diagnosis is valuable. The diagnosis of appendicitis is mainly based upon the history and clinical examination. When the diagnosis is not clear, further investigation may include ultrasound or CCT of abdomen and pelvis. A negative and incorrect diagnosis ensures the cost and potential complication for the unnecessary operation, such as in case of mesenteric adenitis in ovarian cyst or inflammatory bowel disease. Aim of the study to study the clinical and biochemical parameters in case of appendicitis. In the clinical symptoms, sign, and biochemical parameters that can help to differentiate perforated from non-perforated appendicitis. Details and methods. The proposed cross-section study was conducted in Department of High Tech Medical College Bhubaneswar, period of 18 months. Study population, all the suspected cases of appendicitis admitted to the surgery ward are included after information from the patients or relatives. Inclusion criteria, all the patients admitted in our emergency ward of surgery in suspected cases will be taken for the study. Exclusion criteria, pediatric age group, pregnant ladies, patients having comorbidities like heart disease, stroke, tuberculosis, epilepsy. Methodology, the variable analysis include age, sex, time, and onset sign and symptom to the date of operation, operative finding. For the collection of the data, pre-designed questionnaire will be used for following points: pain in the right iliac fossa, Murphy's shift, fever, nausea, vomiting, anorexia. Sign: tenderness, fossa, rebound tenderness, distension of the abdomen, guiding rigidity, diffuse tenderness, bowel sound, rupturing sign, cough, Uswas test, operator test. Protein laboratory investigation, complete blood count, C-reactive protein, random blood sugar, blood urea, serum creatinine, and liver function test include serum pregnancy test, other tests like chest X-ray, ultrasonography, ultrasonography of abdomen, pelvis, electrocardiogram. Result: total 60 patients included in my study, after which put in two groups, and that is acute appendicitis group, 49 cases, and appendix 17 cases. The age distribution lies between 20 to 50 years, and the highest in 21 to 30 years appendicitis, and 41 to 50 in appendicular perforation. These are my charts. TLC count, it is 6,600 to 14,000. Appendicular perforation, 13,800, 100. CRP 1.7 to 1.7 to 4.8, 2.4 to 30.1. Bilirubin rises to 0.2 to 0.8, 0.07 in 0.75 to 1.45 appendicular perforation. My summary: the study was conducted in the High-Tech Medical College in the Department of General Surgery, includes 62 patients with suspected case of appendicitis. Male frequency of appendicitis than female. Most common symptom is right iliac fossa pain, low-grade fever, tenderness, and rebound tenderness is present of acute appendicitis. Guarding and rigidity is present in case of appendicular perforation. In patients of blood parameters like TLC, CRP, and bilirubin were rise significantly. TLC had maximum significance up to 100%. CRP had up to 100%. Positive predictive value was maximum in TLC, and negative predictive value for maximum for CRP is 100%. These parameters were combined, TLC and CRP and bilirubin had maximum sensitivity up to 94.12%. Bilirubin had the maximum sensitivity up to 100%. TLC and CRP had the maximum positive predictive value up to 100% and negative predictive percent. All the other three parameters were combined together. Specifically, the positive predictive value reaches to the maximum of 100 to 88%, and negative predictive value to 96%. Thank you.
Okay. Do we have time? Hello, organizers. Do we have time?
Yeah.
Hello.
No, ma'am. Time is over.
Hello.
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 Time is over, ma'am.
Yes. Can I ask questions? And I can't see the timer today. Okay. Time is over.
Yes, ma'am.
Hello.
Yes, ma'am. Yes,
Doctor,
time
I
is.
can ask you many questions. Time is there? Okay, right. Dr. Ralph,
Okay, ma'am.
hello. Can you
Hello,
hear me?
ma'am. Yes, ma'am.
Okay. I have couple of questions to you. I didn't understand why did you need to exclude patients with comorbidities, pediatric age group, or pregnancy? Why? Any particular reason? Because it is a done to death topic.
No, ma'am, there is no specific data.
Clinical and
We have chosen.
biological correlation. This is a done.
Hello.
No. Why? Why must you exclude them? I didn't understand the exclusion criteria because it makes no sense. Second, except reducing the study size. Second is that did you compare them with any radiological? Did you carry out any radiological investigation? Because especially whenever you are suspecting a perforated appendix, generally ultrasound is ordered or a CT scan is ordered.
Yes,
So
ma'am.
did you include the data in it or not?
No,
Because see,
we didn't
TSC
include.
and CRT, these are established data in perforated appendix. What is
Yes,
the
ma'am.
new thing that you told me?
No, ma'am.
What is that new thing
We,
that I'm going to learn out of your presentation?
ma'am,
So you are just confirming what is known already,
yes, ma'am.
right?
Yes, ma'am. Ma'am,
What is
but
that you learned out of this? You tell me that.
ma'am,
That
this
you don't
study
need to
can
do
help.
any investigation if you have a positive
Ma'am,
sign.
yes,
How
ma'am.
is it going to help you?
But this study can
See, it is very clear.
the
This is
rural people where there is no ultrasound or CT scan is available. Ma'am.
okay, right. Thank you very much. Can we go on to the next presentation?
Next is Dr. Ganesh, BB.
Hello, good evening, ma'am.
Dr. Ganesh.
Am I audible?
Dr. Ganesh.
Hello.
Yes, sir. Good evening, ma'am.
Dr. Dinesh.
Dr. Dinesh.
Yes, ma'am.
Dr.
Good
Ganesh.
evening. Okay.
Shall I begin?
Hello, Dr.
Hello.
Dinesh.
Yes,
You
ma'am.
are Dr. Ganesh.
Dinesh.
Okay. Okay. Please start.
Yes, ma'am. Good evening,
Okay, I
ma'am.
think you need to amend the name or something.
Doctor.
Okay, you're the third speaker. Second speaker is not available. Hello.
Dr. Ganesh.
Okay, please go ahead. Go ahead.
Yes, ma'am. Good evening. My paper is on a comparative study between laparoscopic versus open appendectomy. This is performed in DY Patil, Pune. Appendectomy is one of the most commonly done. Hello. Appendectomy is one of the most commonly done surgeries by a surgeon. Lawson performed the first planned appendectomy for appendicitis in 1880. Thereafter, immediate surgery for appendicitis was recommended in 1886 for the Reginald Funds. Appendectomy was further popularized by Charles McBurney, who introduced in 1889 a newer operating technique by performing appendectomy with use of lesser invasive muscle splitting incision, and describing in 1894 the McBurney point. At present time, appendectomy is the most common abdominal operation because of its relatively high lifetime risk of men and women for developing appendicitis. The introduction of laparoscopic surgery has dramatically changed the field of surgery. At present, there is no consensus regarding the superiority of laparoscopic approach over the conventional technique. The trend is towards greater utilization of laparoscopic appendectomy, and therefore it becomes imperative to prove scientifically the effectiveness of two methods by comparing them point to point. This became the basis of my study, which was performed in DY Patil, Pune. A total of the methodology, a total of 100 patients are included in the study since July 2019 that got admitted in the Department of General Surgery in DY Patil. All patients were interviewed for detailed clinical history and they were examined. They were then subject to routine blood, urine, and other investigations as per proper protocol. And an abdominal ultrasound was performed in all cases. After clinico-radiological confirmation of diagnosis of acute appendicitis, 50 cases were randomly taken up for laparoscopic appendectomy, and 50 for open appendectomy. Comparison is done on the basis of age group affected the most, complications, duration of hospital stay, pain score, and time taken to resume to daily activities after appendectomy. Inclusion criteria on the basis of patients with pain in abdomen, local tenderness, and leukocytosis. All patients of age 16 years or more of both sexes who suffered an attack of acute appendicitis, and patients who had signs of generalized peritonitis and suspicious mass or appendiceal abscess, and pregnant and patients with previous abdominal surgery were excluded. Result. This is the highest incidence was noted in 20 to 30 years age group, which accounted for about 45% of the patients, and followed by 30 to 40 age group, which was seen in 40%. Complications was the post-operative wound infections and fever were noted more in open appendectomy rather than laparoscopic. Laparoscopic, there were 4% of cases have seen the post-operative complications, while open appendectomy has seen 24%. Duration of hospital stay was approximately 1/3 in laparoscopic appendectomy patients compared to 8 to 10 days in the open appendectomy patients. Laparoscopic appendectomy patients were discharged on POD 3 to 5. And comparing the pain score on the visual and in the visual analog score, laparoscopic appendectomy was has a pain score of only 5 to 7, while the average pain score in open appendectomy was 8 to 9. Time to return to daily activities was patient returned to daily activities earlier in following a laparoscopic appendectomy rather than open appendectomy. It was 4 to 5 days following a laparoscopic procedure rather than 14 to 20 days in an open procedure. Discussion. This is a prospective study of 100 cases of appendicitis. Most commonly affected age group is 20 to 30 years of age. Patients that were operated by laparoscopy, 50 out of 100, 4% of the cases developed post-operative complications, while in post-op cases of open appendectomy, 24% patients developed post-operative complications. Duration of stay in the hospital in the post-operative period was 3 to 5 days in laparoscopic, while it was 8 to 10 days in a post-operative case of open appendectomy. The pain score in the post-operative period was found to be less in laparoscopic compared to the open. Lastly, the time taken to resume to daily activities was found to be less, 4 to 5 days in a case of laparoscopic appendectomy, rather than 14 to 21 days in a case of open appendectomy. Result. Appendicitis is one of the commonest causes of acute abdomen in patients presented to surgical emergency department. Most common age group is being 20 to 30 years of age. Surgery being the treatment of choice. Out of the two modalities available, laparoscopic appendectomy has a better outcome than open appendectomy in terms of patient satisfaction, duration of hospital stay, post-operative complications, and earlier return to daily activities. Although laparoscopic appendectomy has shown to give better results than open appendectomy, in my study, as our center is a teaching institute, open appendectomy was also equally performed. Thank you, ma'am.
Right.
These are my
Okay.
references, ma'am.
Dr. Dinesh,
Yes, ma'am.
I'm in serious disagreement with all your conclusions. My only first thing, how much have you compared the time taken to perform a laparoscopic appendectomy versus open appendectomy?
No, ma'am. In this study, I haven't
Have you
compared.
compared that?
No, ma'am. In this
And
study,
what is the mode of anesthesia? What is the mode of anesthesia administered in both these cases?
ma'am,
In laparoscopic, what kind of anesthesia was administered?
ma'am, in laparoscopic general anesthesia was administered, and
Hello?
yes, ma'am. In laparoscopic general anesthesia was administered,
And in
open case spinal, and in some cases spinal plus epidural was given, ma'am.
Okay. And time taken?
Ma'am, time taken open appendectomy.
By the way, your open surgery. Do you have any average, or you have not considered it at all?
Ma'am, in open surgery, the average is around 1.5 hour to 2
Hello?
hours. Hello? 1 hour 30 minutes, ma'am.
Yeah.
Hello?
First of all, open surgery in these days does not have so much of high complication rates.
Yes,
okay, 24% is too high. Probably you have taken only perforated appendix.
Yes.
for open surgeries. So that is why you have such a high rate of wound infection. Then the comparison does not stand to logic.
Oh, yes, ma'am.
You cannot compare a perforated appendix surgery with a laparoscopic. Your wound infection rates are going to be very high whenever you do a perforated appendix when you open up. Okay?
Yes, ma'am.
So
Yes.
that bias should have been eliminated.
Yes, ma'am.
Right?
Yes, yes, ma'am.
Okay. So that is a very Dr. Omkar Singh?
Dr. Ganesh. Dr. Ganesh. Dr. Ganesh.
Hello, good evening, sir.
Sir, please share your screen.
Yeah, sir. Am I audible, sir?
Yes, yes, loud and clear.
Yes, sir. Good evening, sir. Today's my seminar.
Please share your screen.
Yes, sir. Prospective study on a prophylactic ilioinguinal neurectomy in open inguinal hernia repair.
Dr. Ganesh, please share your screen first.
Yes. Hello, sir.
Yes.
Yeah, got it, sir.
Yeah. Just go to full screen. Slideshow, please.
Yes. Good evening, sir.
Yes, good evening. Start.
My topic is a prospective study on a prophylactic ilioinguinal neurectomy in open inguinal hernia repair. Introduction. Among different types of hernia diagnosed, inguinal hernia accounts for about 80%. Lichtenstein tension-free mesh herniaplasty has emerged as the gold standard for inguinal hernia repair. Chronic groin pain is a major complaint after a successful inguinal repair, and it has been reported in 63% of
फोन आया फोन आया
I'm calling the head office.
cases can be divided in mesh-related replacement or contraction, damaged tendinous tissues, or post-operative causes can lead to nociceptive pain. Non-surgical treatment options includes analgesics, peripheral nerve blocks with local anesthetics, transcutaneous electric nerve stimulation, laser therapy, pulsed radio frequency for chronic post-hernioplasty pain. Surgical options includes selective ilioinguinal, iliohypogastric, and genitofemoral neurolysis or neurectomy. Removal of mesh and revision of repair are common used. Surgeons traditionally prefer to preserve the ilioinguinal nerve during a repair because the nerve injury is often associated with the cutaneous sensory loss and chronic groin pain. Hence, disagreement over the best management option for the neuropathic pain post hernia repair still exists. However, to reduce the incidence of chronic post hernioplasty pain, elective divisions of a ilioinguinal nerve has been recommended. Recently reported aim of the study to evaluate the effect of a prophylactic ilioinguinal neurectomy on the incidence and severity of a chronic groin pain following the Lichtenstein tension-free mesh hernioplasty for inguinal hernia. Method. The present work was conducted in the Department of Surgery at ASICON Medical College, Bangalore from January 2019 to June 21. Inclusion criteria. All uncomplicated unilateral inguinal-scrotal hernia. Exclusion criteria: large inguinal hernia more than 10 cm, complicated hernia surgeries, recurrent inguinal hernia, bilateral inguinal hernia, femoral hernia, associated illness, diabetes mellitus. All patients provided informed consent for the study, and the study was approved the Institutional Ethical Review Board. A total of 60 patients underwent routine pre-operative investigation and preparation for surgery. Total patients were divided into two groups. Group A is number 330. Ilioinguinal nerves were preserved. Group B, ilioinguinal nerve excision was done. The ilioinguinal nerve was identified carefully, protected through the surgery, and extreme care was taken to avoid nerve entrapment during suturing and the mesh replacement in Group A. In Group B, the ilioinguinal nerve was excised laterally to the deep ring. Standard Lichtenstein tension-free mesh hernioplasty was adopted and performed under spinal anesthesia. Patients were regularly followed up and assessment was done for chronic groin pain, hyposthesia, and numbness at a post-operative day 3, 14, after 1 month, and after 3 months after operation. Chronic groin pain was defined as any discomfort or a pain during normal physical activity and included bending forward, squatting, and extending the legs of the operated side to the reasonable degree. Severity of the pain was assessed using visual analog scale, and sensory assessment was done using the standard Sims-Weinstein monofilament test. Statistical analysis. All statistical analysis were performed using SPSS software version 22. Standard student t-test was used for parametric data, and two-sided p-value of less than 0.05 was considered significant. Results. Total number of 60 mesh hernioplasty in this prospective study. In both Group A and B, we lost one patient each to follow-up, and thus only 58 patients completed the study protocol. Mean age of patients in nerve preservation was 40.8 plus or minus 10, and 41 years in the nerve excision group. Majority of the patients presented and were operated within 1 year of onset of hernia. Hernia was more commonly presented on right side, and 18.6% of the patients had a bladder outlet obstruction. All patients underwent Lichtenstein repair for inguinal hernia. In nerve preservation group, 11 patients had a left inguinal hernia, 18 patients presented with swelling, 5 had a blood outlet obstruction, and 18 were smokers. On the other hand, in nerve excision group, 22 patients presented with swelling alone. This is the follow-up. Post-operative pain has significantly decreased in a group B, shown in the slides. Severe pain in a number of 26, and group B is 19. And on post-op day 14 is 10 group and group A, and 5 in group B. These are the hypothesis. Mean numbness score between the groups and in a group A and group B. Discussion. Chronic pain post hernioplasty has emerged as a major clinical problem after an open mesh repair, significantly affecting the quality of life and patients' satisfaction. Even though it can be controlled with analgesics, the rate of chronic pain after inguinal hernia mesh repair is about 51%. Inflammation and fibrosis induced by the mesh, which is in close proximity to the. In addition to this, there could also be an unintentional injury or strangulation of the ilioinguinal nerve during suturing, which can result in the chronic groin pain. Many studies have aimed at assessing the effect of ilioinguinal neurectomy. However, results have not been consistent in our study. Prophylactic excision of ilioinguinal nerve is found to decrease the incidence of a post-surgery chronic groin pain, and it was not associated with the morbidities such as local cutaneous neurosensory disturbance. According to the evidence given by various studies, prophylactic excision of the ilioinguinal nerve during open hernia repair can minimize the morbidities and can also potentially decrease the incidence of chronic groin pain following surgery.
Time is over.
Sir.
Time is over. Hello, time is over.
This can be concluded as prophylactic excision of ilioinguinal neurectomy during Lichtenstein mesh repair decreases the incidence of a chronic groin pain after surgery without additional morbidities. Thus, we recommend that.
You need to stop, doctor.
Yes.
Dr. Ganesh, you already exceeded your time. And
Yeah, ma'am.
how do you locate ilioinguinal nerve?
It will be near the deep inguinal ring, ma'am. It's difficult to make out, ma'am.
You performed a neurectomy. So you should be able to tell me where it is located and how does it look like and how often are you able to do the...
Lateral to the deep inguinal ring, ma'am.
So, so which branch are you going to cut? You said a division of ilioinguinal nerve.
Yeah, ma'am. At the incision site only we'll cut that ilioinguinal nerve.
Why must you preserve it?
Ma'am?
What is the... why must you preserve it actually? Okay, we have no more questions. I cannot give you that much of time. It would be unfair to the other participants. Can we go on to the next?
Yes. Dr. Kala,
Yes, sir. Hello.
Dr. Kala,
Yes, sir. Yes, sir.
please
I'm
share
here,
your screen.
Please stick to your time. Otherwise, you're going to lose marks.
I mean, in order to prevent the chronic groin pain, ma'am.
Hello.
Dr.
Actually,
Ganesh,
the
you have to
group
stop it. You go on to the next slide.
will try to preserve that, ma'am.
Hello.
Yes. Dr. Kala, please start your presentation and stick to your time, please.
Hello.
Good evening, everyone. My topic is a study on the need of upper GA endoscopy as a routine investigation in cholelithiasis patients prior to cholecystectomy. Introduction. It is an immense challenge to discriminate between upper GA symptoms due to gallstones or any other causes. Thorough evaluation is required to ascertain whether gallstones are responsible for the symptoms or it is just an incidental finding. This study focused on the yield of upper GA endoscopy as an investigative modality to find out the associated disorders of the upper gastrointestinal tract in patients with ultrasonogram-proved gallstones presenting with the dyspeptic symptoms. Aims and objectives of the study. To determine the patterns of preoperative upper GA endoscopy findings among patients with gallstone disease confirmed by ultrasonogram, to determine the yield of preoperative upper GA endoscopy as a routine investigative tool in the patients with gallstone disease. Method of the study. A prospective study from January 2019 to June 2020 was held in the Department of General Surgery, ASICMC, and the PGIMS at Bangalore on inpatient and outpatient basis with complaints of the upper GA symptoms in patients with complaints of upper GA symptoms like abdominal discomfort, dyspepsia, nausea, belching, heartburn, food intolerance, flatulence, vomiting, and loss of appetite. These patients were subjected to undergo ultrasound abdomen at first. A total of 100 patients with positive ultrasonography findings of cholelithiasis was included in the study, and they were further evaluated by upper GA endoscopy. The personal information and detailed description of the symptoms at the time of presentation were documented. The clinical examination findings, the ultrasonographic findings, and the endoscopic findings were tabulated and analyzed. Inclusion criteria. The patients with ultrasonogram confirmed cholelithiasis, patients willing to give informed written consent. Exclusion criteria, patients who were not willing to participate in the study, who are unfit or unstable for the study, surgery, acute cholecystitis with cholelithiasis, patient who has history of previous operation, patients with history of APD for more than 6 weeks, patients who were already a non-case of GERD on treatment or pancreatitis on treatment, inflammatory bowel disease, chronic alcoholics, radiologically proven malignancy, and USG proven GB polyps of size more than 1.5 centimeters. The study design, it was a longitudinal study. The statistical analysis was done as SPSS version 22, IBM Chicago. Results. Out of the 100 subjects evaluated during the period, 58 were females and 42 were males. The most common age group were affected between 31 to 50 years. That were 65% of the total study population, and followed by less than 30 years of age in 18% of the population, and 50 years, more than 50 years in 17% of the population. In all the age groups, females were affected more common than the males, except in the age group of 50, where males were more affected than in the females. This is a comparative study bar chart. In this study, The various symptoms that patients presented with were noted. The most common presenting symptoms were found to be heartburn in 69%, followed by dyspepsia in 58%, belching in 56%, nausea and vomiting in 53%. Out of 100 patients, 44 patients were presented with biliary colic, which was the least common symptom, even though it was expected in patients with gallstone disease, suggesting that the upper GI symptoms of the patients were due to other pathologies and not due to gallstone disease, which could probably be just an incidental sonography finding. These are the comparative study of comparative bar diagram of the presenting symptoms of the patient, in which it is showing that most of the patients presented with heartburn, followed by dyspepsia, followed by colic, followed by nausea and vomiting, followed by colic in the last blue diagram. To learn the pattern of presenting symptoms and its complexes in patients with cholelithiasis and probably associated other upper GI pathologies, the symptom complexes were plotted on bar diagram and its frequencies also were noted. In the study, the most common combination of the symptoms was heartburn, belching, dyspepsia, and nausea and vomiting. For total 14 patients presented with all these 5 symptoms. It is to be duly noted that the biliary colic and dyspepsia, which is the usual symptom complex in gallstone disease, was found in only 7% of the cases in the study. This is a comparative study of the presenting symptoms, combination of the symptoms. All these 100 subjects who had sonographic evidence of gallstones underwent upper GI endoscopy after due consent. Out of 100 subjects who underwent upper GI endoscopy, 44% of the cases were found to have normal mucosal study. Remaining 56% of the subjects had positive endoscopic findings. The bar diagram was constructed to study the frequency of different pathologies detected in the endoscopy among the subjects. The most common endoscopic finding was found to be GERD. 31 patients had this disease, followed by gastroduodenal ulcer. 98 patients had gastric or duodenal ulcer. And gastric duodenitis in 11 patients, and other endoscopic findings were hiatus hernia in 5 patients, and gastric polyposis in 3 patients, and esophagitis in 2 patients. One subject had one worm infestation on the endoscopic findings. These are the positive endoscopic findings study represented in a bar diagram. Discussion. In this present study, the age of the patients ranged from 70 to 72 years, with majority of the patients falling in the age group of 30 to 50 years. The mean age of the patients was found to be 41.1. This agrees with the studies conducted by Kedar et al. And Kala et al., in which the mean age was 39.6 years and 38.6 years respectively. Out of the 100 subjects studied, 58 were females and 42 were males. This verifies the fact that gallbladder disease is more prevalent in females. However, the percentage of females being affected was slightly lower when compared to the studies conducted by Gadre et al., where females were 66.6% and Sabita et al., females were 67.5%. Out of the 100 patients, 44 patients presented with typical biliary colic pain. In the studies undertaken by Mosafer et al., 50.6% of the subjects experienced typical pattern of the gallstone pain, that is biliary colic pain. And the most common presenting symptoms in the study was heartburn, 69%, followed by dyspepsia, 58%, and belching in 56%, and nausea and vomiting in 53%. Karmacharya et al. Study showed nausea was the most common symptom, followed by biliary colic and heartburn. Kedar et al. Observed pain abdomen in all the subjects, followed by nausea in 71.25% of the patients. And the patients usually presented with multiple symptoms rather than a single complaint. In this study, 14 of the patients, as I saw told earlier, presented with a combination of heartburn, belching, dyspepsia, nausea, and vomiting. In a similar study conducted by Sabita et al., the most common symptom was found to be
Time is up. Dr. Kala, time is up. Please conclude.
Go to the conclusion slide. Dr. Kala, just go to the conclusion slide.
Screen is not moving.
Dr. Kala, just go to the conclusion slide. Okay. Hello?
Hello, ma'am.
Yeah. Conclude your slide.
So this is what my study conclude, like whoever has diagnosed to have cholelithiasis present with the symptoms apart from the biliary colic,
Okay.
evaluation has to be done, and for the other upper GI pathology associated, and if we are able to get an UGI endoscopy routinely for a patient's planned for cholecystectomy preoperatively, then we can get that other underlying causes also to be cured.
Two questions. Just very quick questions. Okay. I did not understand why did you subject.
Hello, ma'am. Hello.
I did not understand why did you subject 44% of your patients to an invasive procedure like upper GI endoscopy without giving them a trial of PPIs or anything else. You have subjected them to 44% of the patients where you had normal anatomy. Okay. Second answer, please kindly answer me that. And second is this: wherever did you find upper GI diseases, you went on about symptoms, whereas your study was about findings of upper GI endoscopy along with cholelithiasis. How do you decide on upper GI endoscopy that the symptomatology that the patient is suffering from is because of gallstones?
Gallstones can present with a wide range of.
We know what all gallstones can present with. I'm asking you, what correlation are you going to see on upper GI endoscopy with cholelithiasis to say that it is because of this, because of cholelithiasis, this has happened?
Ma'am, so like
correlation.
Hello, ma'am. What I'm trying to say, what we are studying in this, if
remember it is an invasive procedure. Yes.
Ma'am, when we are finding something associated with, in addition to the cholelithiasis, if we are finding something in addition to that in the upper GI endoscopy studies, we have to first treat that.
So did your patients undergo cholecystectomy?
Yes, ma'am.
In whom you had a duodenal ulcer, any other upper GI, did you subject them to cholecystectomy?
Yes, ma'am. Like all patients were with the cholelithiasis symptoms, where cholelithiasis was there, we were planning them to be taken to OT for cholecystectomy. But before taking for cholecystectomy in a gallstone disease, if the patient is subjected to have endoscopy, upper GI endoscopy, and the patient is found to have all these diseases, I have depicted.
Anyway, the time is up. You were not answered my question. What I asked is you did not find any you were unable to provide me any correlation between upper GI endoscopy and whether the symptomatology was because of cholelithiasis. There is no findings actually correlating them. It is like doing a evaluation for peripheral arterial disease along with cholelithiasis. It is as good as that. Looking for appendicitis in a cholelithiasis patient.
No, ma'am. My study was not like that, ma'am. Like they are found to be the independent findings.
Your findings did not suggest that. You have nowhere told me that what upper GI endoscopy findings can be correlated to the cholelithiasis, like a biliary reflux.
Symptom.
Where are the biliary reflux? Where was the heart? Where was the CBD stone? Is there any duodenitis associated with it? All those signs are not mentioned in your study. In your upper GI endoscopy has not brought out those findings.
Ma'am, cholelithiasis causing any upper GI upper GI diseases was not the study, ma'am. If that symptoms are like overlapping,
subjecting someone to upper GI endoscopy because they had cholelithiasis, this is what you have done.
Yes, ma'am. That final output of the study is like if the patient is having atypical symptoms which are not typical biliary colic, then the patient patient may be having another upper GI disease like
symptoms are associated with cholelithiasis. Accepted findings or not accepted?
Ma'am, I didn't get you, ma'am.
Dyspeptic symptoms can arise because of cholelithiasis.
The symptoms like cholelithiasis can present with the varying symptoms, like it can resemble the symptoms of other reflex disease also, ma'am.
Thank you. Next presenter.
Hello.
Hello, am I audible?
Yes, audible. Next,
Yes.
retrospective. Dr. Nayana?
Yes, ma'am.
Yeah, please start.
Yes, ma'am. Am I audible, ma'am?
Yeah, please start.
Yes.
You're losing
Good
time.
evening, everyone. My study is a retrospective study of outcomes of patients with necrotizing fasciitis in elderly patients at JSS Hospital, Mysore. The aims of study, it includes to study the outcomes of necrotizing fasciitis in elderly patients, that is age group more than 60 years, using the following parameters, that is duration of hospital stay, number of patients requiring redebridement procedures, type of closure procedures, that is to cover the wound, the number of deaths in patients with necrotizing fasciitis. My methodology includes I studied over 270 patients diagnosed with only lower limb necrotizing fasciitis at JSS Hospital Doctor, starting from the period of January 2019 onwards, which were randomly selected, out of which I found that 168 patients were above the age of 60 years and 102 patients were below the age of 60 years. So regarding these patients, I studied the data of comorbidities, duration of hospital stay, number of patients requiring redebridement, the type of closure procedures, and the number of deaths. My results included 103 patients out of the 168 patients were aged who were aged above 60 years had type 2 diabetes mellitus, and 72 patients had hypertension, which can be overlapping. Few patients can be having hypertension and diabetes together, but the separate statistics showed this. 146 patients out of 168 patients were male and 22 of them were females. Debridement procedure was done in 237 of the patients, that is 87.4% of the patients, and redebridement was required in 94 of the patients. Amongst the patients who underwent redebridement, 68, that is 72.34% were elderly, and 26 patients were below 60 years of age. Amongst those, 60 were diabetic and the rest of them were non-diabetic patients. Average duration of hospital stay in elderly was found to be 22 days, compared to the average duration of hospital stay for patients below 60 years was 16. Not much significance was found there. Patients were followed up to check the wound healing, which was found by means of which was done by means of regular dressings, split skin grafting, amputation procedures, and secondary suturing procedures. 165 patients underwent surgical procedures to hasten the process and not just regular dressings. Amongst them, 60% were aged above 60 years. 65 patients amongst the 99 who underwent surgical procedure were diabetic, and rest 34 were non-diabetic. Patients undergoing surgical procedure to close the wounds after debridement. This is the graph which is showing 99 of them were aged above 60 and 66 were aged below 60. 61.21% of patients underwent SSG, out of which 39% were elderly and the rest were young individuals. 38% of patients amongst those who underwent SSG were diabetic and the rest were non-diabetic. 21.21% of the patients underwent amputation, out of which 26 were elderly and the rest were young patients. 57% of the patients were diabetic and the rest of them were non-diabetic. 29 patients, that is 17% of the patients, underwent secondary suturing method. Then 14% of the patients succumbed to death, out of which 66% of the patients were elderly and 13 were amongst the young individuals. Amongst 39 deaths, 23 were diabetic patients and 16 were non-diabetic patients. Conclusion: necrotizing fasciitis, being a serious condition, occurs in higher rates in elderly individuals than young individuals, and also higher in diabetic individuals compared to non-diabetic individuals. The outcomes based on duration of hospital stay, requirement of redebridement, deaths were compared between the elderly and the young patients, and was found to be more in elderly individual, which may be contributed to the weak immune system and delayed diagnosis in elderly individuals. In my study, SSG was found to be the most popularly used surgical method to cover the large wound areas in necrotizing fasciitis, and amputation was performed more in the elderly group rather than the young groups. But it did not show significant difference in the diabetic and the non-diabetic group of patients. Thank you.
Right. Dr. Nayana?
Yes, ma'am.
Yeah. My question to you is,
Yes, ma'am.
number of days, do you have any chart which says, which tells you that, hello, can you hear me?
Yes, yes, ma'am. Yes, ma'am.
Okay. So number of days taken taken for healing of wound if you used SSG and where you did not use SSG.
Ma'am, actually various methods were used, not just SSG.
Mm-hmm.
But in my study, the number of days was not included, ma'am. I just calculated the patients who underwent SSG or amputation or just did regular dressings and healed with that.
Okay. So you have not checked on the. Okay. Second
No,
thing.
ma'am.
Okay. Second thing, any did you find any vascular diseases in them?
No, ma'am. These were purely necrotizing fasciitis diseases, ma'am. No other vascular disease or venous disorders or any other problems were included in these patients, ma'am.
In these patients.
Yes.
But you'll be surprised to learn quite a lot of them turn up with a vascular disease, almost 15 to 20%. Generally,
it could be, ma'am. Actually, not all the patients were succumbed to Doppler study, actually. But symptomatically, if we ask a retrospective history, such individuals did not.
That data was not available to you. No,
Sorry, ma'am?
that data was not available to you. The pulses status or anything.
Pulses status was available, ma'am.
Pulses
But
status.
yes, clinical pulses status was available, but Doppler study was not done for all the patients, ma'am.
Right. Thank you. Thank you.
Yes, thank you, ma'am.
Next is Dr. Omkar. Dr. Omkar.
Dr. Omkar.
डॉक्टर ओमकार ओमकार नरेश में उसको भेजना यार अभी तो आया था ही
हेलो डॉक्टर ओमकार
डॉक्टर परनीति वेट वो किसी दूसरे चीज पे चले गए सेशन में अभी जस्ट लॉगिन कर रहे हैं
Hello.
Hello. Yes,
Hello.
Dr.
Sorry, ma'am. Ma'am, I tried to share my screen and it just crashed. I'm sorry. One second, ma'am. One second. I'll try.
डॉक्टर ओमकार डॉक्टर ओमकार एनी प्रॉब्लम यार यहाँ पे स्क्रीन शेयर कर रहे हैं उनके पास
Are you able to connect with him?
मैम वो पेज से लॉग आउट हो गए.
Okay, I believe his screen's crashed or something. So let's just give him 2 more minutes and let's see.
Okay.
Hello, is he able to log in?
नो मैम.
No.
मैम को कॉल कर रहा हूँ मैं.
Okay, so should we close the session?
Wait, ma'am. And just try to call him.
Right. Thank you.